by Henry Gray. Anatomy of the human body. The urinary bladder. Vesica urinaria, bladder. The urinary bladder is a muscular membranous sac which acts as a reservoir for the urine, and as its size, position and relations vary according to the amount of fluid it contains, it is necessary to study it as it appears A. when empty, and B. when distended. In both conditions, the position of the bladder varies with the condition of the rectum, being pushed upward and forward when the rectum is distended. The empty bladder. When hardened in situ, the empty bladder has the form of a flattened tetrahedron with its vertex tilted forward. It presents a fundus, a vertex, a superior and an inferior surface. The fundus is triangular in shape and is directed downward and backward toward the rectum, from which it is separated by the rectovesical fascia, the vesiculae seminales, and the terminal portions of the ductus deferentes. The vertex is directed forward toward the upper part of the symphysis pubis, and from it the middle umbilical ligament is continued upward on the back of the anterior abdominal wall to the umbilicus. The peritoneum is carried by it from the vertex of the bladder on to the abdominal wall to form the middle umbilical fold. The superior surface is triangular, bounded on either side by a lateral border which separates it from the inferior surface, and behind by a posterior border, represented by a line joining the two ureters, which intervenes between it and the fundus. The lateral borders extend from the ureters to the vertex, and from them the peritoneum is carried to the walls of the pelvis. On either side of the bladder, the peritoneum shows a depression, named the paravesical fossa. The superior surface is directed upward, is covered by peritoneum, and is in relation with the sigmoid colon and some of the coils of the small intestine. When the bladder is empty and firmly contracted, this surface is convex and the lateral and posterior borders are rounded, whereas if the bladder be relaxed it is concave, and the interior of the viscus, as seen in a median sagittal section, presents the appearance of a V-shaped slit with a shorter posterior and a longer anterior limb, the apex of the V corresponding with the internal orifice of the urethra. The inferior surface is directed downward and is uncovered by peritoneum. It may be divided into a posterior or prostatic area and two inferolateral surfaces. The prostatic area is somewhat triangular. It rests upon and is in direct continuity with the base of the prostate, and from it the urethra emerges. The inferolateral portions of the inferior surface are directed downward and lateralward. In front, they are separated from the symphysis pubis by a mass of fatty tissue, which is named the retropubic pad. Behind, they are in contact with the fascia, which covers the levatores anni and obturatores interni. When the bladder is empty, it is placed entirely within the pelvis, below the level of the obliterated hypogastric arteries, and below the level of those portions of the ductus deferentes which are in contact with the lateral wall of the pelvis. After they cross the ureters, the ductus deferentes come into contact with the fundus of the bladder. As the viscus fills, its fundus, being more or less fixed, is only slightly depressed, while its superior surface gradually rises into the abdominal cavity, carrying with it its peritoneal covering, and at the same time rounding off the posterior and lateral borders. The distended bladder. When the bladder is moderately full, it contains about 0.5 litres and assumes an oval form. The long diameter of the oval measures about 12 centimetres and is directed upward and forward. In this condition it presents a postero-superior, an antero-inferior, and two lateral surfaces, a fundus and a summit. The postero-superior surface is directed upward and backward and is covered by peritoneum. Behind, it is separated from the rectum by the rectovesical excavation, while its anterior part is in contact with the coils of the small intestine. The antero-inferior surface is devoid of peritoneum and rests below, against the pubic bones, above which it is in contact with the back of the anterior abdominal wall. The lower parts of the lateral surfaces are destitute of peritoneum and are in contact with the lateral walls of the pelvis. The line of peritoneal reflection from the lateral surface is raised to the level of the obliterated hypogastric artery. The fundus undergoes little alteration in position, being only slightly lowered. It exhibits, however, a narrow triangular area, which is separated from the rectum merely by the rectovesical fascia. This area is bounded below by the prostate, above by the rectovesical fold of peritoneum, and laterally by the ductus deferentes. The ductus deferentes frequently come into contact with each other above the prostate, and under such circumstances the lower part of the triangular area is obliterated. The line of reflection of the peritoneum from the rectum to the bladder appears to undergo little or no change when the latter is distended. It is situated about 10 centimeters from the anus. The summit is directed upward and forward above the point of attachment of the middle umbilical ligament, and hence the peritoneum which follows the ligament forms a pouch of varying depth between the summit of the bladder and the anterior abdominal wall. The bladder in the child. In the newborn child, the internal urethral orifice is at the level of the upper border of the symphysis pubis. The bladder, therefore, lies relatively at a much higher level in the infant than in the adult. Its anterior surface is in contact with about the lower 2/3 of that part of the abdominal wall which lies between the symphysis pubis and the umbilicus. Symington. Its fundus is clothed with peritoneum as far as the level of the internal orifice of the urethra. Although the bladder of the infant is usually described as an abdominal organ, Symington has pointed out that only about 1/2 of it lies above the plane of the superior aperture of the pelvis. Dis maintains that the internal urethral orifice sinks rapidly during the first years, and then more slowly until the 9th year, after which it remains stationary until puberty, when it again slowly descends and reaches its adult position. The female bladder. In the female, the bladder is in relation behind with the uterus and the upper part of the vagina. It is separated from the anterior surface of the body of the uterus by the vesicuterine excavation, but below the level of this excavation it is connected to the front of the cervix uteri, and the upper part of the anterior wall of the vagina by areolar tissue. When the bladder is empty, the uterus rests upon its superior surface. The female bladder is said by some to be more capacious than that of the male, but probably the opposite is the case. Ligaments. The bladder is connected to the pelvic wall by the fascia endopelvina. In front, this fascial attachment is strengthened by a few muscular fibres, the pubovesicales, which extend from the back of the pubic bones to the front of the bladder. Behind, other muscular fibres run from the fundus of the bladder to the sides of the rectum in the sacrogenital folds and constitute the rectovesicales. The vertex of the bladder is joined to the umbilicus by the remains of the urachus, which forms the middle umbilical ligament, a fibromuscular cord, broad at its attachment to the bladder, but narrowing as it ascends. From the superior surface of the bladder, the peritoneum is carried off in a series of folds, which are sometimes termed the false ligaments of the bladder. Anteriorly, there are 3 folds: the middle umbilical fold on the middle umbilical ligament, and 2 lateral umbilical folds on the obliterated hypogastric arteries. The reflections of the peritoneum onto the side walls of the pelvis form the lateral false ligaments, while the sacrogenital folds constitute posterior false ligaments. Interior of the bladder. The mucous membrane lining the bladder is, over the greater part of the viscus, loosely attached to the muscular coat, and appears wrinkled or folded when the bladder is contracted. In the distended condition of the bladder, the folds are effaced. Over a small triangular area, termed the trigonum vesicae, immediately above and behind the internal orifice of the urethra, the mucous membrane is firmly bound to the muscular coat and is always smooth. The anterior angle of the trigonum vesicae is formed by the internal orifice of the urethra, its posterolateral angles by the orifices of the ureters. Stretching behind the latter openings is a slightly curved ridge, the torus uretericus, forming the base of the trigon, and produced by an underlying bundle of non-striped muscular fibres. The lateral parts of this ridge extend beyond the openings of the ureters and are named the plici ureterici. They are produced by the terminal portions of the ureters as they traverse obliquely the bladder wall. When the bladder is illuminated, the torus uretericus appears as a pale band and forms an important guide during the operation of introducing a catheter into the ureter. The orifices of the ureters are placed at the posterolateral angles of the trigonum vesicae and are usually slit-like in form. In the contracted bladder they are about 2.5 cm apart and about the same distance from the internal urethral orifice. In the distended viscus, these measurements may be increased to about 5 cm. The internal urethral orifice is placed at the apex of the trigonum vesicae, in the most dependent part of the bladder, and is usually somewhat crescentic in form. The mucous membrane immediately behind it presents a slight elevation, the uvula vesicae, caused by the middle lobe of the prostate. Structure. The bladder is composed of the four coats, serous, muscular, submucous and mucous coats. The serous coat, tunica serosa, is a partial one and is derived from the peritoneum. It invests the superior surface and the upper parts of the lateral surfaces, and is reflected from these onto the abdominal and pelvic walls. The muscular coat, tunica muscularis, consists of 3 layers of unstriped muscular fibres, an external layer, composed of fibres having for the most part a longitudinal arrangement, a middle layer, in which the fibres are arranged more or less in a circular manner, and an internal layer, in which the fibres have a general longitudinal arrangement. The fibres of the external layer arise from the posterior surface of the body of the pubis in both sexes, musculi pubovesicalis, and in the male from the adjacent part of the prostate and its capsule. They pass, in a more or less longitudinal manner, up the inferior surface of the bladder, over its vertex, and then descend along its fundus to become attached to the prostate in the male and to the front of the vagina in the female. At the sides of the bladder, the fibres are arranged obliquely and intersect one another. This layer has been named the detrusor urinae muscle. The fibres of the middle circular layer are very thinly and irregularly scattered on the body of the organ, and, although to some extent placed transversely to the long axis of the bladder, are for the most part arranged obliquely. Toward the lower part of the bladder, around the internal urethral orifice, they are disposed in a thick circular layer, forming the sphincter vesicae, which is continuous with the muscular fibres of the prostate. The internal longitudinal layer is thin, and its fasciculae have a reticular arrangement, but with a tendency to assume for the most part a longitudinal direction. 2 bands of oblique fibres, originating behind the orifices of the ureters, converge to the back part of the prostate, and are inserted by means of a fibrous process into the middle lobe of that organ. They are the muscles of the ureters. Described by Sir C. Bell, who supposed that during the contraction of the bladder they serve to retain the oblique direction of the ureters, and so prevent the reflux of the urine into them. The submucous coat, tela submucosa, consists of a layer of areolar tissue, connecting together the muscular and mucous coats, and intimately united to the latter. The mucous coat, tunica mucosa, is thin, smooth, and of a pale rose colour. It is continuous above through the ureters with the lining membrane of the renal tubules, and below with that of the urethra. The loose texture of the submucous layer allows the mucous coat to be thrown into folds or rugae when the bladder is empty. Over the trigonum vesicae, the mucous membrane is closely attached to the muscular coat and is not thrown into folds, but is smooth and flat. The epithelium covering it is of the transitional variety, consisting of a superficial layer of polyhedral flattened cells, each with 1, 2, or 3 nuclei. Beneath these is a stratum of large club-shaped cells, with their narrow extremities directed downward and wedged in between smaller spindle-shaped cells containing oval nuclei. The epithelium varies according as the bladder is distended or contracted. In the former condition, the superficial cells are flattened and those of the other layers are shortened. In the latter, they present the appearance described above. There are no true glands in the mucous membrane of the bladder, though certain mucous follicles which exist, especially near the neck of the bladder, have been regarded as such. Vessels and nerves. The arteries supplying the bladder are the superior, middle and inferior vesicle, derived from the anterior trunk of the hypogastric. The obturator and inferior gluteal arteries also supply small visceral branches to the bladder, and in the female, additional branches are derived from the uterine and vaginal arteries. The veins form a complicated plexus on the inferior surface and fundus near the prostate, and end in the hypogastric veins. The lymphatics are described in Part 3 of Gray's Anatomy, Section 49. The nerves of the bladder are 1. Fine medullated fibres from the 3rd and 4th sacral nerves, and 2. Non-medullated fibres from the hypogastric plexus. They are connected with ganglia in the outer and submucous coats, and are finally distributed, all as non-medullated fibres, to the muscular layer and epithelial lining of the viscus. Abnormalities. A defect of development in which the bladder is implicated is known under the name of extraversion of the bladder. In this condition, the lower part of the abdominal wall and the anterior wall of the bladder are wanting, so that the fundus of the bladder presents on the abdominal surface and is pushed forward by the pressure of the viscera within the abdomen, forming a red vascular tumour on which the openings of the ureters are visible. The penis, except the glands, is rudimentary and is cleft on its dorsal surface, exposing the floor of the urethra, a condition known as epispadias. The pelvic bones are also arrested in development.
The male urethra, urethra virilis. The male urethra extends from the internal urethral orifice in the urinary bladder to the external urethral orifice at the end of the penis. It presents a double curve in the ordinary relaxed state of the penis. Its length varies from 17.5 to 20 centimeters, and it is divided into 3 portions: the prostatic, membranous, and cavernous, the structure and relations of which are essentially different. Except during the passage of the urine or semen, the greater part of the urethral canal is a mere transverse cleft or slit, with its upper and under surfaces in contact. At the external orifice, the slit is vertical. In the membranous portion, irregular or stellate, and in the prostatic portion, somewhat arched. The prostatic portion, pars prostatica, the widest and most dilatable part of the canal, is about 3 centimeters long. It runs almost vertically through the prostate from its base to its apex, lying nearer its anterior than its posterior surface. The form of the canal is spindle-shaped, being wider in the middle than at either extremity, and narrowest below, where it joins the membranous portion. A transverse section of the canal as it lies in the prostate is horseshoe-shaped, with the convexity directed forward. Upon the posterior wall or floor is a narrow longitudinal ridge, the urethral crest, veromontanum, formed by an elevation of the mucous membrane and its subjacent tissue. It is from 15 to 17 millimeters in length and about 3 millimeters in height, and contains, according to Cobelt, muscular and erectile tissue. When distended, it may serve to prevent the passage of the semen backward into the bladder. On either side of the crest is a slightly depressed fossa, the prostatic sinus, the floor of which is perforated by numerous apertures, the orifices of the prostatic ducts from the lateral lobes of the prostate. The ducts of the middle lobe open behind the crest. At the forepart of the urethral crest, below its summit, is a median elevation, the colliculus seminalis, upon or within the margins of which are the orifices of the prostatic utricle and the slit-like openings of the ejaculatory ducts. The prostatic utricle, sinus pocularis, forms a cul-de-sac about 6 millimeters long, which runs upward and backward in the substance of the prostate, behind the middle lobe. Its walls are composed of fibrous tissue, muscular fibers, and mucous membrane, and numerous small glands open on its inner surface. It was called by Weber the uterus masculinus, from its being developed from the united lower ends of the atrophied Mullerian ducts, and therefore homologous with the uterus and vagina in the female. The membranous portion, pars membranacea, is the shortest, least dilatable, and, with the exception of the external orifice, the narrowest part of the canal. It extends downward and forward, with a slight anterior concavity, between the apex of the prostate and the bulb of the urethra, perforating the urogenital diaphragm about 2.5 centimeters below and behind the pubic symphysis. The hinder part of the urethral bulb lies in opposition with the inferior fascia of the urogenital diaphragm, but its upper portion diverges somewhat from this fascia. The anterior wall of the membranous urethra is thus prolonged for a short distance in front of the urogenital diaphragm. It measures about 2 centimeters in length, while the posterior wall, which is between the two fasciae of the diaphragm, is only 1.25 centimeters long. The membranous portion of the urethra is completely surrounded by the fibers of the sphincter urethrae membranaceae. In front of it, the deep dorsal vein of the penis enters the pelvis between the transverse ligament of the pelvis and the arcuate pubic ligament. On either side, near its termination, are the bulbal urethral glands. The cavernous portion, pars cavernosa, penile or spongy portion, is the longest part of the urethra, and is contained in the corpus cavernosum urethra. It is about 15 centimeters long, and extends from the termination of the membranous portion to the external urethral orifice. Commencing below the inferior fascia of the urogenital diaphragm, it passes forward and upward to the front of the symphysis pubis, and then, in the flaccid condition of the penis, it bends downward and forward. It is narrow, and of uniform size in the body of the penis, measuring about 6 millimeters in diameter. It is dilated behind, within the bulb, and again anteriorly within the glans penis, where it forms the fossa navicularis urethra. The external urethral orifice, orificium urethrae, externum, meatus urinarius, is the most contracted part of the urethra. It is a vertical slit about 6 millimeters long, bounded on either side by two small labia. The lining membrane of the urethra, especially on the floor of the cavernous portion, presents the orifices of numerous mucous glands and follicles situated in the submucous tissue, and named the urethral glands, litrae. Besides these are a number of small pit-like recesses, or lacunae, of varying sizes. Their orifices are directed forward, so that they may easily intercept the point of a catheter in its passage along the canal. One of these lacunae, larger than the rest, is situated on the upper surface of the fossus navicularis. It is called the lacuna magna, The bulbal urethral glands open into the cavernous portion about 2.5 centimeters in front of the inferior fascia of the urogenital diaphragm. Structure. The urethra is composed of mucous membrane supported by a submucous tissue, which connects it with the various structures through which it passes. The mucous coat forms part of the genitourinary mucous membrane. It is continuous with the mucous membrane of the bladder, ureters, and kidneys. Externally, with the integument covering the glans penis, and is prolonged into the ducts of the glands which open into the urethra, viz., the bulbal urethral glands and the prostate, and into the ductus deferentes and vesiculae seminales, through the ejaculatory ducts. In the cavernous and membranous portions, the mucous membrane is arranged in longitudinal folds when the tube is empty. Small papillae are found upon it, near the external urethral orifice. Its epithelial lining is of the columnar variety, except near the external orifice, where it is squamous and stratified. The submucous tissue consists of a vascular erectile layer. Outside this is a layer of unstriped muscular fibers, arranged in a circular direction, which separates the mucous membrane and submucous tissue from the tissue of the corpus cavernosum urethrae. Congenital defects of the urethra occur occasionally. The one most frequently met with is where there is a cleft on the floor of the urethra owing to an arrest of union in the middle line. This is known as hypospadias, and the cleft may vary in extent. The simplest and by far the most common form is where the deficiency is confined to the glans penis. The urethra ends at the point where the extremity of the prepuce joins the body of the penis in a small valve-like opening. The prepuce is also cleft on its undersurface and forms a sort of hood over the glans. There is a depression on the glans in the position of the normal meatus. This condition produces no disability and requires no treatment. In more severe cases, the cavernous portion of the urethra is cleft throughout its entire length, and the opening of the urethra is at the point of junction of the penis and scrotum. The undersurface of the penis, in the middle line, presents a furrow lined by a moist mucous membrane, on either side of which is often more or less dense fibrous tissue stretching from the glans to the opening of the urethra, which prevents complete erection taking place. Great discomfort is induced during micturition, and sexual connection is impossible. The condition may be remedied by a series of plastic operations. The worst form of this condition is where the urethra is deficient as far back as the perineum, and the scrotum is cleft. The penis is small and bound down between the two halves of the scrotum, so as to resemble a hypertrophied clitoris. The testes are often retained. The condition of parts, therefore, very much resembles the external organs of generation of the female, and many children the victims of this malformation have been brought up as girls. The halves of the scrotum deficient of testes resemble the labia. The cleft between them looks like the orifice of the vagina, and the diminutive penis is taken for an enlarged clitoris. There is no remedy for this condition. A much more uncommon form of malformation is where there is an apparent deficiency of the upper wall of the urethra. This is named epispadias. The deficiency may vary in extent. When it is complete, the condition is associated with extraversion of the bladder. In less extensive cases, where there is no extraversion, there is an infundibuliform opening into the bladder. The penis is usually dwarfed and turned upward, so that the glans lies over the opening. Congenital stricture is also occasionally met with, and in such cases multiple strictures may be present throughout the whole length of the cavernous portion. The female urethra. Urethra muliebris. The female urethra is a narrow membranous canal about 4 centimeters long, extending from the internal to the external urethral orifice. It is placed behind the symphysis pubis, embedded in the anterior wall of the vagina, and its direction is obliquely downward and forward. It is slightly curved, with the concavity directed forward. Its diameter, when undilated, is about 6 millimeters. It perforates the fascia of the urogenital diaphragm, and its external orifice is situated directly in front of the vaginal opening, and about 2.5 centimeters behind the glans clitoridis. The lining membrane is thrown into longitudinal folds, one of which, placed along the floor of the canal, is termed the urethral crust. Many small urethral glands open into the urethra. Structure. The urethra consists of 3 coats: muscular, erectile, and mucous. The muscular coat is continuous with that of the bladder. It extends the whole length of the tube and consists of circular fibers. In addition to this, between the superior and inferior fascia of the urogenital diaphragm, the female urethra is surrounded by the sphincter urethrae membranaceae, as in the male, a thin layer of spongy erectile tissue containing a plexus of large veins intermixed with bundles of unstriped muscular fibers lies immediately beneath the mucous coat. The mucous coat is pale. It is continuous externally with that of the vulva, and internally with that of the bladder. It is lined by stratified squamous epithelium, which becomes transitional near the bladder. Its external orifice is surrounded by a few mucous follicles.
The male genital organs. Organa genitalia virilia. The male genitals include the testes, the ductus deferens, the vesiculae seminalis, the ejaculatory ducts, and the penis, together with the following accessory structures, namely the prostate and the bulbourethral glands. The testes and their coverings. The testes are 2 glandular organs which secrete the semen. They are suspended in the scrotum by the spermatic cords. At an early period of fetal life, the testes are contained in the abdominal cavity, behind the peritoneum. Before birth, they descend to the inguinal canal, along which they pass with the spermatic cord, and, emerging at the subcutaneous inguinal ring, they descend into the scrotum, becoming invested in their course by coverings derived from the serous, muscular, and fibrous layers of the abdominal parietes, as well as by the scrotum. The coverings of the testes are the skin, cremaster, scrotum, dartos tunic, infundibuliform fascia, intercrural fascia, tunica vaginalis. The scrotum is a cutaneous pouch which contains the testes and parts of the spermatic cords. It is divided on its surface into 2 lateral portions by a ridge or raphe, which is continued forward to the undersurface of the penis and backward along the middle line of the perineum to the anus. Of these 2 lateral portions, the left hangs lower than the right, to correspond with the greater length of the left spermatic cord. Its external aspect varies under different circumstances. Thus, under the influence of warmth, and in old and debilitated persons, it becomes elongated and flaccid. But under the influence of cold, and in the young and robust, it is short, corrugated, and closely applied to the testes. The scrotum consists of 2 layers, the integument and the dartos tunic. The integument is very thin, of a brownish color, and generally thrown into folds or rugae. It is provided with sebaceous follicles, the secretion of which has a peculiar odor, and is beset with thinly scattered crisp hairs, the roots of which are seen through the skin. The dartos tunic, tunica dartos, is a thin layer of non-striped muscular fibers, continuous around the base of the scrotum, with the 2 layers of the superficial fascia of the groin and the perineum. It sends inward a septum, which divides the scrotal pouch into 2 cavities for the testes, and extends between the raphe and the undersurface of the penis as far as its root. The dartos tunic is closely united to the skin externally, but connected with the sub-adjacent parts by delicate areolar tissue, upon which it glides with the greatest facility. The intercrural fascia, intercolumnar or external spermatic fascia, is a thin membrane, prolonged downward around the surface of the cord and testis. It is separated from the dartos tunic by loose areolar tissue. The cremaster consists of scattered bundles of muscular fibers connected together into a continuous covering by intermediate areolar tissue. The infundibuliform fascia, tunica vaginalis communis, testis et funiculi spermatici, is a thin layer which loosely invests the cord. It is a continuation downward of the transversalis fascia. The tunica vaginalis is described with the testes. Vessels and nerves. The arteries supplying the coverings of the testes are the superficial and deep external pudendal branches of the femoral, the superficial perineal branch of the internal pudendal, and the cremasteric branch from the inferior epigastric. The veins follow the course of the corresponding arteries. The lymphatics end in the inguinal lymph glands. The nerves are the ilioinguinal and lumboinguinal branches of the lumbar plexus, the two superficial perineal branches of the internal pudendal nerve, and the pudendal branch of the posterior femoral cutaneous nerve. The inguinal canal, canalis inguinalis, is described on page 418. The spermatic cord, funiculus spermaticus, extends from the abdominal inguinal ring, where the structures of which it is composed converge, to the back part of the testis. In the abdominal wall, the cord passes obliquely along the inguinal canal, lying at first beneath the obliquus internus and upon the fascia transversalis. But nearer the pubis, it rests upon the inguinal and lacunar ligaments, having the aponeurosis of the obliquus externus in front of it and the inguinal falx behind it. It then escapes at the subcutaneous ring and descends nearly vertically into the scrotum. The left cord is rather longer than the right, consequently the left testis hangs somewhat lower than its fellow. Structure of the spermatic cord. The spermatic cord is composed of arteries, veins, lymphatics, nerves, and the excretory duct of the testis. These structures are connected together by areolar tissue and invested by the layers brought down by the testis in its descent. The arteries of the cord are the internal and external spermatics, and the artery to the ductus deferens. The internal spermatic artery, a branch of the abdominal aorta, escapes from the abdomen at the abdominal inguinal ring and accompanies the other constituents of the spermatic cord along the inguinal canal and through the subcutaneous inguinal ring into the scrotum. It then descends to the testis and, becoming tortuous, divides into several branches, 2 or 3 of which accompany the ductus deferens and supply the epididymis, anastomosing with the artery of the ductus deferens. The others supply the substance of the testis. The external spermatic artery is a branch of the inferior epigastric artery. It accompanies the spermatic cord and supplies the coverings of the cord, anastomosing with the internal spermatic artery. The artery of the ductus deferens, a branch of the superior vesicle, is a long, slender vessel which accompanies the ductus deferens, ramifying upon its coats and anastomosing with the internal spermatic artery near the testis. The spermatic veins emerge from the back of the testis and receive tributaries from the epididymis. They unite and form a convoluted plexus, the plexus pampiniformis, which forms the chief mass of the cord. The vessels composing this plexus are very numerous and ascend along the cord in front of the ductus deferens. Below the subcutaneous inguinal ring, they unite to form 3 or 4 veins, which pass along the inguinal canal, and entering the abdomen through the abdominal inguinal ring, coalesce to form 2 veins. These again unite to form a single vein, which opens on the right side into the inferior vena cava at an acute angle, and on the left side into the left renal vein at a right angle. The lymphatic vessels are described on page 713. The nerves are the spermatic plexus from the sympathetic, joined by filaments from the pelvic plexus, which accompany the artery of the ductus deferens. The scrotum forms an admirable covering for the protection of the testes. These bodies, lying suspended and loose in the cavity of the scrotum and surrounded by serous membrane, are capable of great mobility and can therefore easily slip about within the scrotum and thus avoid injuries from blows or squeezes. The skin of the scrotum is very elastic and capable of great distension, and on account of the looseness and amount of subcutaneous tissue, The scrotum becomes greatly enlarged in cases of edema, to which this part is especially liable as a result of its dependent position. The testes are suspended in the scrotum by the spermatic cords, the left testis hanging somewhat lower than its fellow. The average dimensions of the testis are from 4 to 5 centimeters in length, 2.5 centimeters in breadth, and 3 centimeters in the antero-posterior diameter. Its weight varies from 10.5 to 14 grams. Each testis is of an oval form, compressed laterally, and having an oblique position in the scrotum. The upper extremity is directed forward and a little lateralward, the lower backward and a little medialward. The anterior convex border looks forward and downward, the posterior or straight border to which the cord is attached backward and upward. The anterior border and lateral surfaces, as well as both extremities of the organ, are convex, free, smooth, and invested by the visceral layer of the tunica vaginalis. The posterior border, to which the cord is attached, receives only a partial investment from that membrane. Lying upon the lateral edge of this posterior border is a long, narrow, flattened body named the epididymis. The epididymis consists of a central portion or body, an upper enlarged extremity, the head, globus major, and a lower pointed extremity, the tail, globus minor, which is continuous with the ductus deferens, the duct of the testis. The head is intimately connected with the upper end of the testis by means of the efferent ductules of the gland. The tail is connected with the lower end by cellular tissue and a reflection of the tunica vaginalis. The lateral surface, head, and tail of the epididymis are free and covered by the serous membrane. The body is also completely invested by it, excepting along its posterior border, while between the body and the testis is a pouch, named the sinus of the epididymis, digital fossa. The epididymis is connected to the back of the testis by a fold of the serous membrane. The testes and their coverings. Appendages of the testis and epididymis. On the upper extremity of the testis, just beneath the head of the epididymis, is a minute oval sessile body, the appendix of the testis, hydatid of Morgagni. It is the remnant of the upper end of the Mullerian duct. On the head of the epididymis is a second small stalked appendage, sometimes duplicated. It is named the appendix of the epididymis, pedunculated hydatid, and is usually regarded as a detached efferent duct. The testis is invested by 3 tunics, the tunica vaginalis, tunica albuginea, and tunica vasculosa. The tunica vaginalis propria testis, is the serous covering of the testis. It is a pouch of serous membrane derived from the saccus vaginalis of the peritoneum, which in the fetus preceded the descent of the testis from the abdomen into the scrotum. After its descent, that portion of the pouch which extends from the abdominal inguinal ring to near the upper part of the gland becomes obliterated. The lower portion remains as a shut sac, which invests the surface of the testis and is reflected onto the internal surface of the scrotum. Hence it may be described as consisting of a visceral and a parietal lamina. The visceral lamina, or lamina visceralis, covers the greater part of the testis and epididymis, connecting the latter to the testis by means of a distinct fold. From the posterior border of the gland it is reflected on to the internal surface of the scrotum. The parietal lamina, or lamina parietalis, is far more extensive than the visceral, extending upward for some distance in front and on the medial side of the cord, and reaching below the testis. The inner surface of the tunica vaginalis is smooth and covered by a layer of endothelial cells. The interval between the visceral and parietal laminae constitutes the cavity of the tunica vaginalis. The obliterated portion of the saccus vaginalis may generally be seen as a fibrocellular thread lying in the loose areolar tissue around the spermatic cord. Sometimes this may be traced as a distinct band from the upper end of the inguinal canal, where it is connected with the peritoneum, down to the tunica vaginalis. Sometimes it gradually becomes lost on the spermatic cord. Occasionally no trace of it can be detected. In some cases it happens that the pouch of peritoneum does not become obliterated, but the sac of the peritoneum communicates with the tunica vaginalis. This may give rise to one of the varieties of oblique inguinal hernia. In other cases, the pouch may contract, but not become entirely obliterated. It then forms a minute canal leading from the peritoneum to the tunica vaginalis. The tunica albuginea is the fibrous covering of the testis. It is a dense membrane of a bluish-white color composed of bundles of white fibrous tissue which interlace in every direction. It is covered by the tunica vaginalis, except at the points of attachment of the epididymis to the testis and along its posterior border, where the spermatic vessels enter the gland. It is applied to the tunica vasculosa over the glandular substance of the testis, and at its posterior border is reflected into the interior of the gland, forming an incomplete vertical septum called the mediastinum testis, or corpus hymori. The mediastinum testis extends from the upper to near the lower extremity of the gland and is wider above than below. From its front and sides, numerous imperfect septa, or trabeculae, are given off, which radiate toward the surface of the organ and are attached to the tunica albuginea. They divide the interior of the organ into a number of incomplete spaces which are somewhat cone-shaped, being broad at their base at the surface of the gland and becoming narrower as they converge to the mediastinum. The mediastinum supports the vessels and duct of the testis in their passage to and from the substance of the gland. The tunica vasculosa is the vascular layer of the testis, consisting of a plexus of blood vessels held together by delicate areolar tissue. It clothes the inner surface of the tunica albuginea and the different septa in the interior of the gland, and therefore forms an internal investment to all the spaces of which the gland is composed. Structure. The glandular structure of the testis consists of numerous lobules. Their number in a single testis is estimated by Barris at 250 and by Krauss at 400. They differ in size according to their position, those in the middle of the gland being larger and longer. The lobules are conical in shape, the base being directed toward the circumference of the organ, the apex toward the mediastinum. Each lobule is contained in one of the intervals between the fibrous septa, which extend between the mediastinum testis and the tunica albuginea, and consists of from 1 to 3 or more minute convoluted tubes, the tubuli seminiferi. The tubules may be separately unraveled by careful dissection under water, and may be seen to commence either by free cecal ends or by anastomotic loops. They are supported by loose connective tissue, which contains here and there groups of interstitial cells containing yellow pigment granules. The total number of tubules is estimated by Louth at 840, and the average length of each is 70 to 80 centimeters. Their diameter varies from 0.12 to 0.3 millimeters. The tubules are pale in color in early life, but in old age they acquire a deep yellow tinge from containing much fatty matter. Each tubule consists of a basement layer formed of laminated connective tissue containing numerous elastic fibers with flattened cells between the layers and covered externally by a layer of flattened epithelioid cells. Within the basement membrane are epithelial cells arranged in several irregular layers, which are not always clearly separated, but which may be arranged in 3 different groups. Among these cells may be seen the spermatozoa in different stages of development. Lining the basement membrane and forming the outer zone is a layer of cubicle cells with small nuclei. Some of these enlarge to become spermatogonia. The nuclei of some of the spermatogonia may be seen to be in process of indirect division, or karyokinesis, and in consequence of this, daughter cells are formed, which constitute the second zone. Within this first layer is to be seen a number of larger polyhedral cells with clear nuclei arranged in 2 or 3 layers. These are the intermediate cells, or spermatocytes. Most of these cells are in a condition of karyokinetic division, and the cells which result from this division form those of the next layer, the spermatoblasts, or spermatids. The third layer of cells consists of the spermatoblasts or spermatids, and each of these, without further subdivision, becomes a spermatozoon. The spermatids are small polyhedral cells the nucleus of each of which contains half the usual number of chromosomes. In addition to these 3 layers of cells, others are seen, which are termed the supporting cells, or cells of Sertoli. They are elongated and columnar, and project inward from the basement membrane toward the lumen of the tube. As development of the spermatozoa proceeds, the latter group themselves around the inner extremities of the supporting cells. The nuclear portion of the spermatid, which is partly embedded in the supporting cell, is differentiated to form the head of the spermatozoon, while part of the cell protoplasm forms the middle piece, and the tail is produced by an outgrowth from the double centriole of the cell. Ultimately, the heads are liberated and the spermatozoa are set free. The structure of the spermatozoa is described on pages 42 and 43. In the apices of the lobules, the tubules become less convoluted, assume a nearly straight course, and unite together to form from 20 to 30 larger ducts of about 0.5 millimeters in diameter, and these, from their straight course, are called tubuli recti. The tubuli recti enter the fibrous tissue of the mediastinum and pass upward and backward, forming, in their ascent, a close network of anastomosing tubes, which are merely channels in the fibrous stroma, lined by flattened epithelium and having no proper walls. This constitutes the rete testis. At the upper end of the mediastinum, the vessels of the rete testis terminate in from 12 to 15 or 20 ducts, the ductuli efferentes. They perforate the tunica albuginea and carry the seminal fluid from the testis to the epididymis. Their course is at first straight. They then become enlarged and exceedingly convoluted and form a series of conical masses, the coni vasculosi, which together constitute the head of the epididymis. Each cone consists of a single convoluted duct from 15 to 20 centimeters in length, the diameter of which gradually decreases from the testis to the epididymis. Opposite the bases of the cones, the efferent vessels open at narrow intervals into a single duct, which constitutes, by its complex convolutions, the body and tail of the epididymis. When the convolutions of this tube are unraveled, it measures upward of 6 meters in length. It decreases in diameter and thickness as it approaches the ductus deferens. The convolutions are held together by fine areolar tissue and by bands of fibrous tissue. The tubuli recti have very thin walls. Like the channels of the rete testis, they are lined by a single layer of flattened epithelium. The ductuli efferentes and the tube of the epididymis have walls of considerable thickness on account of the presence in them of muscular tissue, which is principally arranged in a circular manner. These tubes are lined by columnar ciliated epithelium. Peculiarities. The testis, developed in the lumbar region, may be arrested or delayed in its transit to the scrotum, cryptorchism. It may be retained in the abdomen, or it may be arrested at the abdominal inguinal ring, or in the inguinal canal, or it may just pass out of the subcutaneous inguinal ring without finding its way to the bottom of the scrotum. When retained in the abdomen, it gives rise to no symptoms other than the absence of the testis from the scrotum. But when it is retained in the inguinal canal, it is subjected to pressure and may become inflamed and painful. The retained testis is probably functionally useless, so that a man in whom both testes are retained, anorchism, is sterile, though he may not be impotent. The absence of one testis is termed monorchism. When a testis is retained in the inguinal canal, it is often complicated with a congenital hernia, the funicular process of the peritoneum not being obliterated. In addition to the cases above described, where there is some arrest in the descent of the testis, this organ may descend through the inguinal canal, but may miss the scrotum and assume some abnormal position. The most common form is where the testis, emerging at the subcutaneous inguinal ring, slips down between the scrotum and the thigh and comes to rest in the perineum. This is known as perineal ectopia testis. With each variety of abnormality in the position of the testis, it is very common to find concurrently a congenital hernia, or, if a hernia be not actually present, the funicular process is usually patent, and almost invariably so if the testis is in the inguinal canal. The testis, finally reaching the scrotum, may occupy an abnormal position in it. It may be inverted so that its posterior or attached border is directed forward and the tunica vaginalis is situated behind. Fluid collections of a serous character are very frequently found in the scrotum. To these the term hydrocele is applied. The most common form is the ordinary vaginal hydrocele, in which the fluid is contained in the sac of the tunica vaginalis, which is separated, in its normal condition, from the peritoneal cavity by the whole extent of the inguinal canal. In another form, the congenital hydrocele, the fluid is in the sac of the tunica vaginalis, but this cavity communicates with the general peritoneal cavity, its tubular process remaining pervious. A third variety, known as an infantile hydrocele, occurs in those cases where the tubular process becomes obliterated only at its upper part, at or near the abdominal inguinal ring. It resembles the vaginal hydrocele, except as regards its shape, the collection of fluid extending up to the cord into the inguinal canal. Fourthly, the funicular process may become obliterated both at the abdominal inguinal ring and above the epididymis, leaving a central unobliterated portion which may become distended with fluid, giving rise to a condition known as the encysted hydrocele of the cord. The ductus deferens, or the vas deferens, or the seminal duct. The ductus deferens, the excretory duct of the testis, is the continuation of the canal of the epididymis. Commencing at the lower part of the tail of the epididymis, it is at first very tortuous, but gradually becoming less twisted, it ascends along the posterior border of the testis and medial side of the epididymis, and, as a constituent of the spermatic cord, traverses the inguinal canal to the abdominal inguinal ring. Here it separates from the other structures of the cord, curves around the lateral side of the inferior epigastric artery, and ascends for about 2.5 centimeters in front of the external iliac artery. It is next directed backward and slightly downward, and, crossing the external iliac vessels obliquely, enters the pelvic cavity, where it lies between the peritoneal membrane and the lateral wall of the pelvis, and descends on the medial side of the obliterated umbilical artery and the obturator nerve and vessels. It then crosses in front of the ureter, and reaching the medial side of this tube, bends to form an acute angle, and runs medialward and slightly forward between the fundus of the bladder and the upper end of the seminal vesicle. Reaching the medial side of the seminal vesicle, it is directed downward and medialward in contact with it, gradually approaching the opposite ductus. Here it lies between the fundus of the bladder and the rectum, where it is enclosed, together with the seminal vesicle, in a sheath derived from the rectovesical portion of the fascia endopelvina. Lastly, it is directed downward to the base of the prostate, where it becomes greatly narrowed and is joined at an acute angle by the duct of the seminal vesicle to form the ejaculatory duct, which traverses the prostate behind its middle lobe and opens into the prostatic portion of the urethra, close to the orifice of the prostatic utricle. The ductus deferens presents a hard and cord-like sensation to the fingers and is of cylindrical form. Its walls are dense and its canal is extremely small. At the fundus of the bladder it becomes enlarged and tortuous, and this portion is termed the ampulla. A small triangular area of the fundus of the bladder, between the ductus deferens laterally and the bottom of the rectovesical excavation of peritoneum above, is in contact with the rectum. Ductuli aberrantes. A long, narrow tube, the ductulus aberrans inferior, or vas aberrans of Haller, is occasionally found connected with the lower part of the canal of the epididymis, or with the commencement of the ductus deferens. Its length varies from 3.5 to 35 centimeters, and it may become dilated toward its extremity. More commonly, it retains the same diameter throughout. Its structure is similar to that of the ductus deferens. Occasionally it is found unconnected with the epididymis. A second tube, the ductulus aberrans superior, occurs in the head of the epididymis. It is connected with the rete testis. Perididymis, or organ of Geraldis. This term is applied to a small collection of convoluted tubules situated in front of the lower part of the cord above the head of the epididymis. These tubes are lined with columnar ciliated epithelium and probably represent the remains of a part of the Wolfian body. Structure. The ductus deferens consists of three coats. Number 1, an external or areolar coat. Number 2, a muscular coat, which in the greater portion of the tube consists of 2 layers of unstriped muscular fiber, an outer longitudinal in direction and an inner circular. But in addition to these, at the commencement of the ductus there is a third layer, consisting of longitudinal fibers, placed internal to the circular stratum between it and the mucous membrane. Number 3, an internal or mucous coat, which is pale and arranged in longitudinal folds. The mucous coat is lined by columnar epithelium, which is non-ciliated throughout the greater part of the tube. A variable portion of the testicular end of the tube is lined by 2 strata of columnar cells, and the cells of the superficial layer are ciliated. Next chapter, the vesiculae seminalis, or seminal vesicles. The vesiculae seminalis are 2 lobulated membranous pouches placed between the fundus of the bladder and the rectum, serving as reservoirs for the semen and secreting a fluid to be added to the secretion of the testes. Each sac is somewhat pyramidal in form, the broad end being directed backward, upward, and lateralward. It is usually about 7.5 centimeters long, but varies in size, not only in different individuals, but also in the same individual on the 2 sides. The anterior surface is in contact with the fundus of the bladder, extending from near the termination of the ureter to the base of the prostate. The posterior surface rests upon the rectum, from which it is separated by the rectovesical fascia. The upper extremities of the 2 vesicles diverge from each other, and are in relation with the ductus deferens and the terminations of the ureters, and are partly covered by peritoneum. The lower extremities are pointed and converge toward the base of the prostate, where each joins with the corresponding ductus deferens to form the ejaculatory duct. Along the medial margin of each vesicle runs the ampulla of the ductus deferens. Each vesicle consists of a single tube coiled upon itself and giving off several irregular cecal diverticula. The separate coils, as well as the diverticula, are connected together by fibrous tissue. When uncoiled, the tube is about the diameter of a quill and varies in length from 10 to 15 centimeters. It ends posteriorly in a cul-de-sac. Its anterior extremity becomes constricted into a narrow, straight duct, which joins with the corresponding ductus deferens to form the ejaculatory duct. Structure. The vesiculae seminalis are composed of 3 coats: an external or areolar coat, a middle or muscular coat thinner than in the ductus deferens and arranged in 2 layers, an outer longitudinal and an inner circular, an internal or mucous coat which is pale, of a whitish-brown color, and presents a delicate reticular structure. The epithelium is columnar, and in the diverticula goblet cells are present, the secretion of which increases the bulk of the seminal fluid. Vessels and nerves. The arteries supplying the vesiculae seminalis are derived from the middle and inferior vesicle and middle hemorrhoidal. The veins and lymphatics accompany the arteries. The nerves are derived from the pelvic plexuses. The next chapter is the ejaculatory ducts, or ductus ejaculatorii. The ejaculatory ducts are 2 in number, 1 on either side of the middle line. Each is formed by the union of the duct from the vesicula seminalis with the ductus deferens and is about 2 centimeters long. They commence at the base of the prostate and run forward and downward between its middle and lateral lobes and along the sides of the prostatic utricle, to end by separate slit-like orifices close to or just within the margins of the utricle. The ducts diminish in size and also converge toward their terminations. Structure. The coats of the ejaculatory ducts are extremely thin. They are an outer fibrous layer which is almost entirely lost after the entrance of the ducts into the prostate, a layer of muscular fibers consisting of a thin outer circular and an inner longitudinal layer, and mucous membrane.
The penis. The penis is a pendulous organ suspended from the front and sides of the pubic arch and containing the greater part of the urethra. In the flaccid condition it is cylindrical in shape, but when erect assumes the form of a triangular prism with rounded angles, one side of the prism forming the dorsum. It is composed of three cylindrical masses of cavernous tissue bound together by fibrous tissue and covered with skin. Two of the masses are lateral and are known as the corpora cavernosa penis. The third is median and is termed the corpus cavernosum urethrae. The corpora cavernosa penis form the greater part of the substance of the penis. For their anterior 3/4 they lie in intimate apposition with one another, but behind they diverge in the form of two tapering processes, known as the crura, which are firmly connected to the rami of the pubic arch. Traced from behind forward, each crus begins by a blunt-pointed process in front of the tuberosity of the ischium. Just before it meets its fellow, it presents a slight enlargement, named by Cobalt the bulb of the corpus cavernosum penis. Beyond this point, the crus undergoes a constriction and merges into the corpus cavernosum proper, which retains a uniform diameter to its anterior end. Each corpus cavernosum penis ends abruptly in a rounded extremity some distance from the point of the penis. The corpora cavernosa penis are surrounded by a strong fibrous envelope consisting of superficial and deep fibers. The superficial fibers are longitudinal in direction and form a single tube which encloses both corpora. The deep fibers are arranged circularly around each corpus and form by their junction in the median plane the septum of the penis. This is thick and complete behind, but it is imperfect in front, where it consists of a series of vertical bands arranged like the teeth of a comb. It is therefore named the septum pectiniforme. The corpus cavernosum urethrae, corpus spongiosum, contains the urethra. Behind, it is expanded to form the urethral bulb, and lies in apposition with the inferior fascia of the urogenital diaphragm, from which it receives a fibrous investment. The urethra enters the bulb nearer to the upper than to the lower surface. On the latter there is a median sulcus, from which a thin fibrous septum projects into the substance of the bulb and divides it imperfectly into two lateral lobes or hemispheres. The portion of the corpus cavernosum urethra in front of the bulb lies in a groove on the under surface of the conjoined corpora cavernosa penis. It is cylindrical in form and tapers slightly from behind forward. Its anterior end is expanded in the form of an obtuse cone, flattened from above downward. This expansion, termed the glans penis, is molded on the rounded ends of the corpora cavernosa penis, extending farther on their upper than on their lower surfaces. At the summit of the glans is the slit-like, vertical external urethral orifice. The circumference of the base of the glans forms a rounded projecting border, the corona glandis, overhanging a deep retroglandular sulcus, behind which is the neck of the penis. For descriptive purposes it is convenient to divide the penis into three regions: the root, the body, and the extremity. The root, radix penis, of the penis is triradiate in form, consisting of the diverging crura, one on either side, and the median urethral bulb. Each crus is covered by the ischiocavernosus, while the bulb is surrounded by the bulbocavernosus. The root of the penis lies in the perineum between the inferior fascia of the urogenital diaphragm and the fascia of Colles. In addition to being attached to the fascia in the pubic rami, it is bound to the front of the symphysis pubis by the fundiform and suspensory ligaments. The fundiform ligament springs from the front of the sheath of the rectus abdominis and the linea alba. It splits into two fasciculi, which encircle the root of the penis. The upper fibers of the suspensory ligament pass downward from the lower end of the linea alba, and the lower fibers from the symphysis pubis. Together they form a strong fibrous band, which extends to the upper surface of the root, where it blends with the fascial sheath of the organ. The body, corpus penis, extends from the root to the ends of the corpora cavernosa penis, and in it these corpora cavernosa are intimately bound to one another. A shallow groove which marks their junction on the upper surface lodges the deep dorsal vein of the penis, while a deeper and wider groove between them on the undersurface contains the corpus cavernosum urethrae. The body is ensheathed by fascia, which is continuous above the fascia of Scarpa, and below with the dartos tunic of the scrotum and the fascia of Colles. The extremity is formed by the glans penis, the expanded anterior end of the corpus cavernosum urethrae. It is separated from the body by the constricted neck, which is overhung by the corona glandis. The integument covering the penis is remarkable for its thinness, its dark color, its looseness of connection with the deeper parts of the organ, and its absence of adipose tissue. At the root of the penis it is continuous with that over the pubes, scrotum, and perineum. At the neck it leaves the surface and becomes folded upon itself to form the prepuce or foreskin. The internal layer of the prepuce is directly continuous along the line of the neck with the integument over the glans. Immediately behind the external urethral orifice it forms a small secondary reduplication attached along the bottom of a depressed median raphe, which extends from the meatus to the neck. This fold is termed the frenulum of the prepuce. The integument covering the glans is continuous with the urethral mucous membrane at the orifice. It is devoid of hairies, but projecting from its free surface are a number of small, highly sensitive papillae. Scattered glands on the corona, neck, glans, and inner layer of the prepuce, the preputial glands, have been described. They secrete a sebaceous material of very peculiar odor, which probably contains casein, and readily undergoes decomposition. When mixed with discarded epithelial cells, it is called smegma. The prepuce covers a variable amount of the glans, and is separated from it by a potential sac, the preputial sac, which presents two shallow fossae, one on either side of the frenulum. Structure of the penis. From the internal surface of the fibrous envelope of the corpora cavernosa penis, as well as from the sides of the septum, numerous bands or cords are given off, which cross the interior of these corpora cavernosa in all directions, subdividing them into a number of separate compartments and giving the entire structure a spongy appearance. These bands and cords are called trabeculae and consist of white fibrous tissue, elastic fibers, and plain muscular fibers. In them are contained numerous arteries and nerves. The component fibers which form the trabeculae are larger and stronger around the circumference than at the centers of the corpora cavernosa. They are also thicker behind than in front. The interspaces, cavernous spaces, on the contrary, are larger at the center than at the circumference, their long diameters being directed transversely. They are filled with blood, and are lined by a layer of flattened cells similar to the endothelial lining of veins. The fibrous envelope of the corpus cavernosum urethrae is thinner, whiter in color, and more elastic than that of the corpora cavernosa penis. The trabeculae are more delicate, nearly uniform in size, and the meshes between them smaller than in the corpora cavernosa penis, their long diameters, for the most part, corresponding with that of the penis. The external envelope or outer coat of the corpus cavernosum urethrae is formed partly of unstriped muscular fibers, and a layer of the same tissue immediately surrounds the canal of the urethra. Vessels and nerves. The arteries bringing the blood to the cavernous spaces are the deep arteries of the penis and branches from the dorsal arteries of the penis, which perforate the fibrous capsule along the upper surface, especially near the forepart of the organ. On entering the cavernous structure, the arteries divide into branches which are supported and enclosed by the trabeculae. Some of these arteries end in capillary network, the branches of which open directly into the cavernous spaces. Others assume a tendril-like appearance and form convoluted and somewhat dilated vessels, which were named by Müller Helicine arteries. They open into the spaces, and from them are also given off small capillary branches to supply the trabecular structure. They are bound down in the spaces by fine fibrous processes, and are most abundant in the back part of the corpora cavernosa. The blood from the cavernous spaces is returned by a series of vessels, some of which emerge in considerable numbers from the base of the glans penis and converge on the dorsum of the organ to form the deep dorsal vein. Others pass out on the upper surface of the corpora cavernosa and join the same vein. Some emerge from the under surface of the corpora cavernosa penis, and receiving branches from the corpus cavernosum urethrae, wind around the sides of the penis to end in the deep dorsal vein, but the greater number pass out at the root of the penis and join the prostatic plexus. The lymphatic vessels of the penis are described on page 713. The nerves are derived from the pudendal nerve and the pelvic plexuses. On the glans and bulb, some filaments of the cutaneous nerves have Pacinian bodies connected with them, and, according to Krauss, many of them end in peculiar end bulbs. Footnote 178. Staida, Comptes Rendus du 12 Congrès International de Médecine, Moscow, 1897, asserts that glands are never found on the corona glandis, and that what have hitherto been mistaken for glands are really large papillae. End footnote.
37. The prostate. Bulbourethral glands. 3c. 6. The prostate. Prostata. Prostate gland. The prostate is a firm, partly glandular and partly muscular body, which is placed immediately below the internal urethral orifice, and around the commencement of the urethra. It is situated in the pelvic cavity below the lower part of the symphysis pubis, above the superior fascia of the urogenital diaphragm, and in front of the rectum, through which it may be distinctly felt, especially when enlarged. It is about the size of a chestnut and somewhat conical in shape, and presents for examination a base, an apex, an anterior, a posterior, and 2 lateral surfaces. The base, basis prostatae, is directed upward and is applied to the inferior surface of the bladder. The greater part of this surface is directly continuous with the bladder wall. The urethra penetrates it nearer its anterior than its posterior border. The apex, apex prostatae, is directed downward and is in contact with the superior fascia of the urogenital diaphragm. Surfaces. The posterior surface, facies posterior, is flattened from side to side and slightly convex from above downward. It is separated from the rectum by its sheath and some loose connective tissue, and is distant about 4 centimeters from the anus. Near its upper border, there is a depression through which the 2 ejaculatory ducts enter the prostate. This depression serves to divide the posterior surface into a lower, larger, and an upper, smaller part. The upper, smaller part constitutes the middle lobe of the prostate and intervenes between the ejaculatory ducts and the urethra. It varies greatly in size and in some cases is destitute of glandular tissue. The lower, larger portion sometimes presents a shallow median furrow, which imperfectly separates it into a right and a left lateral lobe. These form the main mass of the gland, and are directly continuous with each other behind the urethra. In front of the urethra, they are connected by a band which is named the isthmus. This consists of the same tissues as the capsule and is devoid of glandular substance. The anterior surface, facies anterior, measures about 2.5 centimeters from above downward, but is narrow and convex from side to side. It is placed about 2 centimeters behind the pubic symphysis, from which it is separated by a plexus of veins and a quantity of loose fat. It is connected to the pubic bone on either side by the puboprostatic ligaments. The urethra emerges from this surface a little above and in front of the apex of the gland. The lateral surfaces are prominent and are covered by the anterior portions of the levatories ani, which are, however, separated from the gland by a plexus of veins. The prostate measures about 4 centimeters transversely at the base, 2 centimeters in its anteroposterior diameter, and 3 centimeters in its vertical diameter. Its weight is about 8 grams. It is held in its position by the puboprostatic ligaments, by the superior fascia of the urogenital diaphragm, which invests the prostate, and the commencement of the membranous portion of the urethra, and by the anterior portions of the levatories ani, which pass backwards from the pubis, and embrace the sides of the prostate. These portions of the levatories ani, from the support they afford to the prostate, are named the levatories prostatae. The prostate is perforated by the urethra and the ejaculatory ducts. The urethra usually lies along the junction of its anterior with its middle third. The ejaculatory ducts pass obliquely downward and forward through the posterior part of the prostate and open into the prostatic portion of the urethra. Structure. The prostate is immediately enveloped by a thin but firm fibrous capsule, distinct from that derived from the fascia endopelvina and separated from it by a plexus of veins. This capsule is firmly adherent to the prostate and is structurally continuous with the stroma of the gland, being composed of the same tissues, viz., non-striped muscle and fibrous tissue. The substance of the prostate is of a pale reddish-gray color, of great density and not easily torn. It consists of glandular substance and muscular tissue. The muscular tissue, according to Kroliker, constitutes the proper stroma of the prostate, the connective tissue being very scanty and simply forming between the muscular fibers. Thin trabecula in which the vessels and nerves of the gland ramify. The muscular tissue is arranged as follows. Immediately beneath the fibrous capsule is a dense layer, which forms an investing sheath for the gland. Secondly, around the urethra, as it lies in the prostate, is another dense layer of circular fibers, continuous above with the internal layer of the muscular coat of the bladder, and blending below with the fibers surrounding the membranous portion of the urethra. Between these 2 layers, strong bands of muscular tissue, which decussate freely, form meshes in which the glandular structure of the organ is embedded. In that part of the gland which is situated in front of the urethra, the muscular tissue is especially dense, and there is here little or no gland tissue, while in that part which is behind the urethra, the muscular tissue presents a wide-meshed structure, which is densest at the base of the gland, that is, near the bladder, becoming looser and more sponge-like toward the apex of the organ. The glandular substance is composed of numerous follicular pouches, the lining of which frequently shows papillary elevations. The follicles open into elongated canals which join to form from 12 to 20 small excretory ducts. They are connected together by areolar tissue, supported by prolongations from the fibrous capsule and the muscular stroma, and enclosed in a delicate capillary plexus. The epithelium which lines the canals and the terminal vesicles is of the columnar variety. The prostatic ducts open into the floor of the prostatic portion of the urethra and are lined by 2 layers of epithelium, the inner layer consisting of columnar and the outer of small cubical cells. Small colloid masses known as amyloid bodies are often found in the gland tubes. Vessels and nerves. The arteries supplying the prostate are derived from the internal pudental, inferior vesicle, and middle hemorrhoidal. Its veins form a plexus around the sides and base of the gland. They receive in front the dorsal vein of the penis, and end in the hypogastric veins. The nerves are derived from the pelvic plexus. 3C7. The bulbourethral glands. Glandulae bulbourethral. Cowper's glands. The bulbourethral glands are two small, rounded, and somewhat lobulated bodies, of a yellow color, about the size of peas, placed behind and lateral to the membranous portion of the urethra, between the two layers of the fascia of the urogenital diaphragm. They lie close above the bulb, and are enclosed by the transverse fibers of the sphincter urethrae membranaceae. Their existence is said to be constant. They gradually diminish in size as age advances. The excretory duct of each gland, nearly 2.5 centimeters long, passes obliquely forward beneath the mucous membrane, and opens by a minute orifice on the floor of the cavernous portion of the urethra about 2.5 centimeters in front of the urogenital diaphragm. Structure. The gland is made up of several lobules held together by a fibrous investment. Each lobule consists of a number of acini lined by columnar epithelial cells, opening into one duct, which joins with the ducts of other lobules outside the gland to form the single excretory duct.
Female genital organs, ovaries, uterine tube. Female genital organs, ovaries, uterine tube. The female genital organs. Organa genitalia mulibria. The female genital organs consist of an internal and an external group. The internal organs are situated within the pelvis and consist of the ovaries, the uterine tubes, the uterus, and the vagina. The external organs are placed below the urogenital diaphragm and below and in front of the pubic arch. They comprise the mons pubis, the labia majora et minora pudendi, the clitoris, the bulbus vestibuli, and the greater vestibular glands. The ovaries, ovaria. The ovaries are homologous with the testes in the male. They are two nodular bodies, situated one on either side of the uterus in relation to the lateral wall of the pelvis, and attached to the back of the broad ligament of the uterus, behind and below the uterine tubes. The ovaries are of a grayish-pink color, and present either a smooth or a puckered, uneven surface. They are each about 4 centimeters in length, 2 centimeters in width, and about 8 millimeters in thickness, and weigh from 2 to 3.5 grams. Each ovary presents a lateral and a medial surface, an upper or tubal, and a lower or uterine extremity, and an anterior or mesovarian and a posterior free border. It lies in a shallow depression, named the ovarian fossa, on the lateral wall of the pelvis. This fossa is bounded above by the external iliac vessels, in front by the obliterated umbilical artery, and behind by the ureter. The exact position of the ovary has been the subject of considerable difference of opinion, and the description here given applies to the ovary of the nulliparous woman. The ovary becomes displaced during the first pregnancy and probably never again returns to its original position. In the erect posture, the long axis of the ovary is vertical. The tubal extremity is near the external iliac vein. To it are attached the ovarian fimbria of the uterine tube and a fold of peritoneum, the suspensory ligament of the ovary, which is directed upward over the iliac vessels and contains the ovarian vessels. The uterine end is directed downward toward the pelvic floor. It is usually narrower than the tubal, and is attached to the lateral angle of the uterus, immediately behind the uterine tube, by a rounded cord termed the ligament of the ovary, which lies within the broad ligament and contains some non-striped muscular fibers. The lateral surface is in contact with the parietal peritoneum, which lines the ovarian fossa. The medial surface is to a large extent covered by the fimbriated extremity of the uterine tube. The mesovarian border is straight and is directed toward the obliterated umbilical artery, and is attached to the back of the broad ligament by a short fold named the mesovarium. Between the two layers of this fold, the blood vessels and nerves pass to reach the hilum of the ovary. The free border is convex and is directed toward the ureter. The uterine tube arches over the ovary, running upward in relation to its mesovarian border, then curving over its tubal pole and finally passing downward on its free border and medial surface. Epuphoron, parivarium, organ of Rosenmuller. The epuphoron lies in the mesosulpinx between the ovary and the uterine tube, and consists of a few short tubules, ductuli transversi, which converge toward the ovary, while their opposite ends open into a rudimentary duct, the ductus longitudinalis epuphori, duct of Gartner. Peruphoron. The peruphoron consists of a few scattered rudimentary tubules, best seen in the child, situated in the broad ligament between the epuphoron and the uterus. The ductuli transversi of the epuphoron and the tubules of the peruphoron are remnants of the tubules of the Wolffian body, or mesonephros. The ductus longitudinalis epuphori is a persistent portion of the Wolffian duct. In the fetus, the ovaries are situated, like the testes, in the lumbar region, near the kidneys, but they gradually descend into the pelvis. Structure. The surface of the ovary is covered by a layer of columnar cells which constitutes the germinal epithelium of Waldeyer. The epithelium gives to the ovary a dull gray color as compared with the shining smoothness of the peritoneum, and the transition between the squamous epithelium of the peritoneum and the columnar cells which cover the ovary is usually marked by a line around the anterior border of the ovary. The ovary consists of a number of vesicular ovarian follicles embedded in the meshes of a stroma or framework. The stroma is a peculiar soft tissue, abundantly supplied with blood vessels, consisting for the most part of spindle-shaped cells with a small amount of ordinary connective tissue. These cells have been regarded by some anatomists as unstriped muscle cells, which, indeed, they most resemble, by others as connective tissue cells. On the surface of the organ, this tissue is much condensed, and forms a layer, tunica albuginea, composed of short connective tissue fibers, with fusiform cells between them. The stroma of the ovary may contain interstitial cells resembling those of the testes. Vesicular ovarian follicles. Graafian follicles. Upon making a section of an ovary, numerous round transparent vesicles of various sizes are to be seen. They are the follicles, or ovisacs, containing the ova. Immediately beneath the superficial covering is a layer of stroma, in which are a large number of minute vesicles, of uniform size, about 0.25 millimeters in diameter. These are the follicles in their earliest condition, and the layer where they are found has been termed the cortical layer. They are especially numerous in the ovary of the young child. After puberty, and during the whole of the childbearing period, large and mature, or almost mature, follicles are also found in the cortical layer in small numbers, and also corpora lutea, the remains of follicles which have burst and are undergoing atrophy and absorption. Beneath this superficial stratum, other large and more or less mature follicles are found embedded in the ovarian stroma. These increase in size as they recede from the surface toward a highly vascular stroma in the center of the organ, termed the medullary substance, zona vasculosa of Waldeyer. This stroma forms the tissue of the hilum by which the ovary is attached, and through which the blood vessels enter. It does not contain any follicles. The larger follicles consist of an external fibrovascular coat connected with the surrounding stroma of the ovary by a network of blood vessels, and an internal coat which consists of several layers of nucleated cells called the membrana granulosa. At one part of the mature follicle, the cells of the membrana granulosa are collected into a mass which projects into the cavity of the follicle. This is termed the discus proligerus, and in it the ovum is embedded. The follicle contains a transparent albuminous fluid. The development and maturation of the follicles and ova continue uninterruptedly from puberty to the end of the fruitful period of woman's life, while their formation commences before birth. Before puberty, the ovaries are small, and the follicles contained in them are disposed in a comparatively thick layer in the cortical substance. Here they present the appearance of a large number of minute closed vesicles constituting the early condition of the follicles. Many, however, never attain full development, but shrink and disappear. At puberty, the ovaries enlarge and become more vascular. The follicles are developed in greater abundance, and their ova are capable of fecundation. Discharge of the ovum. The follicles, after attaining a certain stage of development, gradually approach the surface of the ovary and burst. The ovum and fluid contents of the follicle are liberated on the exterior of the ovary and carried into the uterine tube by currents set up by the movements of the cilia covering the mucous membrane of the fimbriae. Corpus luteum. After the discharge of the ovum, the lining of the follicle is thrown into folds, and vascular processes grow inward from the surrounding tissue. In this way, the space is filled up and the corpus luteum formed. It consists at first of a radial arrangement of yellow cells with blood vessels and lymphatic spaces, and later it merges with the surrounding stroma. Vessels and nerves. The arteries of the ovaries and uterine tubes are the ovarian from the aorta. Each anastomoses freely in the mesosalpinx, with the uterine artery giving some branches to the uterine tube, and others which traverse the mesovarium and enter the hilum of the ovary. The veins emerge from the hilum in the form of a plexus, the pampiniform plexus. The ovarian vein is formed from this plexus and leaves the pelvis in company with the artery. The nerves are derived from the hypogastric or pelvic plexus, and from the ovarian plexus, the uterine tube receiving a branch from one of the uterine nerves. Footnote 179. For a description of the ovum, see page 38. End footnote. The uterine tube. Tuba uterina, fallopian tube, oviduct. The uterine tubes convey the ova from the ovaries to the cavity of the uterus. They are 2 in number, 1 on either side, situated in the upper margin of the broad ligament, and extending from the superior angle of the uterus to the side of the pelvis. Each tube is about 10 centimeters long, and is described as consisting of 3 portions. 1. The isthmus, or medial constricted third. 2. The ampulla, or intermediate dilated portion, which curves over the ovary. And 3. The infundibulum, with its abdominal ostium, surrounded by fimbriae, one of which, the ovarium fimbriae, is attached to the ovary. The uterine tube is directed lateralward as far as the uterine pole of the ovary, and then ascends along the mesovarian border of the ovary to the tubal pole, over which it arches. Finally it turns downward and ends in relation to the free border and medial surface of the ovary. The uterine opening is minute and will only admit a fine bristle. The abdominal opening is somewhat larger. In connection with the fimbriae of the uterine tube, or with the broad ligament close to them, there are frequently 1 or more small pedunculated vessels. These are termed the appendices vesculosæ, hydatids of Morgagni. Structure. The uterine tube consists of 3 coats, serous, muscular, and mucous. The external or serous coat is peritoneal. The middle or muscular coat consists of an external longitudinal and an internal circular layer of non-striped muscular fibers continuous with those of the uterus. The internal or mucus coat is continuous with the mucus lining of the uterus, and at the abdominal ostium of the tube with the peritoneum. It is thrown into longitudinal folds, which in the ampulla are much more extensive than in the isthmus. The lining epithelium is columnar and ciliated. This form of epithelium is also found on the inner surface of the fimbriae, which, while on the outer or serous surfaces of these processes, the epithelium gradually emerges from the endothelium of the peritoneum. Fertilization of the ovum is believed to occur in the tube, and the fertilized ovum is then normally passed on into the uterus. The ovum, however, may adhere to and undergo development in the uterine tube, giving rise to the commonest variety of ectopic gestation. In such cases the amnion and chorion are formed, but a true decidua is never present, and the gestation usually ends by extrusion of the ovum through the abdominal ostium, although it is not uncommon for the tube to rupture into the peritoneal cavity, this being accompanied by severe hemorrhage and needing surgical interference.
The uterus, womb. The uterus is a hollow, thick-walled, muscular organ situated deeply in the pelvic cavity between the bladder and rectum. Into its upper part the uterine tubes open, one on either side, while below its cavity communicates with that of the vagina. When the ova are discharged from the ovaries, they are carried to the uterine cavity through the uterine tubes. If an ovum be fertilized, it embeds itself in the uterine wall, and is normally retained in the uterus until prenatal development is completed, the uterus undergoing changes in size and structure to accommodate itself to the needs of the growing embryo. After parturition, the uterus returns almost to its former condition, but certain traces of its enlargement remains. It is necessary, therefore, to describe as the type form the adult virgin uterus, and then to consider the modifications which are effected as a result of pregnancy. In the virgin state, the uterus is flattened antero-posteriorly and is piriform in shape, with the apex directed downward and backward. It lies between the bladder in front and the pelvic or sigmoid colon and rectum behind, and is completely within the pelvis, so that its base is below the level of the superior pelvic aperture. Its upper part is suspended by the broad and the round ligaments, while its lower portion is embedded in the fibrous tissue of the pelvis. The long axis of the uterus usually lies approximately in the axis of the superior pelvic aperture, but as the organ is freely movable, its position varies with the state of distension of the bladder and rectum. Except when much displaced by a fully distended bladder, it forms a forward angle with the vagina, since the axis of the vagina corresponds to the axes of the cavity and inferior aperture of the pelvis. The uterus measures about 7.5 centimeters in length, 5 centimeters in breadth at its upper part, and nearly 2.5 centimeters in thickness. It weighs from 30 to 40 grams. It is divisible into two portions. On the surface, about midway between the apex and base, is a slight constriction known as the isthmus, and corresponding to this in the interior is a narrowing of the uterine cavity, the internal orifice of the uterus. The portion above the isthmus is termed the body, and that below the cervix. The part of the body which lies above a plane passing through the points of entrance of the uterine tubes is known as the fundus. Body, corpus uteri. The body gradually narrows from the fundus to the isthmus. The vesicle or anterior surface, facies vesicalis, is flattened and covered by peritoneum, which is reflected onto the bladder to form the vesico-uterine excavation. The surface lies in apposition with the bladder. The intestinal or posterior surface, facies intestinalis, is convex transversely and is covered by peritoneum, which is continued down onto the cervix and vagina. It is in relation with the sigmoid colon, from which it is usually separated by some coils of small intestine. The fundus, fundus uteri, is convex in all directions, and covered by peritoneum, continuous with that on the vesical and intestinal surfaces. On it rest some coils of small intestine, and occasionally the distended sigmoid colon. The lateral margins, margo lateralis, are slightly convex. At the upper end of each, the uterine tube pierces the uterine wall. Below and in front of this point, the round ligament of the uterus is fixed, while behind it is the attachment of the ligament of the ovary. These three structures lie within a fold of peritoneum which is reflected from the margin of the uterus to the wall of the pelvis, and is named the broad ligament. Cervix, cervix uteri, neck. The cervix is the lower constricted segment of the uterus. It is somewhat conical in shape, with its truncated apex directed downward and backward, but is slightly wider in the middle than either above or below. Owing to its relationships, it is less freely movable than the body, so that the latter may bend on it. The long axis of the cervix is therefore seldom in the same straight line as the long axis of the body. The long axis of the uterus as a whole presents the form of a curved line, with its concavity forward, or in extreme cases may present an angular bend at the region of the isthmus. The cervix projects through the anterior wall of the vagina, which divides it into an upper supravaginal portion and a lower vaginal portion. The supravaginal portion, portio supravaginalis, cervicis, is separated in front from the bladder by fibrous tissue, parametrium, which extends also onto its sides and lateralward between the layers of the broad ligaments. The uterine arteries reach the margins of the cervix in this fibrous tissue, while on either side the ureter runs downward and forward in it, at a distance of about 2 centimeters from the cervix. Posteriorly, the supravaginal cervix is covered by peritoneum, which is prolonged below onto the posterior vaginal wall, when it is reflected onto the rectum, forming the recto-uterine excavation. It is in relation with the rectum, from which it may be separated by coils of small intestine. The vaginal portion, portio vaginalis cervicis, of the cervix, projects free into the anterior wall of the vagina between the anterior and posterior fornices. On its rounded extremity is a small, depressed, somewhat circular aperture, the external orifice of the uterus, through which the cavity of the cervix communicates with that of the vagina. The external orifice is bounded by 2 lips, an anterior and a posterior, of which the anterior is the shorter and thicker, although, on account of the slope of the cervix, it projects lower than the posterior. Normally, both lips are in contact with the posterior vaginal wall. Interior of the uterus. The cavity of the uterus is small in comparison with the size of the organ. The cavity of the body, cavum uteri, is a mere slit, flattened antero-posteriorly. It is triangular in shape, the base being formed by the internal surface of the fundus between the orifices of the uterine tubes, the apex by the internal orifice of the uterus through which the cavity of the body communicates with the canal of the cervix. The canal of the cervix, canalus cervicis uteri, is somewhat fusiform, flattened from before backward, and broader at the middle than at either extremity. It communicates above through the internal orifice with the cavity of the body, and below through the external orifice with the vaginal cavity. The wall of the canal presents an anterior and a posterior longitudinal ridge, from each of which proceed a number of small oblique columns, the palmate folds, giving the appearance of branches from the stem of a tree. To this arrangement the name arbor vitae uterina is applied. The folds on the 2 walls are not exactly opposed, but fit between one another so as to close the cervical canal. The total length of the uterine cavity from the external orifice to the fundus is about 6.25 centimeters. Ligaments. The ligaments of the uterus are 8 in number, 1 anterior, 1 posterior, 2 lateral or broad, 2 uterosacral, and 2 round ligaments. The anterior ligament consists of the vesico-uterine fold of peritoneum, which is reflected onto the bladder from the front of the uterus, at the junction of the cervix and body. The posterior ligament consists of the rectovaginal fold of peritoneum, which is reflected from the back of the posterior fornix of the vagina onto the front of the rectum. It forms the bottom of a deep pouch called the recto-uterine excavation, which is bounded in front by the posterior wall of the uterus, the supravaginal cervix, and the posterior fornix of the vagina. behind by the rectum, and laterally by two crescentic folds of peritoneum which pass backward from the cervix uteri on either side of the rectum to the posterior wall of the pelvis. These folds are named the sacrogenital or recto-uterine folds. They contain a considerable amount of fibrous tissue and non-striped muscular fibers, which are attached to the front of the sacrum and constitute the uterosacral ligaments. The two lateral or broad ligaments, ligamentum latum uteri, pass from the sides of the uterus to the lateral walls of the pelvis. Together with the uterus they form a septum across the female pelvis, dividing that cavity into two portions. In the anterior part is contained the bladder, in the posterior part the rectum, and in certain conditions some coils of the small intestine and a part of the sigmoid colon. Between the two layers of each broad ligament are contained 1. The uterine tube superiorly, 2. The round ligament of the uterus, 3. The ovary and its ligament, 4. The epiophoron and paraophoron, 5. Connective tissue, 6. Unstriped muscular fibers, and 7. Blood vessels and nerves. The portion of the broad ligament which stretches from the uterine tube to the level of the ovary is known by the name of the mesosalpinx. Between the fimbriated extremity of the tube and the lower attachment of the broad ligament is a concave rounded margin called the infundibulopelvic ligament. The round ligaments, ligamentum teres uteri, are two flattened bands between 10 and 12 centimeters in length, situated between the layers of the broad ligament in front of and below the uterine tubes. Commencing on either side at the lateral angle of the uterus, this ligament is directed forward, upward, and lateralward over the external iliac vessels. It then passes through the abdominal inguinal ring and along the inguinal canal to the labium majus, in which it becomes lost. The round ligaments consist principally of muscular tissue, prolonged from the uterus, also of some fibrous and areolar tissue, besides blood vessels, lymphatics, and nerves, enclosed in a duplicature of peritoneum, which, in the fetus, is prolonged in the form of a tubular process for a short distance into the inguinal canal. This process is called the canal of Nuck. It is generally obliterated in the adult, but sometimes remains pervious even in advanced life. It is analogous to the saccus vaginalis, which precedes the descent of the testis. In addition to the ligaments just described, there is a band named the ligamentum transversalis cali, Mackenrot, on each side of the cervix uteri. It is attached to the side of the cervix uteri and to the vault and lateral fornix of the vagina, and is continuous externally with the fibrous tissue which surrounds the pelvic blood vessels. The form, size, and situation of the uterus vary at different periods of life and under different circumstances. In the fetus, the uterus is contained in the abdominal cavity, projecting beyond the superior aperture of the pelvis. The cervix is considerably larger than the body. At puberty, the uterus is piriform in shape and weighs from 14 to 17 grams. It has descended into the pelvis, the fundus being just below the level of the superior aperture of this cavity. The palmate folds are distinct and extend to the upper part of the cavity of the organ. The position of the uterus in the adult is liable to considerable variation, depending chiefly on the condition of the bladder and rectum. When the bladder is empty, the entire uterus is directed forward, and is at the same time bent on itself at the junction of the body and cervix, so that the body lies upon the bladder. As the latter fills, the uterus gradually becomes more and more erect, until with a fully distended bladder the fundus may be directed backward toward the sacrum. During menstruation the organ is enlarged, more vascular, and its surface is rounder. The external orifice is rounded, its labia swollen, and the lining membrane of the body thickened, softer, and of a darker color. According to Sir J. Williams, at each recurrence of menstruation, a molecular disintegration of the mucous membrane takes place, which leads to its complete removal, only the bases of the glands embedded in the muscle being left. At the cessation of menstruation, a fresh mucous membrane is formed by a proliferation of the remaining structures. During pregnancy, the uterus becomes enormously enlarged, and in the 8th month reaches the epigastric region. The increase in size is partly due to growth of pre-existing muscle, and partly to development of new fibers. After parturition, the uterus nearly regains its usual size, weighing about 42 grams, but its cavity is larger than in the virgin state, its vessels are tortuous, and its muscular layers are more defined. The external orifice is more marked, and its edges present one or more fissures. In old age, the uterus becomes atrophied and paler and denser in texture. A more distinct constriction separates the body and cervix. The internal orifice is frequently, and the external orifice occasionally, obliterated, while the lips almost entirely disappear. Structure. The uterus is composed of 3 coats, an external or serous, a middle or muscular, and an internal or mucus. The serous coat, tunica serosa, is derived from the peritoneum. It invests the fundus and the whole of the intestinal surface of the uterus, but covers the vesical surface only as far as the junction of the body and cervix. In the lower fourth of the intestinal surface, the peritoneum, though covering the uterus, is not closely connected with it, being separated from it by a layer of loose cellular tissue and some large veins. The muscular coat, tunica muscularis, forms the chief bulk of the substance of the uterus. In the virgin it is dense, firm, of a grayish color, and cuts almost like cartilage. It is thick opposite the middle of the body and fundus, and thin at the orifices of the uterine tubes. It consists of bundles of unstriped muscular fibers, disposed in layers, intermixed with areolar tissue, blood vessels, lymphatic vessels, and nerves. The layers are 3 in number: external, middle, and internal. The external and middle layers constitute the muscular coat proper, while the inner layer is a greatly hypertrophied muscularis mucosae. During pregnancy, the muscular tissue becomes more prominently developed, the fibers being greatly enlarged. The external layer, placed beneath the peritoneum, is disposed as a thin plane on the vesical and intestinal surfaces. It consists of fibers which pass transversely across the fundus, and, converging at each lateral angle of the uterus, are continued on to the uterine tube, the round ligament, and the ligament of the ovary, some passing at each side into the broad ligament, and others running backward from the cervix into the sacro-uterine ligaments. The middle layer of fibers presents no regularity in its arrangement, being disposed longitudinally, obliquely, and transversely. It contains more blood vessels than either of the other 2 layers. The internal or deep layer consists of circular fibers arranged in the form of 2 hollow cones, the apices of which surround the orifices of the uterine tubes, their bases intermingling with one another on the middle of the body of the uterus. At the internal orifice, these circular fibers form a distinct sphincter. The mucous membrane, tunica mucosa, is smooth, and closely adherent to the subjacent tissue. It is continuous through the fimbriated extremity of the uterine tubes with the peritoneum, and through the external uterine orifice with the lining of the vagina. In the body of the uterus, the mucous membrane is smooth, soft, of a pale red color, lined by columnar ciliated epithelium, and presents, when viewed with a lens, the orifices of numerous tubular follicles arranged perpendicularly to the surface. The structure of the corium differs from that of ordinary mucous membranes, and consists of an embryonic nucleated and highly cellular form of connective tissue in which run numerous large lymphatics. In it are the tube-like uterine glands, lined by ciliated columnar epithelium. They are of small size in the unimpregnated uterus, but shortly after impregnation become enlarged and elongated, presenting a contorted or waved appearance. In the cervix, the mucous membrane is sharply differentiated from that of the uterine cavity. It is thrown into numerous oblique ridges, which diverge from an anterior and posterior longitudinal raphe. In the upper 2/3 of the canal, the mucous membrane is provided with numerous deep glandular follicles, which secrete a clear, viscid alkaline mucus. And in addition, extending through the whole length of the canal, is a variable number of little cysts, presumably follicles which have become occluded and distended with retained secretion. They are called the ovula nabothi. The mucous membrane covering the lower half of the cervical canal presents numerous papillae. The epithelium of the upper two-thirds is cylindrical and ciliated, but below this it loses its cilia, and gradually changes to stratified squamous epithelium close to the external orifice. On the vaginal surface of the cervix, the epithelium is similar to that lining the vagina, that is, stratified squamous. Vessels and nerves. The arteries of the uterus are the uterine from the hypogastric and the ovarian from the abdominal aorta. They are remarkable for their tortuous course in the substance of the organ and for their frequent anastomoses. The termination of the ovarian artery meets that of the uterine artery and forms an anastomotic trunk from which branches are given off to supply the uterus, their disposition being circular. The veins are of large size and correspond with the arteries. They end in the uterine plexuses. In the impregnated uterus, the arteries carry the blood to, and the veins convey it away from, the intervillous space of the placenta. The lymphatics are described on page 714. The nerves are derived from the hypogastric and ovarian plexuses, and from the third and fourth sacral nerves.
The vagina. The vagina extends from the vestibule to the uterus, and is situated behind the bladder and in front of the rectum. It is directed upward and backward, its axis forming with that of the uterus an angle of over 90 degrees, opening forward. Its walls are ordinarily in contact, and the usual shape of its lower part on transverse section is that of an H, the transverse limb being slightly curved forward or backward, while the lateral limbs are somewhat convex towards the median line. Its middle part has the appearance of a transverse slit. Its length is 6 to 7.5 centimeters along its anterior wall and 9 centimeters along its posterior wall. It is constricted at its commencement, dilated in the middle, and narrowed near its uterine extremity. It surrounds the vaginal portion of the cervix uteri, a short distance from the external orifice of the uterus, its attachment extending higher up on the posterior than on the anterior wall of the uterus. To the recess behind the cervix the term posterior fornix is applied, while the smaller recesses in front and at the sides are called the anterior and lateral fornices. Relations. The anterior surface of the vagina is in relation with the fundus of the bladder and with the urethra. Its posterior surface is separated from the rectum by the recto-uterine excavation in its upper fourth and by the rectovesical fascia in its middle 2/4. The lower fourth is separated from the anal canal by the perineal body. Its sides are enclosed between the levatores ani muscles. As the terminal portions of the ureters pass forward and medialward to reach the fundus of the bladder, they run close to the lateral fornices of the vagina, and as they enter the bladder are slightly in front of the anterior fornix. Structure. The vagina consists of an internal mucous lining and a muscular coat separated by a layer of erectile tissue. The mucous membrane, tunica mucosa, is continuous above with that lining the uterus. Its inner surface presents two longitudinal ridges, one on its anterior and one on its posterior wall. These ridges are called the columns of the vagina, and from them numerous transverse ridges or rugae extend outward on either side. These rugae are divided by furrows of variable depth, giving to the mucous membrane the appearance of being studded over with conical projections or papillae. They are most numerous near the orifice of the vagina, especially before parturition. The epithelium covering the mucous membrane is of the stratified squamous variety. The submucous tissue is very loose and contains numerous large veins, which by their anastomoses form a plexus together with smooth muscular fibers derived from the muscular coat. It is regarded by Gussenbauer as an erectile tissue. It contains a number of mucous crypts, but no true glands. The muscular coat, tunica muscularis, consists of two layers, an external longitudinal, which is by far the stronger, and an internal circular layer. The longitudinal fibers are continuous with the superficial muscular fibers of the uterus. The strongest fasciculi are those attached to the rectovesical fascia on either side. The two layers are not distinctly separable from each other, but are connected by oblique decussating fasciculi, which pass from the one layer to the other. In addition to this, the vagina at its lower end is surrounded by a band of striped muscular fibers, the bulbocavernosus. External to the muscular coat is a layer of connective tissue containing a large plexus of blood vessels. The erectile tissue consists of a layer of loose connective tissue situated between the mucous membrane and the muscular coat. Embedded in it is a plexus of large veins and numerous bundles of unstriped muscular fibers derived from the circular muscular layer. The arrangement of the veins is similar to that found in other erectile tissues. The external organs. Partes genitales externae muliebris. The external genital organs of the female are the mons pubis, the labia majora et minora pudendi, the clitoris, the vestibule of the vagina, the bulb of the vestibule, and the greater vestibular glands. The term pudendum or vulva, as generally applied, includes all these parts. The mons pubis, commissura labiorum anterior, mons veneris, the rounded eminence in front of the pubic symphysis, is formed by a collection of fatty tissue beneath the integument. It becomes covered with hair at the time of puberty. The labia majora pudendi, are two prominent longitudinal cutaneous folds which extend downward and backward from the mons pubis and form the lateral boundaries of a fissure or cleft, the pudendal cleft or rima, into which the vagina and urethra open. Each labium has two surfaces, an outer, pigmented and covered with strong, crisp hairs, and an inner, smooth and beset with large sebaceous follicles. Between the two there is considerable quantity of areolar tissue, fat, and a tissue resembling the dartos tunic of the scrotum, besides vessels, nerves, and glands. The labia are thicker in front, where they form by their meeting the anterior labial commissure. Posteriorly, they are not really joined, but appear to become lost in the neighbouring integument, ending close to and nearly parallel with each other. Together with the connecting skin between them, they form the posterior labial commissure or posterior boundary of the pudendum. The interval between the posterior commissure and the anus, from 2.5 to 3 cm in length, constitutes the perineum. The labia majora correspond to the scrotum in the male. The labia minora pudendi, nymphae, are two small cutaneous folds situated between the labia majora and extending from the clitoris obliquely downward, lateralward, and backward for about 4 cm on either side of the orifice of the vagina, between which and the labia majora they end. In the virgin, the posterior ends of the labia minora are usually joined across the middle line by a fold of skin named the frenulum of the labia or fourchette. Anteriorly, each labium minus divides into two portions. The upper division passes above the clitoris to meet its fellow of the opposite side, forming a fold which overhangs the glans clitoridis, and is named the preputium clitoridis. The lower division passes beneath the clitoris and becomes united to its undersurface, forming, with its fellow of the opposite side, the frenulum of the clitoris. On the opposed surfaces of the labia minora are numerous sebaceous follicles. The clitoris is an erectile structure, homologous with the penis. It is situated beneath the anterior labial commissure, partially hidden between the anterior ends of the labia minora. It consists of two corpora cavernosa, composed of erectile tissue enclosed in a dense layer of fibrous membrane, united together along their medial surfaces by an incomplete fibrous pectiniform septum. Each corpus is connected to the rami of the pubis and ischium by a crus. The free extremity, glans clitoridis, is a small rounded tubercle consisting of spongy erectile tissue and highly sensitive. The clitoris is provided, like the penis, with a suspensory ligament and with two small muscles, the ischiocavernosi, which are inserted into the crura of the clitoris. The vestibule, vestibulum vaginae. The cleft between the labia minora and behind the glans clitoridis is named the vestibule of the vagina. In it are seen the urethral and vaginal orifices and the openings of the ducts of the greater vestibular glands. The external urethral orifice, orificium urethrae externum, urinary meatus, is placed about 2.5 centimeters behind the glans clitoridis and immediately in front of that of the vagina. It usually assumes the form of a short sagittal cleft with slightly raised margins. The vaginal orifice is a median slit below and behind the opening of the urethra. Its size varies inversely with that of the hymen. The hymen is a thin fold of mucous membrane situated at the orifice of the vagina. The inner edges of the fold are normally in contact with each other, and the vaginal orifice appears as a cleft between them. The hymen varies much in shape. When stretched, its commonest form is that of a ring, generally broadest posteriorly. Sometimes it is represented by a semilunar fold, with its concave margin turned towards the pubes. Occasionally it is cribriform, or its free margin forms a membranous fringe. It may be entirely absent, or may form a complete septum across the lower end of the vagina. The latter condition is known as an imperforate hymen. It may persist after copulation, so that its presence cannot be considered as a sign of virginity. When the hymen has been ruptured, small rounded elevations, known as the carunculi hymenales, are found at its remains. Between the hymen and the frenulum of the labia is a shallow depression named the navicular fossa. The bulb of the vestibule, bulbus vestibuli, vaginal bulb, is the homologue of the bulb and adjoining part of the corpus cavernosum urethrae of the male, and consists of two elongated masses of erectile tissue placed one on either side of the vaginal orifice and united to each other in front by a narrow median band termed the pars intermedia. Each lateral mass measures a little over 2.5 centimeters in length. Their posterior ends are expanded and are in contact with the greater vestibular glands. Their anterior ends are tapered and joined to one another by the pars intermedia. Their deep surfaces are in contact with the inferior fascia of the urogenital diaphragm. Superficially, they are covered by the bulbo cavernosus. The greater vestibular glands, glandulae vestibularis major, Bartolini, Bartolin's glands, are the homologues of the bulbo-urethral glands in the male. They consist of two small, roundish bodies of a reddish-yellow colour, situated one on either side of the vaginal orifice, in contact with the posterior end of each lateral mass of the bulb of the vestibule. Each gland opens by means of a duct, about 2 centimeters long, immediately lateral to the hymen, in the groove between it and the labium minus.
Mammary glands, breast. The mammae secrete milk and are accessory glands of the generative system. They exist in the male as well as in the female, but in the former only in the rudimentary state, unless their growth is excited by peculiar circumstances. In the female they are two large hemispherical eminences lying within the superficial fascia and situated on the front and sides of the chest. Each extends from the second rib above to the sixth rib below, and from the side of the sternum to near the mid-axillary line. Their weight and dimensions differ at different periods of life and in different individuals. Before puberty they are of small size, but enlarge as the generative organs become more completely developed. They increase during pregnancy and especially after delivery, and become atrophied in old age. The left mamma is generally a little larger than the right. The deep surface of each is nearly circular, flattened, or slightly concave, and has its long diameter directed upward and lateralward toward the axilla. It is separated from the fascia covering the pectoralis major, serratus anterior, and obliquus externus abdominis by loose connective tissue. The subcutaneous surface of the mamma is convex and presents just below the center a small conical prominence, the papilla. The mammary papilla or nipple, papilla mammae, is a cylindrical or conical eminence situated above the level of the fourth intercostal space. It is capable of undergoing a sort of erection from mechanical excitement, a change mainly due to the contractions of its muscular fibers. It is of a pink or brownish hue, its surface wrinkled and provided with secondary papillae, and it is perforated by from 15 to 20 orifices, the apertures of the lactiferous ducts. The base of the mammary papilla is surrounded by an areola. In the virgin, the areola is of a delicate rosy hue. About the second month after impregnation, it enlarges and acquires a darker tinge, and as pregnancy advances, it may assume a dark brown or even black color. This color diminishes as soon as lactation is over, but is never entirely lost throughout life. These changes in the color of the areola are of importance in forming a conclusion in a case of suspected first pregnancy. Near the base of the papilla and upon the surface of the areola are numerous large sebaceous glands, the areolar glands, which become much enlarged during lactation and present the appearance of small tubercles beneath the skin. These glands secrete a peculiar fatty substance which serves as a protection to the integument of the papilla during the act of sucking. The mammillary papilla consists of numerous vessels, intermixed with plain muscular fibers, which are principally arranged in a circular manner around the base, some few fibers radiating from base to apex. Development. The mamma is developed partly from mesoderm and partly from ectoderm, its blood vessels and connective tissues being derived from the former, its cellular elements from the latter. Its first rudiment is seen about the third month, in the form of a number of small inward projections of the ectoderm, which invade the mesoderm. From these secondary tracts of cellular elements radiate and subsequently give rise to the epithelium of the glandular follicles and ducts. The development of the follicles, however, remains imperfect, except in the parous female. Structure. The mamma consists of gland tissue, of fibrous tissue connecting its lobes, and of fatty tissue in the intervals between the lobes. The gland tissue, when freed from fibrous tissue and fat, is of a pale reddish color, firm in texture, flattened from before backward, and thicker in the center than in the circumference. The subcutaneous surface of the mamma presents numerous irregular processes which project toward the skin and are joined to it by bands of connective tissue. It consists of numerous lobes, and these are composed of lobules connected together by areolar tissue, blood vessels, and ducts. The smallest lobules consist of a cluster of rounded alveoli, which open into the smallest branches of the lactiferous ducts. These ducts unite to form larger ducts, and these end in a single canal, corresponding with one of the chief subdivisions of the gland. The number of excretory ducts varies from 15 to 20. They are termed the tubuli lactiferi. They converge toward the areola, beneath which they form dilations of ampullae, which serve as reservoirs for the milk, and, in the base of the papillae, become contracted and pursue a straight course to its summit, perforating it by separate orifices considerably narrower than the ducts themselves. These ducts are composed of areolar tissue, containing longitudinal and transverse elastic fibers. Muscular fibers are entirely absent. They are lined by columnar epithelium resting on a basement membrane. The epithelium of the mamma differs according to the state of activity of the organ. In the gland of a woman who is not pregnant or suckling, the alveoli are very small and solid, being filled with a mass of granular polyhedral cells. During pregnancy, the alveoli change, and the cells undergo rapid multiplication. At the commencement of lactation, the cells in the center of the alveolus undergo fatty degeneration and are eliminated in the first milk, as colostrum corpuscles. The peripheral cells of the alveolus remains, and form a single layer of granular, short columnar cells, with spherical nuclei, lining the basement membrane. The cells, during the state of activity of the gland, are capable of forming in their interior oil globules, which are then ejected into the lumen of the alveolus and constitute the milk globules. When the acini are distended by the accumulation of the secretion, the lining epithelium becomes flattened. The fibrous tissue invests the entire surface of the mamma and sends down septa between its lobes, connecting them together. The fatty tissue covers the surface of the gland and occupies the interval between its lobes. It usually exists in considerable abundance and determines the form and size of the gland. There is no fat immediately beneath the areola and papilla. Vessels and nerves. The arteries supplying the mammae are derived from the thoracic branches of the axillary, the intercostals, and the internal mammary. The veins described an anastomotic circle around the base of the papillae, called by Haller the circulus venosus. From this large branches transmit the blood to the circumference of the gland, and end in the axillary and internal mammary veins. The lymphatics are described on page 715. The nerves are derived from the anterior and lateral cutaneous branches of the 4th, 5th, and 6th thoracic nerves.
The ductless glands. There are certain organs which are very similar to secreting glands, but differ from them in one essential particular. That is, they do not possess any ducts by which their secretion is discharged. These organs are known as ductless glands. They are capable of internal secretion, that is to say, of forming, from materials brought to them in the blood, substances which have a certain influence upon the nutritive and other changes going on in the body. This secretion is carried into the bloodstream, either directly by the veins or indirectly through the medium of the lymphatics. These glands include the thyroid, the parathyroids and the thymus, the pituitary body and the pineal body, the chromophil and cortical systems, to which belong the suprarenals, the paraganglia and aortic glands, the glomus caroticum, and perhaps the glomus coccygeum. The spleen is usually included in this list, and sometimes the lymph and hemolymph nodes described with the lymphatic system. Other glands, as the liver, pancreas, and sexual glands, give off internal secretions, as do the gastric and intestinal mucous membranes. The thyroid gland, glandula thyroidea, thyroid body. The thyroid gland is a highly vascular organ situated at the front and sides of the neck. It consists of right and left lobes connected across the middle line by a narrow portion, the isthmus. Its weight is somewhat variable, but is usually about 30 grams. It is slightly heavier in the female, in whom it becomes enlarged during menstruation and pregnancy. The lobes, lobuli glandulae thyroideae, are conical in shape, the apex of each being directed upward and lateralward, as far as the junction of the middle with the lower third of the thyroid cartilage. The base looks downward, and is on a level with the 5th or 6th tracheal ring. Each lobe is about 5 centimeters long. Its greatest width is about 3 centimeters, and its thickness about 2 centimeters. The lateral or superficial surface is convex, and covered by the skin, the superficial and deep fascia, the sternocleidomastoideus, the superior belly of the omohyoideus, the sternohyoideus and sternothyroideus, and beneath the last muscle by the pretracheal layer of the deep fascia, which forms a capsule for the gland. The deep or medial surface is molded over the underlying structures. These are the thyroid and cricoid cartilages, the trachea, the constrictor pharyngeus inferior and posterior part of the cricothyroideus, the esophagus, particularly on the left side of the neck, the superior and inferior thyroid arteries, and the recurrent nerves. The anterior border is thin and inclines obliquely from above downward toward the middle line of the neck, while the posterior border is thick and overlaps the common carotid artery and, as a rule, the parathyroids. The isthmus, isthmus glandulae thyroidea, connects together the lower thirds of the lobes. It measures about 1.25 centimeters in breadth, and the same in depth, and usually covers the 2nd and 3rd rings of the trachea. Its situation and size present, however, many variations. In the middle line of the neck it is covered by the skin and fascia, and close to the middle line, on either side, by the sternothyroideus. Across its upper border runs an anastomotic branch uniting the 2 superior thyroid arteries. At its lower border are the inferior thyroid veins. Sometimes the isthmus is altogether wanting. A third lobe, of conical shape, called the pyramidal lobe, frequently arises from the upper part of the isthmus, or from the adjacent portion of either lobe, but most commonly the left, and ascends as far as the hyoid bone. It is occasionally quite detached, or may be divided into 2 or more parts. A fibrous or muscular band is sometimes found attached above to the body of the hyoid bone, and below to the isthmus of the gland, or its pyramidal lobe. When muscular, it is termed the levator glandulae thyroideae. Small detached portions of thyroid tissue are sometimes found in the vicinity of the lateral lobes or above the isthmus. They are called accessory thyroid glands, glandulae thyroideae accessorii. Development. The thyroid gland is developed from a median diverticulum, which appears about the 4th week on the summit of the tuberculum impar, but later is found in the furrow immediately behind the tuberculum. It grows downward and backward as a tubular duct, which bifurcates and subsequently subdivides into a series of cellular cords, from which the isthmus and lateral lobes of the thyroid gland are developed. The ultimobranchial bodies from the 5th pharyngeal pouches are enveloped by the lateral lobes of the thyroid gland. They undergo atrophy and do not form true thyroid tissue. The connection of the diverticulum with the pharynx is termed the thyroglossal duct. Its continuity is subsequently interrupted, and it undergoes degeneration, its upper end being represented by the foramen cecum of the tongue, and its lower by the pyramidal lobe of the thyroid gland. Structure. The thyroid gland is invested by a thin capsule of connective tissue, which projects into its substance, and imperfectly divides it into masses of irregular form and size. When the organ is cut into, it is of a brownish-red color, and is seen to be made up of a number of closed vesicles containing a yellow, glairy fluid, and separated from each other by intermediate connective tissue. The vesicles of the thyroid of the adult animal are generally closed spherical sacs, but in some young animals, for example young dogs, the vesicles are more or less tubular and branched. This appearance is supposed to be due to the mode of growth of the gland, and merely indicates that an increase in the number of vesicles is taking place. Each vesicle is lined by a single layer of cubical epithelium. There does not appear to be a basement membrane, so that the epithelial cells are in direct contact with the connective tissue reticulum which supports the acini. The vesicles are of various sizes and shapes, and contain as a normal product a viscid, homogeneous, semifluid, slightly yellowish colloid material. Red corpuscles are found in it in various stages of disintegration and decolorization, the yellow tinge being probably due to the hemoglobin, which is thus set free from the colored corpuscles. The colloid material contains an iodine compound, iodothyron, and is readily stained by eosin. According to Bensley, the thyroid gland prepares and secretes into the vascular channels a substance formed under normal conditions in the outer pole of the cell and excreted from it directly without passing by the indirect route through the follicular cavity. In addition to this direct mode of secretion, there is an indirect mode, which consists in the condensation of the secretion into the form of droplets having high content of solids, and the extension of these droplets into the follicular cavity. These droplets are formed in the same zone of the cell as that in which the primary or direct secretion is formed. This internal secretion of the thyroid is supposed to contain a specific hormone which acts as a chemical stimulus to other tissues, increasing their metabolism. Vessels and nerves. The arteries supplying the thyroid gland are the superior and inferior thyroids, and sometimes an additional branch, thyroidea ema, from the innominate artery or the arch of the aorta, which ascends upon the front of the trachea. The arteries are remarkable for their large size and frequent anastomoses. The veins form a plexus on the surface of the gland and on the front of the trachea. From this plexus the superior, middle, and inferior thyroid veins arise. The superior and middle end in the internal jugular, the inferior in the innominate vein. The capillary blood vessels form a dense plexus in the connective tissue around the vesicles, between the epithelium of the vesicles and the endothelium of the lymphatics, which surround a greater or smaller part of the circumference of the vesicle. The lymphatic vessels run in the interlobular connective tissue, not uncommonly surrounding the arteries which they accompany, and communicate with the network in the capsule of the gland. They may contain colloid material. They end in the thoracic and right lymphatic trunks. The nerves are derived from the middle and inferior cervical ganglia of the sympathetic. The parathyroid glands. The parathyroid glands are small brownish-red bodies situated, as a rule, between the posterior borders of the lateral lobes of the thyroid gland and its capsule. They differ from it in structure, being composed of masses of cells arranged in a more or less columnar fashion, with numerous intervening capillaries. They measure, on an average, about 6 mm in length, and from 3 to 4 mm in breadth, and usually present the appearance of flattened oval discs. They are divided, according to their situation, into superior and inferior. The superior, usually 2 in number, are the more constant in position, and are situated, one on either side, at the level of the lower border of the cricoid cartilage, behind the junction of the pharynx and esophagus. The inferior, also usually 2 in number, may be applied to the lower edge of the lateral lobes, or placed at some little distance below the thyroid glands, or found in relation to one of the inferior thyroid veins. In man they number 4 as a rule. Fewer than 4 were found in less than 1% of over 1,000 persons, papyri, but more than 4 in over 33% of 122 bodies examined by Civelleri. In addition, numerous minute islands of parathyroid tissue may be found scattered in the connective tissue and fat of the neck around the parathyroid glands proper, and quite distinct from them. Development. The parathyroid bodies are developed as outgrowths from the 3rd and 4th branchial pouches. A pair of diverticula arise from the 5th branchial pouch and formed what are termed the ultimobranchial bodies. These fuse with the thyroid gland, but probably contribute no true thyroid tissue. Structure. Microscopically, the parathyroids consist of intercommunicating columns of cells supported by connective tissue containing a rich supply of blood capillaries. Most of the cells are clear, but some, larger in size, contain oxyphil granules. Vesicles containing colloid have been described as occurring in the parathyroid, but the observation has not been confirmed. No doubt the parathyroid glands produce an internal secretion essential to the well-being of the human economy, but it is still a matter of dispute what symptoms of disease are produced by their removal and suppression of their secretion. Papyri believes that they show signs of exceptional activity during pregnancy, and that parathyroid insufficiency is a main factor in the production of tetany in infants and adults, of eclampsia, and of certain sorts of fits. It is probable that the tetany following parathyroidectomy is due to the accumulation of ammonium carbonate, and Kendall has suggested that the function of the parathyroid is to convert ammonium carbonate into urea.
The thymus. The thymus is a temporary organ attaining its largest size at the time of puberty, Hamar. When it ceases to grow, gradually dwindles and almost disappears. If examined when its growth is most active, it will be found to consist of 2 lateral lobes placed in close contact along the middle line, situated partly in the thorax, partly in the neck, and extending from the 4th costal cartilage upward, as high as the lower border of the thyroid gland. It is covered by the sternum, and by the origins of the sternohyoidea and the sternothyroidea. Below it rests upon the pericardium, being separated from the aortic arch and great vessels by a layer of fascia. In the neck it lies on the front and sides of the trachea, being the sternohyoidea and sternothyroidea. The 2 lobes generally differ in size. They are occasionally united, so as to form a single mass, and sometimes separated by an intermediate lobe. The thymus is of a pinkish-gray color, soft and lobulated on its surfaces. It is about 5 centimeters in length, 4 centimeters in breadth below, and about 6 millimeters in thickness. At birth it weighs about 15 grams. At puberty its weight is about 35 grams. After this it gradually decreases to 25 grams at 25 years, and less than 15 grams at 60, and about 6 grams at 70 years. Development. The thymus appears in the form of 2 flask-shaped entodermal diverticula, which arise, one on either side, from the 3rd brachial pouch, and extend lateralward and backward into the surrounding mesoderm in front of the ventral aorta. Here they meet and become joined to one another by connective tissue, but there is never any fusion of the thymus tissue proper. The pharyngeal opening of each diverticulum is soon obliterated, but the neck of the flask persists for some time as a cellular cord. By further proliferation of the cells lining the flask, buds of cells are formed, which become surrounded and isolated by invading mesoderm. In the latter, numerous lymphoid cells make their appearance, and are aggregated to form lymphoid follicles. These lymphoid cells are probably derivatives of the entodermal cells, which line original diverticula and their subdivisions. Additional portions of thymus tissues are sometimes developed from the 4th branchial pouches. Thymus continues to grow until the time of puberty and then begins to atrophy. Structure. Each lateral lobe is composed of numerous lobules, held together by delicate areolar tissue, the entire gland being enclosed in an investing capsule of similar but denser structure. The primary lobules vary in size from that of a pin's head to that of a small pea, and are made up of a number of small nodules or follicles, which are irregular in shape and are more or less fused together, especially toward the interior of the gland. Each follicle is from 1 to 2 millimeters in diameter and consists of a medullary and a cortical portion. These differ in many essential particulars from each other. The cortical portion is mainly composed of lymphoid cells, supported by a network of finely branched cells, which is continuous with a similar network in the medullary portion. The network forms an adventitia to the blood vessels. In the medullary portion, the reticulum is coarser than the cortex. The lymphoid cells are relatively fewer in number, and there are found peculiar nest-like bodies, the concentric corpuscles of Hassel. These concentric corpuscles are composed of a central mass consisting of one or more granular cells and of a capsule which is formed of epithelioid cells. They are the remains of the epithelial tubes which grow out from the third branchial pouches of the embryo to form the thymus. Each follicle is surrounded by a vascular plexus, from which vessels pass into the interior and radiate from the periphery toward the center, forming a second zone just within the margin of the medullary portion. In the center of the medullary portion there are very few vessels, and they are of minute size. Watney has made the important observation that hemoglobin is found in the thymus, either in cysts or in cells situated near to or forming part of the concentric corpuscles. This hemoglobin occurs as granules or as circular masses exactly resembling colored blood corpuscles. He has also discovered in the lymph issuing from the thymus similar cells to those found in the gland, and like them containing hemoglobin in the form of either granules or masses. From these facts he arrives at the conclusion that the gland is one source of the colored blood corpuscles. More recently, Schaefer has observed actual nucleated red blood corpuscles in the thymus. The function of the thymus is obscure. It seems to furnish, during the period of growth, an internal secretion concerned with some phases of body metabolism, especially that of the sexual glands. Vessels and nerves. The arteries supplying the thymus are derived from the internal mammary and from the superior inferior thyroids. The veins end in the left innominate vein and in the thyroid veins. The lymphatics are described on page 698. The nerves are exceedingly minute. They are derived from the vagi and sympathetic. Branches of the descendens hypoglossy and phrenic reach the investing capsule, but do not penetrate into the substance of the gland.
The hypophysis cerebri. The hypophysis, pituitary body, is a small reddish-gray body, about 1 centimeter in diameter, attached to the end of the infundibulum of the brain and resting in the hypophyseal fossa. The hypophysis consists of an anterior and a posterior lobe, which differ from one another in their mode of development and in their structure. The anterior lobe is the larger and is somewhat kidney-shaped, the concavity being directed backward and embracing the posterior lobe. It consists of a pars anterior and a pars intermedia, separated from each other by a narrow cleft, the remnant of the pouch or diverticulum. The pars anterior is extremely vascular and consists of epithelial cells of varying size and shape, arranged in cord-like trabeculae or alveoli, and separated by large, thin-walled blood vessels. The pars intermedia is a thin lamina closely applied to the body and neck of the posterior lobe and extending onto the neighboring parts of the brain. It contains few blood vessels and consists of finely granular cells between which are small masses of colloid material. The pars intermedia, in spite of the fact that it arises in common with the pars anterior from the ectoderm of the primitive buccal cavity, is often considered as a part of the posterior lobe which arises from the floor of the third ventricle of the brain. Although of nervous origin, the posterior lobe contains no nerve cells or fibers. It consists of neuroglia cells and fibers, and is invaded by columns which grow into it from the pars intermedia. Embedded in it are large quantities of a colloid substance histologically similar to that found in the thyroid gland. In certain of the lower vertebrates, for example fishes, nervous structures are present, and the lobe is of large size. From the pars intermedia, a substance, no doubt an internal secretion, causes constriction of the blood vessels with rise of arterial blood pressure. This substance seems to have a stimulating effect on most of the smooth muscles, acting directly upon the muscle causing contraction. It also increases the secretion of the urine, of the mammary glands when in functional activity, and of the cerebrospinal fluid. Extracts of this lobe also influence the general metabolism of the carbohydrates by accelerating the process of glycogenolysis in the liver. The pars anterior exercises a stimulating effect on the growth of the skeleton and probably on connective tissues in general. Enlargement of the hypophysis and of the cavity of the sella turcica are found in the rare disease acromegaly, which is characterized by a gradual enlargement of the face, hands, and feet, with headache and often a peculiar type of blindness. This blindness is due to the pressure of the enlarging hypophysis on the optic chiasma. Development of the hypophysis cerebri. This in the adult consists of a large anterior, consisting of the pars anterior and the pars intermedia, and a small posterior lobe. The former is derived from the ectoderm of the stomadeum, the latter from the floor of the forebrain. About the 4th week there appears a pouch-like diverticulum of the ectodermal lining of the roof of the stomadeum. This diverticulum, pouch of Rathke, is the rudiment of the anterior lobe of the hypophysis. It extends upward in front of the cephalic end of the notochord and the remnant of the buccopharyngeal membrane, and comes into contact with the under surface of the forebrain. It is then constricted off to form a closed vesicle, but remains for a time connected to the ectoderm of the stomadeum by a solid cord of cells. Masses of epithelial cells form on either side and in the front wall of the vesicle, and by the growth between these of a stroma from the mesoderm, the development of the anterior lobe is completed. The upwardly directed hypophyseal involution becomes applied to the anterolateral aspect of a downwardly directed diverticulum from the base of the forebrain. This diverticulum constitutes the future infundibulum in the floor of the third ventricle, while its inferior extremity becomes modified to form the posterior lobe of the hypophysis. In some of the lower animals, the posterior lobe contains nerve cells and nerve fibers, but in man and the higher vertebrates, these are replaced by connective tissue. A canal, craniopharyngeal canal, is sometimes found extending from the anterior part of the fossa hypophyseos of the sphenoid bone to the undersurface of the skull, and marks the original position of Rathke's pouch, while at the junction of the septum of the nose with the palate, traces of the stomadeal end are occasionally present. Fraser. The pineal body. The pineal body, epiphysis, is a small reddish-gray body about 8 mm in length, which lies in the depression between the superior colliculi. It is attached to the roof of the third ventricle near its junction with the midbrain. It develops as an outgrowth from the third ventricle of the brain. In early life it has a glandular structure which reaches its greatest development at about the 7th year. Later, especially after puberty, the glandular tissue gradually disappears and is replaced by connective tissue. Structure. The pineal body is destitute of nervous substance, and consists of follicles lined by epithelium and enveloped by connective tissue. These follicles contain a variable quantity of gritty material composed of phosphate and carbonate of calcium, phosphate of magnesium and ammonia, and a little animal matter. It contains a substance which, if injected intravenously, causes fall of blood pressure. It seems probable that the gland furnishes an internal secretion in children that inhibits the development of the reproductive glands, since the invasion of the gland in children by pathological growths which practically destroy the glandular tissue results in accelerated development of the sexual organs, increased growth of the skeleton, and precocious mentality. The chromophil and cortical systems. Chromophil or chromaffin cells, so called because they stain yellow or brownish with chromium salts, are associated with the ganglia of the sympathetic nervous system. Development. They arise in common with the sympathetic cells from the neural crest, and are therefore ectodermal in origin. The chromophil and sympathetic cells are indistinguishable from one another at the time of their migration from the spinal ganglia to the regions occupied in the adult. Differentiation of chromophil cells begins in embryos about 18 millimeters in length, but is not complete until about birth. The chromophiloblasts increase in size more than the sympathoblasts and stain less intensely with ordinary dyes. Later, the chrome reaction develops. The aortic bodies differentiate first and are prominent in 20 millimeter embryos. The paraganglia of the sympathetic plexuses differentiate next and last of all the paraganglia of the sympathetic trunk. The carotid body is completely differentiated in 30 millimeter embryos. After birth, the chromophil organs degenerate, but the paraganglia can be recognized with the microscope in sites ordinarily occupied by them. The paraganglia are small groups of chromophil cells connected with the ganglia of the sympathetic trunk and the ganglia of the celiac, renal, suprarenal, aortic, and hypogastric plexuses. They are sometimes found in connection with the ganglia of other sympathetic plexuses. None have been found with the sympathetic ganglia associated with the branches of the trigeminal nerve. The aortic glands, or bodies, are the largest of these groups of chromophil cells, and measure, in the newborn, about 1 centimeter in length. They lie one on either side of the aorta in the region of the inferior mesenteric artery. They decrease in size with age and after puberty are only visible with the microscope. About 40 they disappear entirely. Other groups of chromophil cells have been found associated with the sympathetic plexuses of the abdomen independently of the ganglia. The medullary portions of the suprarenal glands and the glomus caroticum belong to the chromophil system. The suprarenal glands, glandulae suprarenalis, adrenal capsule. The suprarenal glands are two small flattened bodies of a yellowish color, situated at the back part of the abdomen, behind the peritoneum, and immediately above and in front of the upper end of each kidney, hence their name. The right one is somewhat triangular in shape, bearing a resemblance to a cocked hat. The left is more semilunar, usually larger, and placed at a higher level than the right. They vary in size in different individuals, being sometimes so small as to be scarcely detected. Their usual size is from 3 to 5 centimeters in length, rather less in width, and from 4 to 6 millimeters in thickness. Their average weight is from 1.5 to 2.5 grams each. Development. Each suprarenal gland consists of a cortical portion derived from the coelomic epithelium and a medullary portion originally composed of sympathochromaffin tissue. The cortical portion is first recognizable about the beginning of the 4th week as a series of buds from the coelomic cells at the root of the mesentery. Later it becomes completely separated from the coelomic epithelium and forms a suprarenal ridge projecting into the coelom between the mesonephros and the root of the mesentery. Into this cortical portion cells from the neighboring masses of sympathochromaffin tissue migrate along the line of its central vein to reach and form the medullary portion of the gland. Relations. The relations of the suprarenal glands differ on the two sides of the body. The right suprarenal is situated behind the inferior vena cava and right lobe of the liver and in front of the diaphragm and upper end of the right kidney. It is roughly triangular in shape. Its base, directed downward, is in contact with the medial and anterior aspects of the upper end of the right kidney. It presents two surfaces for examination, an anterior and a posterior. The anterior surface looks forward and lateralward, and has two areas, a medial, narrow, and non-peritoneal, which lies behind the inferior vena cava, and a lateral, somewhat triangular, in contact with the liver. The upper part of the latter surface is devoid of peritoneum, and is in relation with the bare area of the liver near its lower and medial angle, while its inferior portion is covered by peritoneum, reflected onto it from the inferior layer of the coronary ligament. Occasionally the duodenum overlaps the inferior portion. A little below the apex, and near the anterior border of the gland, is a short furrow termed the hilum, from which the suprarenal vein emerges to join the inferior vena cava. The posterior surface is divided into upper and lower parts by a curved ridge. The upper, slightly convex, rests upon the diaphragm. The lower, concave, is in contact with the upper end and the adjacent part of the anterior surface of the kidney. The left suprarenal, slightly larger than the right, is crescentic in shape, its concavity being adapted to the medial border of the upper part of the left kidney. It presents a medial border which is convex, and a lateral which is concave. Its upper end is narrow, and its lower rounded. Its anterior surface has two areas, an upper one, covered by the peritoneum of the omental bursa, which separates it from the cardiac end of the stomach, and sometimes from the superior extremity of the spleen, and a lower one, which is in contact with the pancreas and lienal artery, and is therefore not covered by the peritoneum. On the anterior surface, near its lower end, is a furrow or hilum, directed downward and forward, from which the suprarenal vein emerges. Its posterior surface presents a vertical ridge, which divides it into two areas. The lateral area rests on the kidney, the medial and smaller on the left crus of the diaphragm. The surface of the suprarenal gland is surrounded by areolar tissue containing much fat, and closely invested by a thin fibrous capsule, which is difficult to remove on account of the numerous fibrous processes and vessels entering the organ through the furrows on its anterior surface and base. Small accessory suprarenals, glandulae suprarenales accessoriae, are to be found in the connective tissue around the suprarenals. The smaller of these, on section, show a uniform surface, but in some of the larger a distinct medulla can be made out. Structure. On section, the suprarenal gland is seen to consist of two portions, an external or cortical, and an internal or medullary. The former constitutes the chief part of the organ, and is of a deep yellow color. The medullary substance is soft, pulpy, and of a dark red or brown color. The cortical portion, substantia corticalis, consists of a fine connective tissue network in which is embedded the glandular epithelium. The epithelial cells are polyhedral in shape and possess rounded nuclei. Many of the cells contain coarse granules, others lipoid globules. Owing to differences in the arrangement of the cells, three distinct zones can be made out. 1. The zona glomerulosa, situated beneath the capsule, consists of cells arranged in rounded groups, with here and there indications of an alveolar structure. The cells of this zone are very granular and stain deeply. 2. The zona fasciculata, continuous with the zona glomerulosa, is composed of columns of cells arranged in a radial manner. These cells contain finer granules and, in many instances, globules of lipoid material. 3. The zona reticularis, in contact with the medulla, consists of cylindrical masses of cells irregularly arranged. These cells often contain pigment granules which give this zone a darker appearance than the rest of the cortex. The medullary portion, substantia medullaris, is extremely vascular and consists of large chromophil cells arranged in a network. The irregular polyhedral cells have a finely granular cytoplasm that are probably concerned with the secretion of adrenaline. In the meshes of the cellular network are large anastomosing venous sinuses, sinusoids, which are in close relationship with the chromophil or medullary cells. In many places, the endothelial lining of the blood sinuses is in direct contact with the medullary cells. Some authors consider the endothelium absent in places, and here the medullary cells are directly bathed by the blood. This intimate relationship between the chromophil cells and the bloodstream undoubtedly facilitates the discharge of the internal secretion into the blood. There is a loose meshwork of supporting connective tissue containing non-striped muscle fibers. This portion of the gland is richly supplied with non-medullated nerve fibers, and here and there sympathetic ganglia are found. Vessels and nerves. The arteries supplying the suprarenal glands are numerous and of comparatively large size. They are derived from the aorta, the inferior phrenic, and the renal. They subdivide into minute branches previous to entering the cortical part of the gland, where they break up into capillaries, which end in the venous plexus of the medullary portion. The suprarenal vein returns the blood from the medullary venous plexus and receives several branches from the cortical substance. It emerges from the hilum of the gland and on the right side opens into the inferior vena cava. on the left into the renal vein. The lymphatics end in the lumbar glands. The nerves are exceedingly numerous, and are derived from the celiac and renal plexuses, and according to Bergman from the phrenic and vagus nerves. They enter the lower and medial part of the capsule, traverse the cortex, and end around the cells of the medulla. They have numerous small ganglia developed upon them in the medullary portion of the gland. In connection with the development of the medulla from the sympathochromaffin tissue, it is to be noted that this portion of the gland secretes a substance, adrenaline, which has a powerful influence on those muscular tissues which are supplied by sympathetic fibers. Glomus caroticum, carotid glands, carotid bodies. The carotid bodies, 2 in number, are situated one on either side of the neck, behind the common carotid artery at its point of bifurcation into the external and internal carotid trunks. They are reddish-brown in color and oval in shape, the long diameter measuring about 5 millimeters. Each is invested by a fibrous capsule and consists largely of spherical or irregular masses of cells, the masses being more or less isolated from one another by septa, which extend inward from the deep surface of the capsule. The cells are polyhedral in shape, and each contains a large nucleus embedded in finely granular protoplasm, which is stained yellow by chromic salts. Numerous nerve fibers, derived from the sympathetic plexus on the carotid artery, are distributed throughout the organ, and a network of large sinusoidal capillaries ramifies among the cells. Glomus coccygeum, coccygeal gland or body, Luschke's gland. The glomus coccygeum is placed in front of, or immediately below, the tip of the coccyx. It is about 2.5 millimeters in diameter, and is irregularly oval in shape. Several smaller nodules are found around or near the main mass. It consists of irregular masses of round or polyhedral cells, the cells of each mass being grouped around a dilated sinusoidal capillary vessel. Each cell contains a large round or oval nucleus, the protoplasm surrounding which is clear and is not stained by chromic salts.
The spleen. Lion. The spleen is situated principally in the left hypochondriac region, but its superior extremity extends into the epigastric region. It lies between the fundus of the stomach and the diaphragm. It is the largest of the ductless glands, and is of an oblong, flattened form, soft, of very friable consistence, highly vascular, and of a dark purplish color. Development. The spleen appears about the 5th week as a localized thickening of the mesoderm in the dorsal mesogastrium above the tail of the pancreas. With the change in position of the stomach, the spleen is carried to the left, and comes to lie behind the stomach and in contact with the left kidney. The part of the dorsal mesogastrium which intervened between the spleen and the greater curvature of the stomach forms the gastrosplenic ligament. Relations. The diaphragmatic surface, facies diaphragmatica, external or phrenic surface, is convex, smooth, and is directed upward, backward, and to the left, except at its upper end, where it is directed slightly medialward. It is in relation with the undersurface of the diaphragm, which separates it from the 9th, 10th, and 11th ribs on the left side, and the intervening lower border of the left lung and pleura. The visceral surface is divided by a ridge into an anterior or gastric and a posterior or renal portion. The gastric surface, facies gastrica, which is directed forward, upward, and medialward, is broad and concave, and is in contact with the posterior wall of the stomach, and below this with the tail of the pancreas. It presents near its medial border a long fissure, termed the hilum. This is pierced by several irregular apertures, for the entrance and exit of vessels and nerves. The renal surface, facies renalis, is directed medialward and downward. It is somewhat flattened, is considerably narrower than the gastric surface, and is in relation with the upper part of the anterior surface of the left kidney, and occasionally with the left suprarenal gland. The superior extremity, extremitus superior, is directed toward the vertebral column, where it lies on a level with the 11th thoracic vertebra. The lower extremity or colic surface, extremitus inferior, is flat, triangular in shape, and rests upon the left flexure of the colon and the phrenico-colic ligament, and is generally in contact with the tail of the pancreas. The anterior border, margo anterior, is free, sharp, and thin, and is often notched, especially below. It separates the diaphragmatic from the gastric surface. The posterior border, margo posterior, more rounded and blunter than the anterior, separates the renal from the diaphragmatic surface. It corresponds to the lower border of the 11th rib and lies between the diaphragm and the left kidney. The intermediate margin is the ridge which separates the renal and gastric surfaces. The inferior border, internal border, separates the diaphragmatic from the colic surface. The spleen is almost entirely surrounded by peritoneum, which is firmly adherent to its capsule. It is held in position by two folds of this membrane. One, the phrenico-lional ligament, is derived from the peritoneum, where the wall of the general peritoneal cavity comes into contact with the omental bursa between the left kidney and the spleen. The lional vessels pass between its two layers. The other fold, the gastro-lional ligament, is also formed of two layers, derived from the general cavity and the omental respectively, where they meet between the spleen and the stomach. The short gastric and left gastroepiploic branches of the lional artery run between its two layers. The lower end of the spleen is supported by the phrenico-colic ligament. The size and weight of the spleen are liable to very extreme variations at different periods of life, in different individuals, and in the same individual under different conditions. In the adult, it is usually about 12 centimeters in length, 7 centimeters in breadth, and 3 or 4 centimeters in thickness, and weighs about 200 grams. At birth, its weight, in proportion to the entire body, is almost equal to what is observed in the adult, being as 1 to 350, while in the adult it varies from 1 to 320 and 400. In old age, the organ not only diminishes in weight, but decreases considerably in proportion to the entire body, being as 1 to 700. The size of the spleen is increased during and after digestion, and varies according to the state of nutrition of the body, being large in highly fed and small in starved animals. In malarial fever, it becomes much enlarged, weighing occasionally as much as 9 kilos. Frequently, in the neighborhood of the spleen, and especially in the gastro-lional ligament and greater omentum, small nodules of splenic tissue may be found, either isolated or connected to the spleen by thin bands of splenic tissue. They are known as accessory spleens, lion accessorius, supernumerary spleen. They vary in size from that of a pea to that of a plum. Structure. The spleen is invested by two coats, an external serous and an internal fibroelastic coat. The external or serous coat, tunica serosa, is derived from the peritoneum. It is thin, smooth, and in the human subject intimately adherent to the fibroelastic coat. It invests the entire organ, except at the hilum and along the lines of reflection of the phrenico-lional and gastro-lional ligaments. The fibroelastic coat, tunica albuginea, invests the organ, and at the hilum is reflected inward upon the vessels in the form of sheaths. From these sheaths, as well as from the inner surface of the fibroelastic coat, numerous small fibrous bands, trabeculae, are given off in all directions. These, uniting, constitute the framework of the spleen. The spleen therefore consists of a number of small spaces or areolae formed by the trabeculae. In these areolae is contained the splenic pulp. The fibroelastic coat, the sheaths of the vessels, and the trabeculae are composed of white and yellow elastic fibrous tissues, the latter predominating. It is owing to the presence of the elastic tissue that the spleen possesses a considerable amount of elasticity, which allows of the very great variations in size that it presents under certain circumstances. In addition to these constituents of this tunic, there is found in man a small amount of non-striped muscular fiber, and in some mammalia, for example dog, pig, and cat, a large amount, so that the trabeculae appear to consist chiefly of muscular tissue. The splenic pulp, pulpa lionis, is a soft mass of dark reddish-brown color, resembling grumous blood. It consists of a fine reticulum of fibers, continuous with those of the trabeculae, to which are applied flat, branching cells. The meshes of the reticulum are filled with blood, in which, however, the white corpuscles are found to be in larger proportion than they are in ordinary blood. Large rounded cells, termed splenic cells, are also seen. These are capable of amoeboid movement, and often contain pigment and red blood corpuscles in their interior. The cells of the reticulum each possess a round or oval nucleus, and like the splenic cells, they may contain pigment granules in their cytoplasm. They do not stain deeply with carmine, and in this respect differ from the cells of the Malpighian bodies. In the young spleen, giant cells may also be found, each containing numerous nuclei or one compound nucleus. Nucleated red blood corpuscles have also been found in the spleen of young animals. Blood vessels of the spleen. The lyenal artery is remarkable for its large size in proportion to the size of the organ, and also for its tortuous course. It divides into 6 or more branches, which enter the hilum of the spleen and ramify throughout its substance, receiving sheaths from an involution of the external fibrous tissue. Similar sheaths also invest the nerves and veins. Each branch runs in the transverse axis of the organ, from within outward, diminishing in size during its transit, and giving off in its passage smaller branches, some of which pass to the anterior, others to the posterior part. These ultimately leave the trabecular sheaths and terminate in the proper substance of the spleen in small tufts or pencils of minute arterioles, which open into the interstices of the reticulum formed by the branch sustenticular cells. Each of the larger branches of the artery supplies chiefly that region of the organ in which the branch ramifies, having no anastomosis with the majority of the other branches. The arterioles, supported by the minute trabeculae, traverse the pulp in all directions in bundles, pencillae, of straight vessels. Their trabecular sheaths gradually undergo a transformation, become much thickened, and converted into adenoid tissue, the bundles of connective tissue becoming looser and their fibrils more delicate, and containing in their interstices an abundance of lymph corpuscles. W. Mueller. The altered coat of the arterioles, consisting of adenoid tissue, presents here and there thickenings of a spheroidal shape, the lymphatic nodules, Malpighian bodies of the spleen. These bodies vary in size from about 0.25 mm to 1 mm in diameter. They are merely local expansions or hypoplasia of the adenoid tissue, of which the external coat of the smaller arteries of the spleen is formed. They are most frequently found surrounding the arteriole, which thus seems to tunnel them, but occasionally they grow from one side of the vessel only, and present the appearance of a sessile bud growing from the arterial wall. In transverse sections, the artery, in the majority of cases, is found in an eccentric position. These bodies are visible to the naked eye on the surface of a fresh section of the organ, appearing as minute dots of a semi-opaque whitish color in the dark substance of the pulp. In minute structure they resemble the adenoid tissue of lymph glands, consisting of a delicate reticulum, in the meshes of which lie ordinary lymphoid cells. The reticulum is made up of extremely fine fibrils, and is comparatively open in the center of the corpuscle, becoming closer at its periphery. The cells which it encloses are possessed of amoeboid movement. When treated with carmine they become deeply stained, and can be easily distinguished from those of the pulp. The arterioles end by opening freely into the splenic pulp. Their walls become much attenuated, they lose their tubular character, and the endothelial cells become altered, presenting a branched appearance, and acquiring processes which are directly connected with the processes of the reticular cells of the pulp. In this manner the vessels end, and the blood flowing through them finds its way into the interstices of the reticulated tissue of the splenic pulp. Thus the blood passing through the spleen is brought into intimate relation with the elements of the pulp, and no doubt undergoes important changes. After these changes have taken place, the blood is collected from the interstices of the tissue by the rootlets of the veins, which begin much in the same way as the arteries end. The connective tissue corpuscles of the pulp arrange themselves in rows, in such a way as to form an elongated space or sinus. They become elongated and spindle-shaped, and overlap each other at their extremities, and thus form a sort of endothelial lining of the path or sinus, which is the radicle of a vein. On the outer surfaces of these cells are seen delicate transverse lines or markings, which are due to minute elastic fibulae arranged in a circular manner around the sinus. Thus the channel obtains an external investment, and gradually becomes converted into a small vein, which after a short course acquires a coat of ordinary connective tissue, lined by a layer of flattened epithelial cells, which are continuous with the supporting cells of the pulp. The smaller veins unite to form larger ones. These do not accompany the arteries, but soon enter the tubercular sheaths of the capsule, and by their junction form 6 or more branches, which emerge from the hilum and, uniting, constitute the lienal vein, the largest radicle of the portal vein. The veins are remarkable for their numerous anastomoses, while the arteries hardly anastomose at all. The lymphatics are described on page 711. The nerves are derived from the celiac plexus and are chiefly non-medullated. They are distributed to the blood vessels and to the smooth muscle of the capsule and tuberculi.
Surface anatomy and surface markings. 1. Surface anatomy of the head and neck. Bones, figure 1193. Various bony surfaces and prominences on the skull can be easily identified by palpation. The external occipital protuberance is situated behind, in the middle line, at the junction of the skin of the neck with that of the head. The superior nuchal line runs lateralward from it on either side, while extending downward from it the median nuchal crest, situated deeply at the bottom of the nuchal furrow. Above the superior nuchal lines, the vault of the cranium is thinly covered with soft structures, so that the form of this part of the head is almost that of the upper portion of the occipital, the parietal, and the frontal bones. The superior nuchal line can be followed lateralward to the mastoid portion of the temporal bone, from which the mastoid process projects downward and forward behind the ear. The anterior and posterior borders, the apex, and the external surface of this process are all available for superficial examination. The anterior border lies immediately behind the concha, and the apex is on a level with the lobule of the auricula, about 1 centimeter below and in front of the apex of the mastoid process. The transverse process of the atlas can be distinguished. In front of the ear, the zygomatic arch can be felt throughout its entire length. Its posterior end is narrow and is situated a little above the level of the tragus. Its anterior end is broad and is continued into the zygomatic bone. The lower border of the arch is more distinct than the upper, which is obscured by the attachment of the temporal fascia. In front and behind, the upper border of the arch can be followed into the superior temporal line. In front, this line begins at the zygomatic process of the frontal bone as a curved ridge, which runs at first forward and upward on the frontal bone, and then curving backward separates the forehead into the temporal fossa. It can be traced across the parietal bone, where, though less marked, it can generally be recognized. Finally, it curves downward and forward, and passing above the external acoustic meatus, ends in the posterior root of the zygomatic arch. Near the line of the greatest transverse diameter of the head are the parietal eminences on either side of the middle line. Further forward, on the forehead, are the frontal eminences, which vary in prominence in different individuals and are frequently unsymmetrical. Below the frontal eminences, the superciliary arches, which indicate the position of the frontal sinuses, can be recognized. As a rule, they are small in the female and absent in children. In some cases, the prominence of the superciliary arches is related to the size of the frontal sinuses, but frequently there is no such relationship. Situated between and connecting the superciliary ridges is a smooth, somewhat triangular area, the glabella, below which the nasion, the frontal nasal suture, can be felt as a slight depression at the root of the nose. Below the nasion, the nasal bones, scantily covered by soft tissues, can be traced to their junction with the nasal cartilages, and on either side of the nasal bone, the complete outline of the orbital margin can be made out. At the junction of the medial and intermediate thirds of the supraorbital margin, The supraorbital notch, when present, can be felt. Close to the medial end of the infraorbital margin is a little tubercle which serves as a guide to the position of the lacrimal sac. Below and lateral to the orbit, on either side, is the zygomatic bone forming the prominence of the cheek. Its posterior margin is easily palpable, and on it, just above the level of the lateral palpebral commissure, is the zygomatic tubercle. A slight depression about 1 centimeter above this tubercle indicates the position of the zygomatico-frontal suture. Directly below the orbit is a considerable part of the anterior surface of the maxilla, and the whole of its alveolar process can be palpated. The outline of the mandible can be recognized throughout practically its entire extent. In front of the tragus and below the zygomatic arch is the condyle, and from this posterior border of the ramus can be followed to the angle. From the angle to the symphysis, the lower rounded border of the mandible can be easily traced. The lower part of the anterior border of the ramus and the alveolar process can be made out without difficulty. In the receding angle below the chin is the hyoid bone, and the finger can be carried along the bone to the tip of the greater cornu, which is on level with the angle of the mandible. The greater cornu is most readily appreciated by making pressure on one side, when the cornu of the opposite side will be rendered prominent and can be felt distinctly beneath the skin. Joints and muscles. The temporomandibular articulation is quite superficial and is situated below the posterior end of the zygomatic arch, in front of the external acoustic meatus. Its position can be ascertained by defining the condyle of the mandible. When the mouth opens, the condyle advances out of the mandibular fossa onto the articular tubercle, and a depression is felt in the situation of the joint. The outlines of the muscles of the head and face cannot be traced on the surface, except in the case of the masseter and temporalis. The muscles of the scalp are so thin that the outline of the bone is perceptible beneath them. Those of the face are small, covered by soft skin and often by a considerable layer of fat, and their outlines are therefore concealed. They serve, however, to round off and smooth prominent borders, and to fill up what would otherwise be unsightly angular depressions. Thus, the orbicularis oculi rounds off the prominent margin of the orbit, and the procerus fills in the sharp depression below the glabella. In like manner, the labial muscles converging to the lips, and assisted by the superimposed fat, fill up the sunken hollow of the lower part of the face. When in action, the facial muscles produce the various expressions, and in addition throw the skin into numerous folds and wrinkles. The masseter imparts fullness to hinder part of the cheek. If firmly contracted, as when the teeth are clenched, its quadrilateral outline is plainly visible. The anterior border forms a prominent vertical ridge, behind which is a considerable fullness, especially marked at the lower part of the muscle. The temporalis is fan-shaped and fills the temporal fossa, substituting for the concavity a somewhat convex swelling, the anterior part of which, on account of the absence of hair on the overlying skin, is more marked than the posterior, and stands out in strong relief when the muscle is in action. In the neck, the platysma, when contracted, throws the skin into oblique ridges parallel with the fasciiculi of the muscle. The sternocleidomastoidus has the most important influence on the surface form of the neck. When the muscle is at rest, its anterior border forms an oblique, rounded edge ending below on the sharp outline of the sternal head. The posterior border is only distinct for about 2 or 3 centimeters, above the middle of the clavicle. During contraction, the sternal head stands out as a sharply defined ridge, while the clavicular head is flatter and less prominent. Between the two heads is a slight depression. The fleshy middle portion of the muscle appears as an oblique elevation, with a thick, rounded anterior border best marked in its lower part. The sternal heads of the two muscles are separated by a V-shaped depression, in which are the sternohyoidus and sternothyroidus. Above the hyoid bone, near the middle line, the anterior belly of the didrasticus produces a slight convexity. The anterior border of the trapezius presents as a faint ridge running from the superior neutral line downward and forward to the junction of the intermediate and lateral thirds of the clavicle. Between the sternocleidomastoidus and the trapezius is the posterior triangle of the neck, the lower part of which appears as a shallow concavity, the supraclavicular fossa. In this fossa, the inferior belly of the omohyoideus, when in action, presents as a round cord-like elevation a little above and almost parallel to the clavicle. Figure 1195, front view of the neck. Arteries. The positions of several of the larger arteries can be ascertained from their pulsations. The subclavian artery can be felt by making pressure downward, backward, and medialward behind the clavicular head of the sternocleidomastoideus. Its transverse cervical branch may be detected parallel to and about a finger's breadth above the clavicle. The common and external carotid arteries can be recognized immediately beneath the anterior edge of the sternocleidomastoideus. The external maxillary artery can be traced over the border of the mandible just in front of the anterior border of the masseter, then about 1 centimeter, lateral to the angle of the mouth, and finally as it runs up the side of the nose. The pulsation of the occipital artery can be distinguished about 3 or 4 centimeters lateral to the external occipital protuberance, that of the posterior auricular, in the groove between the mastoid process and the auricula. The course of the superficial temporal artery can be readily followed across the posterior end of the zygomatic arch to a point about 3 to 5 centimeters above this, where it divides into its frontal and parietal branches. The pulsation of the frontal branch is frequently visible on the side of the forehead. The supraorbital artery can usually be detected immediately above the supraorbital notch, or foramen.
Surface markings of special regions of the head and neck, Part 1. The cranium, scalp. The soft parts covering the upper surface of the skull form the scalp and comprise the following layers. 1. Skin. 2. Subcutaneous tissue. 3. Occipitalis frontalis and Gallia aponeurotica. 4. Subaponeurotic tissue. 5. Pericranium. The subcutaneous tissue consists of a close meshwork of fibers, the meshes of which contain fatty tissue. The fibers bind the skin and Gallia aponeurotica firmly together, so that when the occipitalis or the frontalis is in action, the skin moves with the aponeurosis. The subaponeurotic tissue, which intervenes between the Gallia aponeurotica and the pericranium, is much looser in texture, and permits the movement of the aponeurosis over the underlying bones. Bony landmarks. In addition to the bony points already described, which can be determined by palpation, the following are utilized for surface markings. Auricular point, the center of the orifice of the external acoustic meatus. Preauricular point, a point on the posterior root of the zygomatic arch immediately in front of the external acoustic meatus. Asterion, the point of meeting of the lambdoidal, masto-occipital, and masto-parietal sutures. It lies 4 centimeters behind and 12 millimeters above the level of the auricular point. Pterion, the point where the great wing of the sphenoid joins the sphenoidal angle of the parietal. It is situated 35 mm behind and 12 mm above the level of the frontozygomatic suture. Inion, the external occipital protuberance. Lambda, the point of meeting of the lambdoidal and sagittal sutures. It is in the middle line, about 6.5 cm above the inion. Bregma, the meeting point of the coronal and sagittal sutures. It lies at the point of intersection of the middle line of the scalp with a line drawn vertically upward through the preauricular point. A line passing through the inferior margin of the orbit and the auricular point is known as Reed's base line. The lambdoidal suture can be indicated on either side by the upper two-thirds of a line from the lambda to the tip of the mastoid process. The sagittal suture is in the line joining the lambda to the bregma. The position of the coronal suture on either side is sufficiently represented by a line joining the bregma to the center of the zygomatic arch. The floor of the middle fossa of the skull is at the level of the posterior 3/4 of the upper border of the zygomatic arch. The articular eminence of the temporal bone is opposite the foramen spinosum and the semilunar ganglion. Brain. The general outline of the cerebral hemisphere on either side may be mapped out on the surface in the following manner. Starting from the nasion, a line drawn along the middle of the scalp to the inion represents the superior border. The line of the lower margin behind is that of the transverse sinus, or more roughly a line convex upward from the inion to the posterior root of the zygomatic process of the temporal bone, thence along the posterior two-thirds of the upper border of the zygomatic arch, where the line turns up to the pterion. The front part of the lower margin extends from the pterion to the glabella about 1 cm above the supraorbital margin. The cerebellum is so deeply situated that there is no reliable surface marking for it. A point 4 cm behind and 1.5 cm below the level of the auricular point is situated directly over it. The relations of the principal fissures and gyri of the cerebral hemispheres to the surface of the scalp are of considerable practical importance, and several methods of indicating them have been devised. Necessarily, these methods can only be regarded as approximately correct, yet they are all sufficiently accurate for surgical purposes. The longitudinal fissure corresponds to the medial line of the scalp between the nasion and inion. In order to mark out the lateral cerebral sylvian fissure, a point, termed the sylvian point, which practically corresponds to the pterion, is defined 35 mm behind and 12 mm above the level of the frontozygomatic suture. This point marks the spot where the lateral fissure divides. Another method of defining the sylvian point is to divide the distance between the nasion and inion into 4 equal parts. From the junction of the third and fourth parts, reckoning from the front, draw a line to the frontozygomatic suture. From the junction of the first and second parts, a line to the auricular point. These two lines intersect at the sylvian point, and the portion of the first line behind this point overlies the posterior ramus of the lateral cerebral fissure. The position of the posterior ramus can otherwise be obtained by joining the sylvian point to a point 2 cm below the summit of the parietal eminence. The anterior ascending ramus can be marked out by drawing a line upward at right angles to the line of the posterior ramus for 2 cm, and the anterior horizontal ramus by a line of the same length drawn horizontally forward, both from the sylvian point. To define the central sulcus, fissure of Rolando, 2 points are taken. One is situated 1.25 cm behind the center of the line joining the nasion and inion. The second is at the intersection of the line of the posterior ramus of the lateral cerebral fissure with a line through the preauricular point, at right angles to Reed's baseline. The upper 9 cm of the line joining these 2 points overlies the central sulcus and forms an angle, opening forward, of about 70 degrees with the middle line of the scalp. An alternative method is to draw 2 perpendicular lines from Reed's baseline to the top of the head, one from the preauricular point, and the other from the posterior border of the mastoid process at its root. A line from the upper end of the posterior line to the point where the anterior intersects the line of the posterior ramus of the lateral fissure indicates the position of the central sulcus. The precentral and postcentral sulci are practically parallel to the central sulcus. They are situated, respectively, about 15 millimeters in front of and behind it. The superior frontal sulcus can be mapped out by a line drawn from the junction of the upper and middle thirds of the precentral sulcus, in a direction parallel with the longitudinal sulcus, to a point midway between the middle line of the forehead and the temporal line, 4 centimeters above the supraorbital notch. The inferior frontal sulcus begins at the junction of the middle and lower thirds of the precentral sulcus, and follows the course of the superior temporal line. The horizontal limb of the intraparietal sulcus begins from the junction of the lower with the middle third of the postcentral sulcus, and curves backward parallel to the longitudinal fissure, midway between it and the parietal eminence. It then curves downward to end midway between the lambda and the parietal eminence. The external part of the parieto-occipital fissure runs lateralward at right angles to the longitudinal fissure for about 2.5 centimeters from a point 5 millimeters in front of the lambda. If the line of the posterior ramus of the lateral cerebral fissure be continued back to the longitudinal fissure, the last 2.5 centimeters of it will indicate the position of the parieto-occipital fissure. The lateral ventricle may be circumscribed by a quadrilateral figure. The upper limit is a horizontal line 5 centimeters above the zygomatic arch. This defines the roof of the ventricle. The lower limit is a horizontal line 1 centimeter above the zygomatic arch. It indicates the level of the end of the inferior horn. 2 vertical lines, one through the junction of the anterior and middle thirds of the zygomatic arch, and the other 5 centimeters behind the tip of the mastoid process, indicate the extent of the anterior horn in front and the posterior horn behind. Vessels. The line of the anterior division of the middle meningeal artery is equidistant from the frontozygomatic suture and the zygomatic arch. It is obtained by joining up the following points: 1. 2.5 centimeters, 2. 4 centimeters, and 3. 5 centimeters from these 2 landmarks. The posterior division can be reached 2.5 centimeters above the auricular point. The position of the transverse sinus is obtained by taking 2 lines, the first from the inion to a point 2.5 centimeters behind the auricular point, the second from the anterior end of the first to the tip of the mastoid process. The second line corresponds roughly to the line of reflection of the skin of the auricula behind, and its upper 2/3 represents the sigmoid part of the sinus. The first part of the sinus has a slight upward convexity, and its highest point is about 4 centimeters behind and 1 centimeter above the level of the auricular point. The width of the sinus is about 1 centimeter. The face. Air sinuses. The frontal and maxillary sinuses vary so greatly in form and size that their surface markings must be regarded as only roughly approximate. To mark out the position of the frontal sinus, 3 points are taken. 1. The nasion. 2. A point in the middle line 3 centimeters above the nasion. 3. A point at the junction of the lateral and intermediate thirds of the supraorbital margin. By joining these, a triangular field is described which overlies the greater part of the sinus. The outline of the maxillary sinus is irregularly quadrilateral and is obtained by joining up the following points: 1. The lacrimal tubercle. 2. A point on the zygomatic bone at the level of the inferior and lateral margins of the orbit. 3 and 4. Points on the alveolar process above the last molar and the second premolar teeth, respectively. External maxillary artery. The course of this artery on the face may be indicated by a line starting from the lower border of the mandible at the anterior margin of the masseter, and running at first forward and upward to a point 1 centimeter lateral to the angle of the mouth, thence to the ala of the nose, and upward to the medial commissure of the eye. Trigeminal nerve. Terminal branches of this nerve, namely the supraorbital branch of the ophthalmic, the infraorbital of the maxillary, and the mental of the mandibular, emerge from corresponding foramina on the face. The supraorbital foramen is situated at the junction of the medial and intermediate thirds of the supraorbital margin. A line drawn from this foramen to the lower border of the mandible, through the interval between the 2 lower premolar teeth, passes over the infraorbital and mental foramina. The former lies about 1 centimeter below the margin of the orbit, while the latter varies in position according to the age of the individual. In the adult it is midway between the upper and lower borders of the mandible. In the child it is nearer the lower border, while in the edentulous jaw of old age it is close to the upper margin. The position of the sphenopalatine ganglion is indicated from the side by a point on the upper border of the zygomatic arch, 6 millimeters from the margin of the zygomatic bone. Parotid gland. The upper border of the parotid gland corresponds to the posterior 2/3 of the lower border of the zygomatic arch, the posterior border to the front of the external acoustic meatus, the mastoid process, and the anterior border of sternocleidomastoideus. The inferior border is indicated by a line from the tip of the mastoid process to the junction of the body and greater cornu of the hyoid bone. In front, the anterior border extends for a variable distance on the superficial surface of the masseter. The surface marking for the parotid duct is a line drawn across the face about a finger's breadth below the zygomatic arch, that is, from the lower margin of the concha to midway between the red margin of the lip and the ala of the nose. The duct ends opposite the second upper molar tooth and measures about 5 centimeters in length. The nose. The outlines of the nasal bones and the cartilages forming the external nose can be easily felt. The mobile portion of the nasal septum, formed by the medial crura of the greater alar cartilages and the skin, is easily distinguished between the nares. When the head is tilted back and a speculum introduced through the nares, the floor of the nasal cavity, the lower part of the nasal septum, and the anterior ends of the middle and inferior nasal conchae can be examined. The opening of the nasolacrimal duct, which lies under cover of the front of the inferior nasal concha, is situated about 2.5 centimeters behind the nares and 2 centimeters above the level of the floor of the nasal cavity. Surface markings and special regions of the head and neck, Part 2. The mouth. The orifice of the mouth is bounded by the lips, which are covered externally by the whitish skin and internally by the red mucous membrane. The size of the orifice varies considerably in different individuals, but seems to bear a close relationship to the size and prominence of the teeth. Its angles usually correspond to the lateral borders of the canine teeth. Running down the center of the outer surface of the upper lip is a shallow groove, the philtrum. If the lips be everted, there can be seen, in the middle line of each, a small fold of mucous membrane, the frenulum, passing from the lip to the gum. By pulling the angle of the mouth outward, the mucous membrane of the cheek can be inspected, and on this, opposite the second molar tooth of the maxilla, is the little papilla which marks the orifice of the parotid duct. In the floor of the mouth is the tongue. Its upper surface is convex and is marked along the middle line by a shallow sulcus. The anterior 2/3 are rough and studded with papillae. The posterior third is smooth and tuberculated. The division between the anterior 2/3 and the posterior third is marked by a V-shaped furrow, the sulcus terminalis, which is situated immediately behind the line of the valate papillae. On the undersurface of the tongue, the mucous membrane is smooth and devoid of papillae. In the middle line, the mucous membrane extends to the floor of the mouth as a distinct fold, the frenulum, the free edge of which runs forward to the symphysis menti. Sometimes the ranine vein can be seen immediately beneath the mucous membrane, a little lateral to the frenulum. Close to the attachment of the frenulum to the floor of the mouth, the slit-like orifice of the submaxillary duct is visible on either side. Running backward and lateralward from the orifice of the submaxillary duct is the plica sublingualis, produced by the projection of the sublingual gland which lies immediately beneath the mucous membrane. The plica serves also to indicate the line of the submaxillary duct and of the lingual nerve. At the back of the mouth is the isthmus falcium, bounded above by the palatine velum, from the free margin of which the uvula projects downward in the middle line. On either side of the isthmus are the 2 palatine arches, the anterior formed by the glossopalatinus and the posterior by the pharyngopalatinus. Between the 2 arches of either side is the palatine tonsil, above which is the small supratonsillar recess. The position of the tonsil corresponds to the angle of the mandible. When the mouth is opened widely, a tense band, the pterygomandibular raphe, can be seen and felt lateral to the glossopalatine arch. Its lower end is attached to the mandible behind the last molar tooth, and immediately below and in front of this the lingual nerve can be felt. The upper end of the ligament can be traced to the pterygoid hamulus. About 1 cm in front of the hamulus and 1 cm medial to the last molar tooth of the maxilla is the greater palatine foramen through which the descending palatine vessels and the anterior palatine nerve emerge. Behind the last molar tooth of the maxilla, the carotid process of the mandible is palpable. By tilting the head well back, a portion of the posterior pharyngeal wall, corresponding to the site of the second and third cervical vertebrae, can be seen through the isthmus falcium. On introducing the finger, the anterior surfaces of the upper cervical vertebrae can be felt through the thin muscular wall of the pharynx. If the finger be hooked round the palatine velum, the choane can be distinguished in front, and the pharyngeal ostium of the auditory tube on either side. The level of the choane is that of the atlas, while the palatine velum is opposite the body of the axis. With a laryngoscope, many other structures can be seen. In the nasal part of the pharynx, the choane, the nasal septum, the nasal conchae, and the pharyngeal ostia of the auditory tubes can all be examined. Further down, the base of the tongue, the anterior surface of the epiglottis, with the glossoepiglottic and pharyngo-epiglottic folds bounding the valleculae and the piriform sinuses, are readily distinguished. Beyond these is the entrance to the larynx, bounded on either side by the aryepiglottic folds, in each of which are two rounded eminences corresponding to the corniculate and cuneiform cartilages. Within the larynx on either side are the ventricular and vocal folds, false and true vocal cords, with the ventricle between them. Still deeper are seen the cricoid cartilage and the anterior parts of some of the cartilaginous rings of the trachea, and sometimes, during deep inspiration, the bifurcation of the trachea. The eye. The palpebral fissure is elliptical in shape, and varies in form in different individuals and in different races of mankind. Normally it is oblique, in a direction upward and lateralward, so that the lateral commissure is on a slightly higher level than the medial. When the eyes are directed forward, as in ordinary vision, the upper part of the cornea is covered by the upper eyelid, and its lower margin corresponds to the level of the free margin of the lower eyelid, so that usually the lower 3/4 are exposed. At the medial commissure are the caruncula lachrymalis and the plica semilunaris. When the lids are everted, the tarsal glands appear as a series of nearly straight parallel rows of light yellow granules. On the margins of the lids, about 5 mm from the medial commissure, are two small openings, the lacrimal puncta. In the natural condition they are in contact with the conjunctiva of the bulb of the eye, so that it is necessary to avert the eyelids to expose them. The position of the lacrimal sac is indicated by a little tubercle which can be plainly felt on the lower margin of the orbit. The sac lies immediately above and medial to the tubercle. If the eyelids be drawn lateralward so as to tighten the skin at the medial commissure, a prominent core can be felt beneath the tightened skin. This is the medial palpebral ligament, which lies over the junction of the upper with the lower 2/3 of the sac, thus forming a useful guide to its situation. The direction of the nasolacrimal duct is indicated by a line from the lacrimal sac to the first molar tooth of the maxilla. The length of the duct is about 12 or 13 mm. On looking into the eye, the iris with its opening, the pupil, and the front of the lens can be examined. But for investigation of the retina, an ophthalmoscope is necessary. With this, the lens, the vessels of the retina, the optic disc, and the macula lutea can all be inspected. On the lateral surface of the nasal part of the frontal bone, the pulley of the obliquus superior can be easily reached by pushing the finger backward along the roof of the orbit. The tendon of the muscle can be traced for a short distance backward and lateralward from the pulley. The ear. The various prominences and fossae of the auricula are visible. The opening of the external acoustic meatus is exposed by drawing the tragus forward. At the orifice are a few short, crisp hairs which serve to prevent the entrance of dust or of small insects. Beyond this, the secretion of the ceruminous glands serves to catch any small particles which may find their way into the meatus. The interior of the meatus can be examined through a speculum. At the line of junction of its bony and cartilaginous portions an obtuse angle is formed, which projects into the antero-inferior wall, and produces a narrowing of the lumen in this situation. The cartilaginous part, however, is connected to the bony part by fibrous tissue, which renders the outer part of the meatus very movable, and therefore by drawing the auricula upward, backward, and slightly outward, the canal is rendered almost straight. In children the meatus is very short, and this should be remembered in introducing the speculum. Through the speculum the greater part of the tympanic membrane is visible. It is a pearly gray membrane, slightly glistening in the adult, placed obliquely so as to form with the floor of the meatus an angle of about 55 degrees. At birth it is more horizontal and situated in almost the same plane as the base of the skull. The membrane is concave outward, and the point of deepest concavity, the umbo, is slightly below the center. Running upward and slightly forward from the umbo is a reddish-yellow streak produced by the manubrium of the malleus. This streak ends above, just below the roof of the meatus, at a small white rounded prominence, which is caused by the lateral process of the malleus projecting against the membrane. The anterior and posterior malleolar folds extend from the prominence to the circumference of the membrane and enclose the pars flaccida. Behind the streak caused by the manubrium of the malleus, a second streak, shorter and very faint, can be distinguished. This is the long crus of the incus. A narrow triangular patch extending downward and forward from the umbo reflects the light more brightly than any other part, and is usually described as the cone of light. Tympanic antrum. The site of the tympanic antrum is indicated by the suprameatal triangle. This triangle is bounded above by the posterior root of the zygomatic arch, behind by a vertical line from the posterior border of the external acoustic meatus, in front and below by the upper margin of the meatus. The neck, larynx and trachea. In the receding angle below the chin, the hyoid bone, situated opposite the fourth cervical vertebra, can easily be made out. A finger's breadth below it is the laryngeal prominence of the thyroid cartilage. The space intervening between the hyoid bone and the thyroid cartilage is occupied by the hyothyroid membrane. The outlines of the thyroid cartilage are readily palpated. Below its lower border is a depression corresponding to the middle cricothyroid ligament. The level of the vocal folds corresponds to the middle of the anterior margin of the thyroid cartilage. The anterior part of the cricoid cartilage forms an important landmark on the front of the neck. It lies opposite the sixth cervical vertebra and indicates the junctions of pharynx with esophagus and larynx with trachea. Below the cricoid cartilage the trachea can be felt, though it is only in thin subjects that the separate rings can be distinguished. As a rule there are 7 or 8 rings above the jugular notch of the sternum, and of these the second, third, and fourth are covered by the isthmus of the thyroid gland. Muscles. The posterior belly of Digastricus is marked out by a line from the tip of the mastoid process to the junction of the greater cornu and body of the hyoid bone. A line from this latter point to a point just lateral to the symphysis menti indicates the position of the anterior belly. The line of omohyoideus begins at the lower border of the hyoid bone, curves downward and lateralward to cross sternocleidomastoideus at the junction of its middle and lower thirds, that is, opposite the cricoid cartilage, and then runs more horizontally to the acromial end of the clavicle. Arteries. The position of the common carotid artery in the neck is indicated by a line drawn from the upper part of the sternal end of the clavicle to a point midway between the tip of the mastoid process and the angle of the mandible. From the clavicle to the upper border of the thyroid cartilage, this line overlies the common carotid artery. Beyond this it is over the external carotid. The external carotid artery may otherwise be marked out by the upper part of a line from the side of the cricoid cartilage to the front of the external acoustic meatus, arching the line slightly forward. The points of origin of the main branches of the external carotid in the neck are all related to the tip of the greater cornu of the hyoid bone as follows: 1. The superior thyroid, immediately below it. 2. The lingual, on a level with it. 3. The facial. and 4. The occipital, a little above and behind it. The subclavian artery is indicated on the surface by a curved line, convex upward, from the sternoclavicular articulation to the middle of the clavicle. The highest point of the convexity is from 1 to 3 centimeters above the clavicle. Veins. The surface marking for the internal jugular vein is slightly lateral and parallel to that for the common carotid artery. The position of the external jugular vein is marked out by a line from the angle of the mandible to the middle of the clavicle. A point on this line about 4 centimeters above the clavicle indicates the spot where the vein pierces the deep fascia. The line of the anterior jugular vein begins close to the symphysis menti, runs downward parallel with and a little to one side of the middle line, and, at a variable distance above the jugular notch, turns lateralward to the external jugular. Nerves. The facial nerve, at its exit from the stylomastoid foramen, is situated about 2.5 centimeters from the surface, opposite the middle of the anterior border of the mastoid process. A horizontal line from this point to the ramus of the mandible overlies the stem of the nerve. To mark the site of the accessory nerve, a line is drawn from the angle of the mandible to a point on the anterior border of sternocleidomastoideus, about 3 to 4 centimeters below the apex of the mastoid process, or to the midpoint of the posterior border of the muscle. The line is continued across the posterior triangle to trapezius. The cutaneous branches of the cervical plexus, as they emerge from the posterior border of sternocleidomastoideus, may be indicated as follows. The lesser occipital begins immediately above the midpoint of the border and runs along the border to the scalp. The great auricular and cervical cutaneous both start from the middle of the border, the former running upward toward the lobule of the auricula, the latter crossing sternocleidomastoideus at right angles to its long axis. The supraclavicular nerves emerge from immediately below the middle of the posterior border and run down over the clavicle. The phrenic nerve begins at the level of the middle of the thyroid cartilage and runs behind the clavicle about midway between the anterior and posterior borders of sternocleidomastoideus. The upper border of the brachial plexus is indicated by a line from the side of the cricoid cartilage to the middle of the clavicle. Submaxillary gland. On either side of the neck, the superficial portion of the submaxillary gland, as it lies partly under cover of the mandible, can be palpated.
Surface anatomy. Surface markings of back. 3. Surface anatomy of the back. Bones. The only subcutaneous parts of the vertebral column are the apices of the spinous processes. These are distinguishable at the bottom of a furrow which runs down the middle line of the back, from the external occipital protuberance to the middle of the sacrum. In the cervical region, the furrow is broad and ends below in a conspicuous projection caused by the spinous processes of the 7th cervical and 1st thoracic vertebrae. Above this, the spinous process of the 6 cervical vertebrae sometimes form a projection. The other cervical spinous processes are sunken, but that of the axis can be felt. In the thoracic region, the furrow is shallow and during stooping disappears, and then the spinous processes become more or less visible. The markings produced by them are small and close together. In the lumbar region, the furrow is deep, and the situations of the spinous processes are frequently indicated by little pits or depressions, especially when the muscles in the loins are well developed. In the sacral region, the furrow is shallower, presenting a flattened area which ends below at the most prominent part of the dorsal surface of the sacrum, i.e., the spinous process of the 3rd sacral vertebra. At the bottom of the sacral furrow, the irregular dorsal surface of the bone may be felt, and below this, in the deep groove running to the anus, the coccyx. The only other portions of the vertebral column which can be felt from the surface are the transverse processes of the 1st, 6th, and 7th cervical vertebrae. Muscles. The muscles proper of the back are so obscured by those of the upper extremity that they have very little influence on surface form. The splenei, by their divergence, serve to broaden out the upper part of the back of the neck, and produce a fullness in this situation. In the loin, the sacrospinales, bound down by the lumbodorsal fascia, form rounded vertical eminences which determine the depth of the spinal furrow and taper below to a point on the dorsal surface, the sacrum. The continuations of the sacrospinales in the lower thoracic region form flattened planes which are gradually lost on passing upward. Bony landmarks. In order to identify any particular spinous process, it is customary to count from the prominence caused by the 7th cervical and 1st thoracic. Of these the latter is the most prominent. The root of the spine of the scapula is on a level with the tip of the spinous process of the 3rd thoracic vertebrae, and the inferior angle with that of the 7th. The highest point of the iliac crest is on a level with the spinous process of the 4th lumbar, and the posterior superior iliac spine with that of the 2nd sacral. The transverse process of the atlas is about 1 centimeter below and in front of the apex of the mastoid process. The transverse process of the 6th cervical vertebra is opposite the cricoid cartilage. Below it is the transverse process of the 7th and occasionally a cervical rib. Medulla spinalis. The position of the lower end of the medulla spinalis varies slightly with the movements of the vertebral column, but in the adult in the upright posture it is usually at the level of the spinous process of the 2nd lumbar vertebra. At birth it lies at the level of the 4th lumbar. The subdural and subarachnoid cavities end below opposite the spinous process of the 3rd sacral vertebra.
Surface anatomy and surface markings of thorax. 5. Surface anatomy of the thorax. Bones. The skeleton of the thorax is to a very considerable extent covered by muscles, so that in the strongly developed muscular subject it is for the most part concealed. In the emaciated subject, however, the ribs, especially in the lower and lateral regions, stand out as prominent ridges with the sunken intercostal spaces between them. In the middle line, in front, the superficial surface of the sternum can be felt throughout its entire length at the bottom of a furrow, the sternal furrow, situated between the pectoralis majoris. These muscles overlap the anterior surface somewhat, so that the whole width of the sternum is not subcutaneous, and this overlapping is greatest opposite the middle of the bone. The furrow, therefore, is wide at its upper and lower parts, but narrow in the middle. At the upper border of the manubrium sterni is the jugular notch. The lateral parts of this notch are obscured by the tendinous origins of the sternocleidomastoidea, which appear as oblique cords narrowing and deepening the notch. Lower down on the subcutaneous surface is a well-defined transverse ridge, the sternal angle. It denotes the junction of the manubrium and body. From the middle of the sternum, the sternal furrow spreads out and ends at the junction of the body with the xiphoid process. Immediately below this is the infrasternal notch, between the sternal ends of the 7th costal cartilages, and below the notch is a triangular depression, the epigastric fossa, in which the xiphoid process can be felt. On either side of the sternum, the costal cartilages and ribs on the front of the thorax are partly obscured by the pectoralis major, through which, however, they can be felt as ridges with yielding intervals between them, corresponding to the intercostal spaces. Of these spaces, that between the 2nd and 3rd ribs is the widest. The next two are somewhat narrower, and the remainder, with the exception of the last two, are comparatively narrow. Below the lower border of the pectoralis major on the front of the chest, the broad flat outlines of the ribs as they descend, and the more rounded outlines of the costal cartilages are often visible. The lower boundary of the front of the thorax, which is most plainly seen by bending the body backward, is formed by the xiphoid process, the cartilages of the 7th, 8th, 9th, and 10th ribs, and the ends of the cartilages of the 11th and 12th ribs. On either side of the thorax, from the axilla downward, the flattened external surfaces of the ribs may be defined. Although covered by muscles, all the ribs, with the exception of the first, can generally be followed without difficulty over the front and sides of the thorax. The first rib, being almost completely covered by the clavicle, can only be distinguished in a small portion of its extent. At the back, the angles of the ribs lie on a slightly marked oblique line on either side of, and some distance from, the spinous processes of the vertebrae. The line diverges somewhat as it descends, and lateral to it is a broad convex surface caused by the projection of the ribs beyond their angles. Over this surface, except where covered by the scapula, the individual ribs can be distinguished. Muscles. The surface muscles covering the thorax belong to the musculature of the upper extremity and will be described in that section. There is, however, an area of practical importance bounded by these muscles. It is limited above by the lower border of trapezius, below by the upper border of latissimus dorsi, and laterally by the vertebral border of the scapula. The floor is partly formed by rhomboideus major. If the scapula be drawn forward by folding the arms across the chest, and the trunk bent forward, parts of the sixth and seventh ribs, and the interspace between them, become subcutaneous and available for osculation. The space is therefore known as the triangle of osculation. Mamma. The size of the mamma is subject to great variations. In the adult nulliparous female, it extends vertically from the second to the sixth rib, and transversely from the side of the sternum to the mid-axillary line. In the male, and in the nulliparous female, the mammary papilla is situated in the fourth interspace about 9 or 10 centimeters from the middle line, or 2 centimeters from the costochondral junction. 6. Surface markings of the thorax. Bony landmarks. The second costal cartilage, corresponding to the sternal angle, is so readily found that it is used as a starting point from which to count the ribs. The lower border of the pectoralis major at its attachment corresponds to the fifth rib. The uppermost visible digitation of serratus anterior indicates the sixth rib. The jugular notch is in the same horizontal plane as the lower border of the body of the second thoracic vertebra. The sternal angle is at the level of the fifth thoracic vertebra, while the junction between the body and xiphoid process of the sternum corresponds to the fibrocartilage between the ninth and 10th thoracic vertebrae. The influence of the obliquity of the ribs on horizontal levels in the thorax is well shown by the following line. Quote, "If a horizontal line be drawn around the body at the level of the inferior angle of the scapula, while the arms are at the sides, the line would cut the sternum in front between the fourth and fifth ribs, the fifth rib in the nipple line, and the ninth rib at the vertebral column." Unquote. Treves. Diaphragm. The shape and variations of the diaphragm as seen by skiography have already been described. Page 407. Surface lines. For clinical purposes and for convenience of description, the surface of the thorax has been mapped out by arbitrary lines. On the front of the thorax, the most important vertical lines are the midsternal, the middle line of the sternum, and the mammary, or better, midclavicular, which runs vertically downward from a point midway between the center of the jugular notch and the tip of the acromion. This latter line, if prolonged, is practically continuous with the lateral line on the front of the abdomen. Other vertical lines on the front of the thorax are the lateral sternal along the sternal margin, and the peristernal midway between the lateral sternal and the mammary. On either side of the thorax, the anterior and posterior axillary lines are drawn vertically from the corresponding axillary folds. The mid-axillary line runs downward from the apex of the axilla. On the posterior surface of the thorax, the scapular line is drawn vertically through the inferior angle of the scapula. Pleurae. The lines of reflection of the pleurae can be indicated on the surface. On the right side, the line begins at the sternoclavicular articulation and runs downward and medialward to the midpoint of the junction between the manubrium and body of the sternum. It then follows the midsternal line to the lower end of the body of the sternum, or onto the xiphoid process, where it turns lateralward and downward across the 7th sternocostal articulation. It crosses the 8th costochondral junction in the mammary line, the 10th rib in the mid-axillary line, and is prolonged thence to the spinous process of the 12th thoracic vertebra. On the left side, beginning at the sternoclavicular articulation, it reaches the midpoint of the junction between the manubrium and body of the sternum, and extends down the mid-sternal line in contact with that of the opposite side to the level of the 4th costal cartilage. It then diverges lateralward and is continued downward slightly lateral to the sternal border as far as the 6th costal cartilage. Running downward and lateralward, from this point it crosses the 7th costal cartilage, and from this onward it is similar to the line on the right side, but at a slightly lower level. Lungs. The apex of the lung is situated in the neck above the medial third of the clavicle. The height to which it rises above the clavicle varies very considerably, but is generally about 2.5 centimeters. It may, however, extend as high as 4 or 5 centimeters, or, on the other hand, may scarcely project above the level of this bone. In order to mark out the anterior borders of the lungs, a line is drawn from each apex point, 2.5 centimeters above the clavicle and rather nearer the anterior than the posterior border of sternocleidomastoideus, downward and medialward across the sternoclavicular articulation and manubrium sterni, until it meets, or almost meets, its fellow of the other side at the midpoint of junction between the manubrium and body of the sternum. From this point, the two lines run downward, practically along the midsternal line, as far as the level of the 4th costal cartilages. The continuation of the anterior border of the right lung is marked by a prolongation of its line vertically downward to the level of the 6th costal cartilage, and then it turns lateralward and downward. The line on the left side curves lateralward and downward across the 4th sternocostal articulation to reach the peristernal line at the 5th costal cartilage, and then turns medialward and downward to the 6th sternocostal articulation. In the position of expiration, the lower border of the lung may be marked by a slightly curved line with its convexity downward from the 6th sternocostal junction to the 10th thoracic spinous process. This line crosses the mid-clavicular line at the 6th and the mid-axillary line at the 8th rib. The posterior borders of the lungs are indicated by lines drawn from the level of the spinous process of the 7th cervical vertebra down either side of the vertebral column, across the costovertebral joints, as low as the spinous process of the 10th thoracic vertebra. The position of the oblique fissure in either lung can be shown by a line drawn from the spinous process of the 2nd thoracic vertebra around the side of the thorax to the 6th rib in the mid-clavicular line. This line corresponds roughly to the line of the vertebral border of the scapula when the hand is placed on the top of the head. The horizontal fissure in the right lung is indicated by a line drawn from the midpoint of the preceding, or from the position where it cuts the mid-axillary line to the mid-sternal line at the level of the 4th costal cartilage. Trachea. This may be marked out on the back by a line from the spinous process of the 6th cervical to that of the 4th thoracic vertebra, where it bifurcates. From its bifurcation, the two bronchi are directed downward and lateralward. In front, the point of bifurcation corresponds to the sternal angle. Esophagus. The extent of the esophagus may be indicated on the back by a line from the 6th cervical to the level of the 9th thoracic spinous process, 2.5 centimeters to the left of the middle line. Heart. The outline of the heart in relation to the front of the thorax can be represented by a quadrangular figure. The apex of the heart is first determined either by its pulsation or as a point in the 5th interspace, 9 centimeters to the left of the midsternal line. The other 3 points are A. The 7th right sternocostal articulation, B. A point on the upper border of the 3rd right costal cartilage, 1 centimeter from the right lateral sternal line, C. A point on the lower border of the 2nd left costal cartilage, 2.5 centimeters from the left lateral sternal line. A line joining the apex point, A, and traversing the junction of the body of the sternum with the xiphoid process represents the lowest limit of the heart, its acute margin. The right and left borders are represented respectively by lines joining A to B and the apex to C. Both lines are convex lateralward, but the convexity is more marked on the right, where its summit is 4 centimeters distant from the midsternal line opposite the 4th costal cartilage. A portion of the area of the heart thus mapped out is uncovered by lung and therefore gives a dull note on percussion. The remainder being overlapped by lung gives a more or less resonant note. The former is known as the area of superficial cardiac dullness, the latter as the area of deep cardiac dullness. The area of superficial cardiac dullness is somewhat triangular. From the apex of the heart, 2 lines are drawn to the midsternal line, one to the level of the 4th costal cartilage, the other to the junction between the body and xiphoid process. The portion of the midsternal line between these points is the base of the triangle. Latham lays down the following rule as a sufficient practical guide for the definition of the area of superficial dullness. Quote, make a circle of 2 inches in diameter around a point midway between the nipple and the end of the sternum. Unquote. The coronary sulcus can be indicated by a line from the 3rd left to the 6th right sternocostal joint. The anterior longitudinal sulcus is a finger's breadth to the right of the left margin of the heart. The position of the various orifices is as follows. The pulmonary orifice is situated in the upper angle of the 3rd left sternocostal articulation. The aortic orifice is a little below and medial to this, close to the articulation. The left atrioventricular opening is opposite the 4th costal cartilage and rather to the left of the midsternal line. The right atrioventricular opening is a little lower, opposite the 4th interspace of the right side. The lines indicating the atrioventricular openings are slightly below and parallel to the line of the coronary sulcus. Arteries. The line of the ascending aorta begins slightly to the left of the midsternal line opposite the 3rd costal cartilage and extends upward and to the right to the upper border of the 2nd right costal cartilage. The beginning of the aortic arch is indicated by a line from this latter point to the midsternal line about 2.5 centimeters below the jugular notch. The point on the midsternal line is opposite the summit of the arch, and a line from it to the right sternoclavicular articulation represents the site of the innominate artery, while another line from a point slightly to the left of it and passing through the left sternoclavicular articulation indicates the position of the left common carotid artery in the thorax. The internal mammary artery descends behind the first 6 costal cartilages about 1 centimeter from the lateral sternal line. Veins. The line of the right innominate vein crosses the right sternoclavicular joint and the upper border of the first right costal cartilage about 1 centimeter from the lateral sternal line. That of the left innominate vein extends from the left sternoclavicular articulation to meet the right at the upper border of the first right costal cartilage. The junction of the two lines indicates the origin of the superior vena cava, the line of which is continued vertically down to the level of the third right costal cartilage. The end of the inferior vena cava is situated opposite the upper margin of the sixth right costal cartilage, about 2 centimeters from the midsternal line.
Surface anatomy of abdomen. Skin. The skin of the front of the abdomen is thin. In the male it is often thickly hair-clad, especially toward the lower part of the middle line. In the female, the hairs are confined to the pubes. Just below the line of the iliac crest, especially marked in fat subjects, is a shallow groove termed the iliac furrow, while in the site of the inguinal ligament, a sharper fold known as the fold of the groin is easily distinguishable. After distension of the abdomen from pregnancy or other causes, the skin commonly presents transverse white lines, which are quite smooth, being destitute of papillae. These are known as the strata gravidarum, or strata albicantes. The linea nigra of pregnancy is often seen as a pigmented brown streak in the middle line between the umbilicus and symphysis pubis. In the middle line of the front of the abdomen is a shallow furrow which extends from the junction between the body of the sternum with the xiphoid process to a short distance between the umbilicus. It corresponds to the linea alba. The umbilicus is situated in the middle line, but varies in position as regards to its height. In an adult subject it is always placed above the middle point of the body, and in a normal, well-nourished subject it is from 2 to 2.5 centimeters above the level of the tubercles of the iliac crests. Bones. The bones in relation with the surface of the abdomen are 1. The lower part of the vertebral column and the lower ribs, and 2. The pelvis, the former having already been described. The latter will be considered with the lower limb. Muscles. The only muscles of the abdomen which have any considerable influence on surface form are the obliquus externus and the rectus. The upper digitations of origin of obliquus externus are well marked in a muscular subject, interdigitating with those in serratus anterior. The lower digitations are covered by the border of latissimus dorsi and are not visible. The attachment of the obliqui externus and internus to the crest of the ilium forms a thick oblique roll which determines the iliac furrow. Sometimes on the front of the lateral region of the abdomen an undulating line marks the passing of the muscular fibers of the obliquus externus, into its aponeurosis. The lateral markings of the obliquus externus is separated from that of the latissimus dorsi by a small triangular interval, the lumbar triangle, the base of which is formed by the iliac crest, and its floor by obliquus externus. The lateral margin of rectus abdominis is indicated by the linea semilunaris, which may be exactly defined by putting the muscle into action. The surface of the rectus presents 3 transverse furrows, the tendinous inscriptions. The upper 2 of these, viz., one opposite or a little below the tip of the xiphoid process, and the other midway between this point and the umbilicus, are usually well marked. The third, opposite the umbilicus, is not so distinct. Between the 2 recti, the linea alba can be palpated from the xiphoid process to a point just below the umbilicus. It is represented by a distinct dip between the muscles. Beyond this, the muscles are in apposition. Vessels. In thin subjects, the pulsation of the abdominal aorta can be readily felt by making deep pressure in the middle line above the umbilicus. Viscera. Under normal conditions, the various portions of the digestive tube cannot be identified by simple palpation. Peristalsis of the coils of small intestine can be observed in some persons with extremely thin abdominal walls when some degree of constipation exists. In cases of constipation, it is sometimes possible to trace portions of the great intestine by feeling the fecal masses within the gut. In thin persons with relaxed abdominal walls, the iliac colon can be felt in the left iliac region, rolling under the fingers when empty, and forming a distinct tumor when distended. The greater part of the liver lies under cover of the lower ribs and their cartilages, but in the epigastric fossa it comes in contact with the abdominal wall. The position of the liver varies according to the posture of the body. In the erect posture in the adult male, the edge of the liver projects about 1 centimeter below the lower margin of the right costal cartilages, and its inferior margin can often be felt in this situation if the abdominal wall is thin. In the supine position, the liver recedes above the margin of the ribs and cannot then be detected by the finger. In the prone position, it falls forward and is then generally palpable in a patient with loose and lax abdominal walls. Its position varies with the respiratory movements. During a deep inspiration, it descends below the ribs. In expiration, it is raised. Pressure from without, as in tight lacing, by compressing the lower part of the chest, displaces the liver considerably, its interior edge frequently extending as low as the crest of the ilium. Again, its position varies greatly with the state of the stomach and intestines. When these are empty, the liver descends. When they are distended, it is pushed upward. The pancreas can sometimes be felt in emaciated subjects when the stomach and colon are empty, by making deep pressure in the middle line about 7 or 8 centimeters above the umbilicus. The kidneys, being situated at the back of the abdominal cavity and deeply placed, cannot be palpated unless enlarged or misplaced.
Surface markings of the abdomen. Bony landmarks. Above, the chief bony markings are the xiphoid process, the lower 6 costal cartilages, and the anterior ends of the lower 6 ribs. The junction between the body of the sternum and the xiphoid process is on the level of the 10th thoracic vertebra. Below, the main landmarks are the symphysis, pubis, and the pubic crest and tubercle, the anterior superior iliac spine, and the iliac crest. Muscles. The rectus lies between the linea alba and the linea semilunaris. The former is indicated by the middle line, the latter by a curved line, convex lateralward, from the tip of the cartilage of the 9th rib to the pubic tubercle. At the level of the umbilicus, the linea semilunaris is about 7 centimeters from the middle line, the line indicating the junction of the muscular fibers of obliquus externus with its aponeurosis extends from the tip of the 9th costal cartilage to a point just medial to the anterior superior iliac spine. The umbilicus is at the level of the fibrocartilage between the 3rd and 4th lumbar vertebrae. The subcutaneous inguinal ring is situated 1 centimeter above and lateral to the pubic tubercle. The abdominal inguinal ring lies 1 to 2 centimeters above the middle of the inguinal ligament. The position of the inguinal canal is indicated by a line joining these 2 points. Surface lines. For convenience of description of the viscera and of reference to morbid conditions of the contained parts, the abdomen is divided into 9 regions by imaginary planes, 2 horizontal and 2 sagittal, the edges of the planes being indicated by lines drawn on the surface of the body. In the older method, the upper or subcostal horizontal line encircles the body at the level of the lowest points of the 10th costal cartilages. The lower or intertubercular is a line carried through the highest points of the iliac crest seen from the front, i.e., through the tubercles on the iliac crests about 5 centimeters behind the anterior superior spines. An alternative method is that of Addison, who adopts the following lines. 1. An upper transverse, the transpyloric, halfway between the jugular notch and the upper border of the symphysis pubis. This indicates the margin of the transpyloric plane, which in most cases cuts through the pylorus, the tips of the 9th costal cartilages, and the lower border of the first lumbar vertebra. 2. A lower transverse line midway between the upper transverse and the upper border of the symphysis pubis. This is termed the transtubercular, since it practically corresponds to that passing through the iliac tubercles. Behind, its plane cuts the body of the 5th lumbar vertebra. By means of these horizontal planes, the abdomen is divided into 3 zones named from above: the subcostal, umbilical, and hypogastric zones. Each of these is further subdivided into 3 regions by the 2 sagittal planes, which are indicated on the surface by a right and left lateral line drawn vertically through points halfway between the anterior superior iliac spines and the middle line. The middle region of the upper zone is called epigastric, and the 2 lateral regions, the right and left, hypochondriac. The central region of the middle zone is the umbilical, and the 2 lateral regions, the right and left lumbar. The middle region of the lower zone is the hypogastric or pubic, and the lateral are the right and left iliac or inguinal. The middle regions, viz. Epigastric, umbilical, and pubic, can each be divided into right and left portions by the middle line. In the following description of the viscera, the regions marked out by Addison's lines are those referred to. Stomach. The shape of the stomach is constantly undergoing alteration. It is affected by the particular phase of the process of gastric digestion, by the state of the surrounding viscera, and by the amount and character of its contents. Its position also varies with that of the body, so that it is impossible to indicate it on the surface with any degree of accuracy. The measurements given refer to a moderately filled stomach, with the body in the supine position. The cardiac orifice is opposite the 7th costal cartilage, about 2.5 centimeters from the side of the sternum. It corresponds to the level of the 10th thoracic vertebra. The pyloric orifice is on the transpyloric line about 1 centimeter to the right of the middle line, or alternately 5 centimeters below the 7th right sternocostal articulation. It is at the level of the first lumbar vertebra. A curved line, convex downward and to the left, joining these points indicates the lesser curvature. In the left lateral line, the fundus of the stomach reaches as high as the 5th interspace, or the 6th costal cartilage, a little below the apex of the heart. To indicate the greater curvature, a curved line is drawn from the cardiac orifice to the summit of the fundus, thence downward and to the left, finally turning medialward to the pyloric orifice, but passing on its way through the intersection of the left lateral with the transpyloric line. The portion of the stomach which is in contact with the abdominal wall can be represented roughly by a triangular area, the base of which is formed by a line drawn from the tip of the 10th left costal cartilage to the tip of the 9th right cartilage, and the sides by 2 lines drawn from the end of the 8th left costal cartilage to the ends of the base line. A space of some clinical importance, the space of Traub, overlies the stomach and may be thus indicated. It is semilunar in outline and lies within the following boundaries: the lower edge of the left lung, the anterior border of the spleen, the left costal margin and the inferior margin of the left lobe of the liver. Duodenum. The superior part is horizontal and extends from the pylorus to the right lateral line. The descending part is situated medial to the right lateral line, from the transpyloric line to a point midway between the transpyloric and transtubercular lines. The horizontal part runs with a slight upward slope from the end of the descending part to the left of the middle line. The ascending part is vertical and reaches the transpyloric line, where it ends in the duodenojejunal flexure, about 2.5 centimeters to the left of the middle line. Small intestine. The coils of the small intestine occupy the front of the abdomen. For the most part, the coils of the jejunum are situated on the left side, i.e., in the left lumbar and iliac regions, and in the left half of the umbilical region. The coils of the ilium lie toward the right in the right lumbar and iliac regions. In the right half of the umbilical region and in the hypogastric region, a portion of the ilium is within the pelvis. The end of the ilium, i.e. the iliocolic junction, is slightly below and medial to the intersection of the right lateral and transtubercular lines. Cecum and vermiform process. The cecum is in the right iliac and hypogastric regions. Its position varies with its degree of distension, but the midpoint of a line draws from the right anterior superior iliac spine to the upper margin of the symphysis pubis will mark approximately the middle of its lower border. The position of the base of the vermiform process is indicated by a point on the lateral line, on a level with the anterior superior iliac spine. Ascending colon. The ascending colon passes upward through the right lumbar region, lateral to the right lateral line. The right colic flexure is situated in the upper and right angle of intersection of the subcostal and right lateral lines. Transverse colon. The transverse colon crosses the abdomen on the confines of the umbilical and epigastric regions, its lower border being on a level slightly above the umbilicus, its upper border just below the great curvature of the stomach. Descending colon. The left colic flexure is situated in the upper left angle of the intersection between the left lateral and transpyloric lines. The descending colon courses down through the left lumbar region, lateral to the left lateral line, as far as the iliac crest. Iliac colon. The line of the iliac colon is from the end of the descending colon to the left lateral line at the left of the anterior superior iliac spine. Liver. The upper limit of the right lobe of the liver in the middle line is at the level of the junction between the body of the sternum and the xiphoid process. On the right side, the line must be carried upward as far as the fifth costal cartilage in the mammary line, and then downward to reach the seventh rib at the side of the thorax. The upper limit of the left lobe can be defined by continuing this line downward and to the left to the sixth costal cartilage 5 centimeters from the middle line. The lower limit can be indicated by a line drawn 1 centimeter below the lower margin of the thorax on the right side as far as the ninth costal cartilage, thence obliquely upward to the eighth left costal cartilage, crossing to the middle line just above the transpyloric plane, and finally, with a slight left convexity to the end of the line indicating the upper limit. According to Birmingham, the limits of the normal liver may be marked out on the surface of the body in the following manner. Take 3 points. A. 1.25 centimeters below the right nipple. B. 1.25 centimeters below the tip of the 10th rib. C. 2.5 centimeters below the left nipple. Join A and C by a line slightly convex upward, A and B by a line slightly convex lateralward, and B and C by a line slightly convex downward. The fundus of the gallbladder approaches the surface behind the anterior end of the ninth right costal cartilage, close to the lateral margin of the rectus abdominis. Pancreas, figure 1225. The pancreas lies in front of the second lumbar vertebra. Its head occupies the curve of the duodenum and is therefore indicated by the same lines as that viscus. Its neck corresponds to the pylorus. Its body extends along the transpyloric line, the bulk of it lying above this line to the tail, which is in the left hypochondriac region, slightly to the left of the lateral line and above the transpyloric. Spleen. To map out the spleen, the 10th rib is taken as representing its long axis. Vertically, it is situated between the upper border of the 9th and the lower border of the 11th ribs. The highest point is 4 centimeters from the middle line of the back at the level of the tip of the 9th thoracic spinous process. The lowest point is in the mid-axillary line at the level of the first lumbar spinous process. Kidneys. The right kidney usually lies about 1 centimeter lower than the left, but for practical purposes, similar surface markings are taken for each. On the front of the abdomen, the upper pole lies midway between the plane of the lower end of the body of the sternum and the transpyloric plane, 5 centimeters from the middle line. The lower pole is situated between the transpyloric and intertubular planes, 7 centimeters from the middle line. The hilum is on the transpyloric plane, 5 centimeters from the middle line. Round these 3 points, a kidney-shaped figure 4 centimeters to 5 centimeters broad is drawn, 2/3 of which lies medial to the lateral line. To indicate the position of the kidney from the back, the parallelogram of Morris is used. 2 vertical lines are drawn. The first 2.5 centimeters, the second 9.5 centimeters from the middle line. The parallelogram is completed by 2 horizontal lines drawn respectively at the levels of the tips of the spinous process of the 11th thoracic and the lower border of the spinous process of the 3rd lumbar vertebra. The hilum is 5 centimeters from the middle line at the level of the spinous process of the 1st lumbar vertebra. Ureters. On the front of the abdomen, the line of the ureter runs from the hilum of the kidney to the pubic tubercle. On the back, from the hilum vertically downward, passing practically through the posterior superior iliac spine. Vessels. The inferior epigastric artery can be marked out by a line from a point midway between the anterior superior iliac spine and the pubic symphysis to the umbilicus. This line also indicates the lateral boundary of Hesselbach's triangle, an area of importance in connection with inguinal hernia. The other boundaries are the lateral edge of rectus abdominis and the medial half of the inguinal ligament. The line of the abdominal aorta begins in the middle line about 4 centimeters above the transpyloric line and extends to a point 2 centimeters below and to the left of the umbilicus, or more accurately, to a point 2 centimeters to the left of the middle line, on a line which passes through the highest points of the iliac crests. The point of termination of the abdominal aorta corresponds to the level of the 4th lumbar vertebra, a line drawn from it to a point midway between the anterior superior iliac spine and the symphysis pubis indicates the common and external iliac arteries. The common iliac is represented by the upper third of this line, the external iliac by the remaining 2/3. Of the larger branches of the abdominal aorta, the celiac artery is 4 centimeters, the superior mesenteric 2 centimeters above the transpyloric line. The renal arteries are 2 centimeters below the same line. The inferior mesenteric artery is 4 centimeters above the bifurcation of the abdominal aorta. Nerves. The thoracic nerves on the anterior abdominal wall are represented by lines continuing those of the bony ribs. The termination of the 7th nerve is at the level of the xiphoid process. The 10th reaches the vicinity of the umbilicus. The 12th ends about midway between the umbilicus and the upper border of the symphysis pubis. The first lumbar is parallel to the thoracic nerves. Its iliohypogastric branch becomes cutaneous above the subcutaneous inguinal ring. Its ilioinguinal branch at the ring. Surface anatomy of the perineum. Skin. In the middle line of the posterior part of the perineum, and about 4 centimeters in front of the tip of the coccyx, is the anal orifice. The junction of the mucous membrane of the anal canal with the skin of the perineum is marked by a white line, which indicates also the line of contact of the external and internal sphincters. In the anterior part of the perineum, the external genital organs are situated. The skin covering the scrotum is rough and corrugated, but over the penis it is smooth. Extending forward from the anus onto the scrotum and penis is a median ridge, which indicates the scrotal raphe. In the female are seen the skin reduplications forming the labia majora and minora laterally, the frenulum of the labia behind, and the pubis of the clitoris in front. Still more anteriorly is the mons pubis. Bones. In the anterolateral boundaries of the perineum, the whole outline of the pubic arch can be readily traced, ending in the ischial tuberosities. Behind, in the middle line, is the tip of the coccyx. Muscles and ligaments. The margin of the gluteus maximus forms the posterolateral boundary, and in thin subjects, by pressing deeply, the sacrotuberous ligament can be felt through the muscle. The only other muscles influencing surface form are the ischiocavernosus, covering the crus penis, which lies on the side of the pubic arch, and the sphincter ani externus, which, in action, closes the anal orifice and causes a puckering of the skin around it. 10. Surface markings of the perineum. A line drawn transversely across, in front of the ischial tuberosities, divides the perineum into a posterior or rectal, and an anterior or urogenital triangle. This line passes through the central point of the perineum, which is situated about 2.5 centimeters in front of the center of the anal aperture, or, in the male, midway between the anus and the reflection of the skin onto the scrotum. Rectum and anal canal. A finger inserted through the anal orifice is grasped by the sphincter ani externus, passes into the region of the sphincter ani internus, and higher up encounters the resistance of the puborectalis. Beyond this, it may reach the lowest of the transverse rectal folds. In front, the urethral bulb and membranous part of the urethra are first identified, and then about 4 centimeters above the anal orifice, the prostate is felt. Beyond this, the vesiculae seminals if enlarged, and the fundus of the bladder, when distended, can be recognized. On either side is the ischiorectal fossa. Behind are the anococcygeal body, the pelvic surfaces of the coccyx and lower end of the sacrum, and the sacrospinous ligaments. In the female, the posterior wall and fornix of the vagina and the cervix and body of the uterus can be felt in front, while somewhat laterally the ovaries can just be reached. Male urogenital organs. The corpora cavernosa penis can be followed backward to the crura, which are attached to the sides of the pubic arch. The glans penis, covered by the pubis, and the external urethral orifice can be examined, and the course of the urethra traced along the undersurface of the penis to the bulb, which is situated immediately in front of the central point of the perineum. Through the wall of the scrotum on either side of the testis can be palpated. It lies toward the back of the scrotum, and along its posterior border the epididymis can be felt. Passing upward along the medial side of the epididymis is the spermatic cord, which can be traced upward to the subcutaneous inguinal ring. By means of a sound, the general topography of the urethra and bladder can be investigated. With the urethroscope, the interior of the urethra can be illuminated and viewed directly. With the cystoscope, the interior of the bladder is in a similar manner illuminated for visual examination. In the bladder, the main points to which attention is directed are the trigone, the torus uretericus, the plicae uretericae, and the openings of the ureters and urethra. Female urogenital organs. In the pudental cleft between the labia minora and the openings of the vagina and urethra. In the virgin, the vaginal opening is partly closed by the hymen. After coitus, the remains of the hymen are represented by the carunculae hymenals. Between the hymen and the frenulum of the labia is the fossa navicularis, while in the groove between the hymen and the labium minus on either side, the small opening of the greater vestibular Bartholin's gland can be seen. These glands, when enlarged, can be felt on either side of the posterior part of the vaginal orifice. By inserting a finger into the vagina, the following structures can be examined through its wall. Behind, from below upward, are the anal canal, the rectum, and the rectuterine excavation. Projecting into the roof of the vagina is the vaginal portion of the cervix uteri with the external uterine orifice. In front of and behind the cervix, the anterior and posterior vaginal fornices respectively can be examined. With the finger in the vagina and the other hand on the abdominal wall, the whole of the cervix and body of the uterus, the uterine tubes, and the ovaries can be palpated. If a speculum be introduced into the vagina, the walls of the passage, the vaginal portion of the cervix, and the external uterine orifice can be exposed for visual examination. The external urethral orifice lies in front of the vaginal opening. The angular gap in which it is situated between the two converging labia minora is termed the vestibule. The urethral canal in the female is very dilatable and can be explored with the finger. About 2.5 centimeters in front of the external orifice of the urethra are the glans and prepuce of the clitoris, and still farther forward is the mons pubis.
Surface anatomy of upper extremity, Part 1. Skin. The skin covering the shoulder and arm is smooth and very movable on the underlying structures. In the axilla there are numerous hairs and many sudoriferous and sebaceous glands. Over the medial side and front of the forearm, the skin is thin and smooth, and contains few hairs but many sudoriferous glands. Over the lateral side and back of the arm and forearm, it is thicker, denser, and contains more hairs but fewer sudoriferous glands. In the region of the olecranon, it is thick and rough, and is very loosely connected to the underlying tissue, so that it falls into transverse wrinkles when the forearm is extended. At the front of the wrist, there are 3 transverse furrows in the skin. They correspond, respectively, from above downward, to the positions of the styloid process of the ulna, the wrist joint, and the midcarpal joint. The skin of the palm of the hand differs considerably from that of the forearm. At the wrist, it suddenly becomes hard and dense and covered with a thick layer of epidermis. On the thenar eminence, these characteristics are less marked than elsewhere. In spite of its hardness and density, the skin of the palm is exceedingly sensitive and very vascular, but it is destitute of hairs and sebaceous glands. It is tied down by fibrous bands along the lines of flexion of the digits, exhibiting certain furrows of a permanent character. One of these, starting in front of the wrist at the tuberosity of the navicular bone, curves around the thenar eminence and ends on the radial border of the hand a little above the metacarpophalangeal joint of the index finger. A second line begins at the end of the first and extends obliquely across the palm to reach the ulnar border about the middle of the 5th metacarpal bone. A third line begins at the ulnar border about 2.5 centimeters distal to the end of the second and extends across the heads of the 5th, 4th, and 3rd metacarpal bones. The proximal segments of the fingers are joined to one another on the volar aspect by folds of skin constituting the web of the fingers. These folds extend across about the level of the centers of the proximal phalanges, and their free margins are continuous with the transverse furrows at the roots of the fingers. Since the web is confined to the volar aspect, the fingers appear shorter when viewed from in front than from behind. Over the fingers and thumb, the skin again becomes thinner, especially at the flexures of the joints where it is crossed by transverse furrows, and over the terminal phalanges. It is disposed on numerous ridges in consequence of the arrangement of the papillae in it. These ridges form, in different individuals, distinctive and permanent patterns which can be used for purposes of identification. The superficial fascia in the palm of the hand is made up of dense fibrofatty tissue which binds the skin so firmly to the palmar aponeurosis that very little movement is permitted between the two. On the back of the hand and fingers, the subcutaneous tissue is lax, so that the skin is freely movable on the underlying parts. Over the interphalangeal joints, the skin is very loose and is thrown into transverse wrinkles when the fingers are extended. Bones. The clavicle can be felt throughout its entire length. The enlarged sternal extremity projects above the upper margin of the sternum at the side of the jugular notch, and from this the body of the bone can be traced lateralward immediately under the skin. The medial part is convex forward, but the surface is partially obscured by the attachments of the sternocleido mastoideus and pectoralis major. The lateral third is concave forward and ends at the acromion of the scapula in a slight enlargement. The clavicle is almost horizontal when the arm is lying by the side, although in muscular subjects it may incline a little upward at its acromial end, which is on a plane posterior to the sternal end. The only parts of the scapula that are truly subcutaneous are the spine and acromion, but the coracoid process, the vertebral border, the inferior angle, and to a lesser extent the axillary border, can also be readily defined. The acromion and spine are easily recognizable throughout their entire extent, forming with the clavicle the arch of the shoulder. The acromion forms the point of the shoulder. It joins the clavicle at an acute angle, the acromial angle, slightly medial to and behind the tip of the acromion. The spine can be felt as a distinct ridge, marked on the surface as an oblique depression which becomes less distinct and ends in a slight dimple, a little lateral to the spinous processes of the vertebrae. Below this point, the vertebral border can be traced downward and lateralward to the inferior angle, which can be identified although covered by latissimus dorsi. From the inferior angle, the axillary border can usually be traced upward through its thick muscular covering, forming with its enveloping muscles the posterior fold of the axilla. The coracoid process is situated about 2 centimeters below the junction of the intermediate and lateral thirds of the clavicle. It is covered by the anterior border of deltoideus, and thus lies a little lateral to the infraclavicular fossa or depression, which marks the interval between the pectoralis major and deltoideus. The humerus is almost entirely surrounded by muscles, and the only parts which are strictly subcutaneous are small portions of the medial and lateral epicondyles. In addition to these, however, the tubercles and a part of the head of the bone can be felt under the skin and muscles by which they are covered. Of these, the greater tubercle forms the most prominent bony point of the shoulder, extending beyond the acromion. It is best recognized when the arm is lying passive by the side, for if the arm be raised, it recedes under the arch of the shoulder. The lesser tubercle, directed forward, is medial to the greater and separated from it by the intertubercular groove, which can be made out by deep pressure. When the arm is abducted, the lower part of the head of the humerus can be examined by pressing deeply into the axilla. On either side of the elbow joint and just above it are the medial and lateral epicondyles. Of these, the former is the more prominent, but the medial supracondylar ridge passing upward from it is much less marked than the lateral, and as a rule is not palpable. Occasionally, however, the hook-shaped supracondylar process is found on this border. The position of the lateral epicondyle is best seen during semiflexion of the forearm and is indicated by a depression. From it, the strongly marked lateral supracondylar ridge runs upward. The most prominent part of the ulna, the olecranon, can always be identified at the back of the elbow joint. When the forearm is flexed, the upper quadrilateral surface is palpable, but during extension it recedes into the olecranon fossa. During extension, the upper border of the olecranon is slightly above the level of the medial epicondyle, and nearer to this than to the lateral. When the forearm is fully flexed, the olecranon and the epicondyles form the angles of an equilateral triangle. On the back of the olecranon is a smooth triangular subcutaneous surface, and running down the back of the forearm from the apex of this triangle, the prominent dorsal border of the ulna can be felt in its whole length. It has a sinuous outline and is situated in the middle of the back of the limb above, but below, where it is rounded off, it can be traced to the small subcutaneous surface of the styloid process on the medial side of the wrist. The styloid process forms a prominent tubercle continuous above with the dorsal border and ending below in a blunt apex at the level of the wrist joint. It is most evident when the hand is in a position midway between supination and pronation. When the forearm is pronated, another prominence, the head of the ulna, appears behind and above the styloid process. Below the lateral epicondyle of the humerus, a portion of the head of the radius is palpable. Its position is indicated on the surface by a little dimple, which is best seen when the arm is extended. If the finger be placed in this dimple and the semi-flexed forearm be alternately pronated and supinated, the head of the radius will be felt distinctly rotating in the radial notch. The upper half of the body of the bone is obscured by muscles. The lower half, though not subcutaneous, can be readily examined, and if traced downward is found to end in a lozenge-shaped convex surface on the lateral side of the base of the styloid process. This is the only subcutaneous part of the bone, and from its lower end the apex of the styloid process bends medialward toward the wrist. About the middle of the dorsal surface of the lower end of the radius is the dorsal radial tubercle, best perceived when the wrist is slightly flexed. It forms the lateral boundary of the oblique groove for the tendon of the extensor pollicis longus. On the front of the wrist are two subcutaneous eminences, one on the radial side, the larger and flatter, produced by the tuberosity of the navicular and the ridge on the greater multangular, the other on the ulnar side by the pisiform. The tuberosity of the navicular is distal and medial to the styloid process of the radius, and is most clearly visible when the wrist joint is extended. The ridge on the greater multangular is about 1 centimeter distal to it. The pisiform is about 1 centimeter distal to the lower end of the ulna, and just distal to the level of the styloid process of the radius. It is crossed by the uppermost crease which separates the front of the forearm from the palm of the hand. The rest of the volar surface of the bony carpus is covered by tendons and the transverse carpal ligament and is entirely concealed, with the exception of the hamulus of the hamate bone, which, however, is difficult to define. On the dorsal surface of the carpus, only the triangular bone can be clearly made out. Distal to the carpus, the dorsal surfaces of the metacarpal bones, covered by the extensor tendons, except the fifth, are visible only in very thin hands. The dorsal surface of the fifth is, however, subcutaneous throughout almost its whole length. Slightly lateral to the middle line of the hand is a prominence, frequently well marked but occasionally indistinct, formed by the styloid process of the third metacarpal bone. It is situated about 4 centimeters distal to the dorsal radial tubercle. The heads of the metacarpal bones can be plainly seen and felt, rounded in contour and standing out in bold relief under the skin when the fist is clenched. The head of the third is the most prominent. In the palm of the hand, the metacarpal bones are covered by muscles, tendons, and aponeuroses, so that only their heads can be distinguished. The base of the metacarpal bone of the thumb, however, is prominent dorsally, distal to the styloid process of the radius. The body of the bone is easily palpable, ending at the head in a flattened prominence, in front of which are the sesamoid bones. The enlarged ends of the phalanges can be easily felt. When the digits are bent, the proximal phalanges form prominences, which in the joints between the first and second phalanges are slightly hollow, but flattened and square-shaped in those between the second and third. Articulations. The sternoclavicular joint is subcutaneous, and its position is indicated by the enlarged sternal extremity of the clavicle, lateral to the long cord-like sternal head of sternocleidomastoideus. If this muscle be relaxed, a depression between the end of the clavicle and the sternum can be felt, defining the exact position of the joint. The position of the acromioclavicular joint can generally be ascertained by determining the slightly enlarged acromial end of the clavicle, which projects above the level of the acromion. Sometimes this enlargement is so considerable as to form a rounded eminence. The shoulder joint is deeply seated and cannot be palpated. If the forearm be slightly flexed, a curved crease or fold with its convexity downward is seen in front of the elbow, extending from one epicondyle to the other. The elbow joint is slightly distal to the center of the fold. The position of the radiohumeral joint can be ascertained by feeling for a slight groove or depression between the head of the radius and the capitulum of the humerus, at the back of the elbow joint. The position of the proximal radio-ulnar joint is marked on the surface at the back of the elbow by the dimple which indicates the position of the head of the radius. The site of the distal radio-ulnar joint can be defined by feeling for the slight groove at the back of the wrist, between the prominent head of the ulna and the lower end of the radius, when the forearm is in a state of almost complete pronation. Of the 3 transverse skin furrows on the front of the wrist, the middle corresponds fairly accurately with the wrist joint, while the most distal indicates the position of the midcarpal articulation. The metacarpophalangeal and interphalangeal joints are readily available for surface examination. The former are situated just distal to the prominences of the knuckles. The latter are sufficiently indicated by the furrows on the volar and the wrinkles on the dorsal surfaces.
Muscles. The anterior border of the trapezius presents as a slight ridge running downward and forward from the superior neutral line of the occipital bone to the junction of the intermediate and lateral thirds of the clavicle. The inferior border of the muscle forms an undulating ridge passing downward and medialward from the root of the spine of the scapula to the spinous process of the 12th thoracic vertebra. The lateral border of the latissimus dorsi may be traced when the muscle is in action as a rounded edge starting from the iliac crest and slanting obliquely forward and upward to the axilla, where it takes part with a teres major in forming the posterior axillary fold. The pectoralis major conceals a considerable part of the thoracic wall in front. Its sternal organ presents a border which bounds and determines the width of the sternal furrow. The upper margin is generally well marked medially and forms the medial boundary of a triangular depression, the infraclavicular fossa, which separates the pectoralis major from the deltoideus. It gradually becomes less marked as it approaches the tendon of insertion and is closely blended with the deltoideus. The lower border of pectoralis major forms the rounded anterior axillary fold. Occasionally, a gap is visible between the clavicular and sternal parts of the muscle. When the arm is raised, the lowest slip of origin of pectoralis minor produces a fullness just below the anterior axillary fold and serves to break the sharp outline of the lower border of pectoralis major. The origin of the serratus anterior causes a very characteristic surface marking. When the arm is abducted, the lower 5 or 6 serrations form a zigzag line with a general convexity forward. When the arm is by the side, the highest visible serration is that attached to the fifth rib. The deltoideus, with the prominence of the upper end of the humerus, produces the rounded contour of the shoulder. It is rounded and fuller in front than behind, where it presents a somewhat flattened form. Above, its anterior border presents a slightly curved eminence, which forms the lateral boundary of the infraclavicular fossa. Below, it is closely united with the pectoralis major. Its posterior border is thin, flattened, and scarcely marked above, but is thicker and more prominent below. The insertion of deltoideus is marked by a depression on the lateral side of the middle of the arm. Of the scapular muscles, the only one which influences surface form is the teres major. It assists the latissimus dorsi in forming the thick, rounded posterior axillary fold. When the arm is raised, the cora cobrachialis reveals itself as a narrow elevation emerging from under cover of the anterior axillary fold and running medial to the body of the humerus. On the front and medial aspects of the arm is the prominence of the biceps brachii, bounded on either side by an interior muscular depression. It determines the contour of the front of the arm and extends from the anterior axillary fold to the bend of the elbow. Its upper tendons are concealed by the pectoralis major and deltoideus, and its lower tendon sinks into the antecubital fossa. When the muscle is fully contracted, it presents a globular form, and the lacertus fibrosus attached to its tendon of insertion becomes prominent as a sharp ridge running downward and medialward. On either side of the biceps brachii at the lower part of the arm, the brachialis is discernible. Laterally, it forms a narrow eminence extending some distance up the arm. Medially, it exhibits only a little fullness above the elbow. On the back of the arm, the long head of the triceps brachii may be seen as a longitudinal eminence, emerging from under cover of deltoideus and gradually passing into the flattened plane of the tendon of the muscle at the lower part of the back of the arm. When the muscle is in action, the medial and lateral heads become prominent. On the front of the elbow are two muscular elevations, one on either side, separate above but converging below, so as to form the medial and lateral boundaries of the antecubital fossa. The medial elevation consists of the pronator teres and the flexors, and forms a fusiform mass, pointed above at the medial epicondyle and gradually tapering off below. The pronator teres is the most lateral of the group, while the flexor carpi radialis, lying to its medial side, is the most prominent and may be traced downward to its tendon, which is situated nearer to the radial than to the ulnar border of the front of the wrist and medial to the radial artery. The palmaris longus presents no surface marking above, but below, its tendon stands out when the muscle is in action as a sharp, tense cord in front of the middle of the wrist. The flexor digitorum sublimis does not directly influence surface form. The position of its four tendons on the front of the lower part of the forearm is indicated by an elongated depression between the tendons of palmaris longus and flexor carpi ulnaris. The flexor carpi ulnaris determines the contour of the medial border of the forearm and is separated from the extensor group of muscles by the ulnar furrow produced by the subcutaneous dorsal border of the ulna. Its tendon is evident along the ulnar border of the lower part of the forearm and is most marked when the hand is flexed and adducted. The elevation forming the lateral side of the antecubital fossa consists of the brachioradialis, the extensors, and the supinator. It occupies the lateral and a considerable part of the dorsal surface of the forearm in the region of the elbow, and forms a fusiform mass which is altogether on a higher level than that produced by the medial elevation. Its apex is between the triceps brachii and brachialis, some distance below the elbow joint. It acquires its greatest breadth opposite the lateral epicondyle. and below this shades off into a flattened surface. About the middle of the forearm, it divides into two diverging longitudinal eminences. The lateral eminence consists of brachioradialis and the extensoris carpi radialis longus and brevis, and descends from the lateral supracondylar ridge in the direction of the styloid process of the radius. The medial eminence comprises the extensor digitorum communis, extensor digiti quinti proprius, and the extensor carpi ulnaris. It begins at the lateral epicondyle of the humerus as a tapering mass which is separated above from the acroneus from a well-marked furrow, and below from the pronator teres and the flexor group by the ulnar furrow. The medial border of the brachioradialis starts as a rounded elevation above the lateral epicondyle. Lower down, the muscle forms a prominent mass on the radial side of the upper part of the forearm. Below, it tapers to its tendon, which may be traced to the styloid process of the radius. The acroneus presents a triangular, slightly elevated area immediately lateral to the subcutaneous surface of the olecranon and differentiated from the extensor group by an oblique depression. The upper angle of the triangle is at the dimple over the lateral epicondyle. At the lower part of the back of the forearm, in the interval between the two diverging eminences, is an oblique elongated swelling, full above but flattened and partially subdivided below. It is caused by the abductor pollicis longus and the extensor pollicis brevis. It crosses the dorsal and lateral surfaces of the radius to the radial side of the wrist joint, whence it is continued on to the dorsal surface of the thumb as a ridge best marked when the thumb is extended. The tendons of most of the extensor muscles can be seen and felt on the back of the wrist. Laterally is the oblique ridge produced by the extensor pollicis longus. The extensor carpi radialis longus is scarcely palpable, but the extensor carpi radialis brevis can be identified as a vertical ridge emerging from under the ulnar border of the tendon of the extensor pollicis longus when the wrist is extended. Medial to this, the extensor tendons of the finger can be felt, the extensor digiti quinti proprius being separated from the tendons of the extensor digitorum communis by a slight furrow. The muscles of the hand are principally concerned, as regards surface form, in producing the thenar and hypothenar eminences, and cannot be individually distinguished. The thenar eminence on the radial side is larger and rounder than the hypothenar, which is a long, narrow elevation along the ulnar side of the palm. When the palmaris brevis is in action, it produces a wrinkling of the skin over the hypothenar eminence and a dimple on the ulnar border. On the back of the hand, the interossi dorsalis give rise to the elongated swellings between the metacarpal bones. The first forms a prominent fusiform bulging when the thumb is adducted. The others are not so marked. Arteries. Above the middle of the clavicle, the pulsation of the subclavian artery can be detected by pressing downward, backward, and medialward against the first rib. The pulsation of the axillary artery as it crosses the second rib can be felt below the middle of the clavicle, just medial to the coracoid process. Along the lateral wall of the axilla, the course of the artery can be easily followed close to the medial border of the coracobrachialis. The brachial artery can be recognized in practicality the whole of this extent along the medial margin of the biceps. In the upper two-thirds of the arm it lies medial to the humerus, but in the lower third it is more directly on the front of the bone. Over the lower end of the radius, between the styloid process and flexor carpi radialis, a portion of the radial artery is superficial and is used clinically for observations on the pulse. Veins. The superficial veins of the upper extremity are easily rendered visible by compressing the proximal trunks. Their arrangement is described on pages 660 to 662. Nerves. The uppermost trunks of the brachial plexus are palpable for a short distance above the clavicle as they emerge from under the lateral border of the sternocleidomastoideus. The larger nerves, derived from the plexus, can be rolled under the finger against the lateral axillary wall but cannot be identified. The ulnar nerve can be detected in the groove behind the medial epicondyle of the humerus.
Surface markings of the upper extremity. Bony landmarks. The bony landmarks as described above are so readily available for surface recognition that no special measurements are required to indicate them. It may be noted, however, that the medial angle of the scapula is applied to the second rib, while the inferior angle lies against the seventh. The intertubercular groove of the humerus is vertically below the acromioclavicular joint when the arm hangs by the side with the palm of the hand forward. Articulations. The acromioclavicular joint is situated in a plane passing sagittally through the middle line of the front of the arm. The line of the elbow joint is not straight. The radiohumeral portion is practically at right angles to the long axis of the humerus and is situated about 2 centimeters distal to the lateral epicondyle. The ulnohumeral portion is oblique, and its medial end is about 2.5 centimeters distal to the medial epicondyle. The position of the wrist joint can be indicated by drawing a curved line with its convexity upward between the styloid processes of the radius and ulna. The summit of the convexity is about 1 centimeter above the center of a straight line joining the two processes. Muscles. The only muscles of the upper extremity which occasionally require definition by surface lines are the trapezius, the latissimus dorsi, and the pectoralis major and minor. The antero-superior border of trapezius is indicated by a line from the superior nuchal line about 3 centimeters lateral to the external occipital protuberance to the junction of the intermediate and lateral thirds of the clavicle. The line of the lower border extends from the spinous process of the 12th thoracic vertebra to the vertebral border of the scapula at the root of the spine. The upper border of latissimus dorsi is almost horizontal, running from the spinous process of the 7th thoracic vertebra to the inferior angle of the scapula, and thence somewhat obliquely to the intertubercular sulcus of the humerus. The lower border corresponds roughly to a line drawn from the iliac crest, about 2 centimeters from the lateral margin of the sacrospinalis to the intertubercular sulcus. The upper margin of pectoralis major extends from the middle of the clavicle to the surgical neck of the humerus. Its lower border is practically in the line of the 5th rib and reaches from the 5th costochondral junction to the middle of the anterior border of deltoideus. The two lines indicating the borders of pectoralis minor begin at the coracoid process of the scapula and extend to the 3rd and 5th ribs respectively, just lateral to the corresponding costal cartilages. On the front of the elbow joint, a triangular space, the antecubital fossa, is mapped out for convenience of reference. The base of the triangle is a line joining the medial and lateral epicondyles, while the sides are formed respectively by the salient margins of the brachioradialis and pronator teres. Mucus sheaths. On the volar surfaces of the wrist and hand, the mucus sheaths of the flexor tendons can be indicated as follows. The sheath for flexor pollicis longus extends from about 3 centimeters above the upper edge of the transverse carpal ligament to the terminal phalanx of the thumb. The common sheath for the flexoris digitorum reaches about 3.5 to 4 centimeters above the upper edge of the transverse carpal ligament, and extends on the palm of the hand to about the level of the centers of the metacarpal bones. The sheath for the tendons to the little finger is continued from the common sheath to the base of the terminal phalanx of this finger. The sheaths for the tendons of the other fingers are separated from the common sheath by an interval. They begin opposite the necks of the metacarpal bones and extend to the terminal phalanges. Arteries. The course of the axillary artery can be marked out by abducting the arm to a right angle, and drawing a line from the middle of the clavicle to the point where the tendon of the pectoralis major crosses the prominence of the coracobrachialis. Of the branches of the axillary artery, the origin of the thoracoacromial corresponds to the point where the artery crosses the upper border of pectoralis minor. The lateral thoracic takes practically the line of the lower border of pectoralis minor. The subscapular is sufficiently indicated by the axillary border of the scapula. The scapular circumflex is given off the subscapular opposite the midpoint of a line joining the tip of the acromion to the lower edge of the deltoid tuberosity, while the humeral circumflex arteries arise from the axillary about 2 centimeters above this. The position of the brachial artery is marked by a line drawn from the junction of the anterior and middle thirds of the distance between the anterior and posterior axillary folds to a point midway between the epicondyles of the humerus and continued distally for 2.5 centimeters, at which point the artery bifurcates. With regard to the branches of the brachial artery, the profunda crosses the back of the humerus at the level of the insertion of deltoideus. The nutrient is given off opposite the middle of the body of the humerus. A line from this point to the back of the medial condyle represents the superior ulnar collateral. The inferior ulnar collateral is given off about 5 centimeters above the fold of the elbow joint and runs directly medialward. The position of the radial artery in the forearm is represented by a line from the lateral margin of the biceps tendon in the center of the antecubital fossa to the medial side of the front of the styloid process of the radius when the limb is in the position of supination. The situation of the distal portion of the artery is indicated by continuing this line around the radial side of the wrist to the proximal end of the first intermetacarpal space. On account of the curved direction of the ulnar artery, 2 lines are required to indicate its course. One is drawn from the front of the medial epicondyle to the radial side of the pisiform bone. The lower 2/3 of this line represents 2/3 of the artery. The upper third is represented by a second line from the center of the hollow in the front of the elbow joint to the junction of the upper and middle thirds of the first line. The superficial volar arch can be indicated by a line starting from the radial side of the pisiform bone and curving distalward and lateralward as far as the base of the thumb, with its convexity toward the fingers. The summit of the arch is usually on a level with the ulnar border of the outstretched thumb. The deep volar arch is practically transverse and is situated about 1 centimeter nearer to the carpus. Nerves. In the arm, the line of the median nerve is practically the same as that for the brachial artery. At the bend of the elbow, the nerve is medial to the artery. The course of the nerve in the forearm is marked by a line starting from a point just medial to the center of one joining the epicondyles and extending to the lateral margin of the tendon of palmaris longus at the wrist. The ulnar nerve follows the line of the brachial artery in the upper half of the arm, but at the middle of the arm it diverges and descends to the back of the medial epicondyle. In the forearm it is represented by a line from the front of the medial epicondyle to the radial side of the pisiform bone. The course of the radial nerve can be indicated by a line from just below the posterior axillary fold to the lateral side of the humerus at the junction of its middle and lower thirds. Thence it passes vertically downward on the front of the arm to the level of the lateral epicondyle. The course of the superficial radial nerve is represented by a continuation of this line downward to the junction of the middle and lower thirds of the radial artery. It then crosses the radius and runs distalward to the dorsum of the base of the first metacarpal bone. The axillary nerve crosses the humerus about 2 centimeters above the center of a line joining the tip of the acromion to the lower edge of the deltoid tuberosity.
Surface anatomy of the lower extremity. Skin. The skin of the thigh, especially in the hollow of the groin and on the medial side, is thin, smooth, and elastic, and contains few hairs except in the neighborhood of the pubis. Laterally it is thicker and the hairs are more numerous. The junction of the skin of the thigh with that on the front of the abdomen is marked by a well-defined furrow which indicates the site of the inguinal ligament. The furrow presents a general convexity downward, but its medial half, which is the better marked, is nearly straight. The skin over the buttock is fairly thick, and is characterized by its low sensibility and slight vascularity. As a rule it is destitute of conspicuous hairs, except toward the post-anal furrow, where in some males they are abundantly developed. An almost transverse fold, the gluteal fold, crosses the lower part of the buttock. It practically bisects the lower margin of the gluteus maximus, and is most evident during extension of the hip joint. The skin over the front of the knee is covered by thickened epidermis. It is loose and thrown into transverse wrinkles when the leg is extended. The skin of the leg is thin, especially on the medial side, and is covered with numerous large hairs. On the dorsum of the foot, the skin is thin, loosely connected to subjacent parts, and contains few hairs. On the plantar surface, and especially over the heel, the epidermis is of great thickness, and here, as in the palm of the hand, there are neither hairs nor sebaceous glands. Bones. The hip bones are largely covered with muscles, so that only at a few points do they approach the surface. In front, the anterior superior iliac spine is easily recognized, and in thin subjects stands out as a prominence at the lateral end of the fold of the groin. In fat subjects, its position is indicated by an oblique depression, at the bottom of which the bony process can be felt. Proceeding upward and backward from this process, the sinuously curved iliac crest can be traced to the posterior superior iliac spine, the site of which is indicated by a slight depression. On the outer lip of the crest, about 5 centimeters behind the anterior superior spine, is the prominent iliac tubercle. In thin subjects the pubic tubercle is very apparent, but in the obese it is obscured by the pubic fat. It can, however, be detected by following up the tendon of origin of adductor longus. Another part of the bony pelvis which is accessible to touch is the ischial tuberosity situated beneath the gluteus maximus, and when the hip is flexed, easily felt, as it is then uncovered by muscle. The femur is enveloped by muscles, so that in fairly muscular subjects the only accessible parts are the lateral surface of the greater trochanter and the lower expanded end of the bone. The site of the greater trochanter is generally indicated by a depression, owing to the thickness of the glutei medius and minimus, which project above it. When, however, the thigh is flexed, and especially if it be crossed over the opposite one, the trochanter produces a blunt eminence on the surface. The lateral condyle is more easily felt than the medial. Both epicondyles can be readily identified, and at the upper part of the medial condyle the sharp adductor tubercle can be recognized without difficulty. When the knee is flexed, a portion of the patellar surface is uncovered and is palpable. The anterior surface of the patella is subcutaneous. When the knee is extended, the medial border of the bone is a little more prominent than the lateral, and if the quadriceps femoris be relaxed, the bone can be moved from side to side. When the joint is flexed, the patella recedes into the hollow between the condyles of the femur and the upper end of the tibia, and becomes firmly applied to the femur. A considerable portion of the tibia is subcutaneous. At the upper end the condyles can be felt just below the knee. The medial condyle is broad and smooth, and merges into the subcutaneous surface of the body below. The lateral is narrower and more prominent, and on it, about midway between the apex of the patella and the head of the fibula, is the tubercle for the attachment of the iliotibial band. In front of the upper end of the bone, between the condyles, is an oval eminence, the tuberosity, which is continuous below with the anterior crest of the bone. This crest can be identified in the upper 2/3 of its extent as a flexuous ridge, but in the lower third it disappears, and the bone is concealed by the tendons of the muscles on the front of the leg. Medial to the anterior crest is the broad surface, slightly encroached on by muscles in front and behind. The medial malleolus forms a broad prominence, situated at a higher level, and somewhat farther forward than the lateral malleolus. It overhangs the medial border of the arch of the foot. Its anterior border is nearly straight, Its posterior presents a sharp edge which forms the medial margin of the groove for the tendon of tibialis posterior. The only subcutaneous parts of the fibula are the head, the lower part of the body, and the lateral malleolus. The head lies behind and lateral to the lateral condyle of the tibia, and presents as a small prominent pyramidal eminence, slightly above the level of the tibial tuberosity. Its position can be readily located by following downward the tendon of biceps femoris. The lateral malleolus is a narrow elongated prominence, from which the lower third or half of the lateral surface of the body of the bone can be traced upward. On the dorsum of the tarsus the individual bones cannot be distinguished, with the exception of the head of the talus, which forms a rounded projection in front of the ankle joint when the foot is forcibly extended. The whole dorsal surface of the foot has a smooth convex outline, the summit of which is the ridge formed by the head of the talus, the navicular, the second cuneiform, and the second metatarsal bone. From this it inclines gradually lateralward and rapidly medialward. On the medial side of the foot, the medial process of the tuberosity of the calcaneus and the ridge separating the posterior from the medial surface of the bone are distinguishable. In front of this, and below the medial malleolus, is the sustentaculum tali. The tuberosity of the navicular is palpable about 2.5 to 3 centimeters in front of the medial malleolus. Farther forward, the ridge formed by the base of the first metatarsal bone can be obscurely felt, and from this the body of the bone can be traced to the expanded head. Beneath the base of the first phalanx is the medial sesamoid bone. On the lateral side of the foot, the most posterior bony point is the lateral process of the tuberosity of the calcaneus, with the ridge separating the posterior from the lateral surface of the bone. In front of this, the greater part of the lateral surface of the calcaneus is subcutaneous. On it, below and in front of the lateral malleolus, the trochlear process, when present, can be felt. Farther forward, the base of the fifth metatarsal bone is prominent, and from it the body and expanded head can be traced. As in the case of the metacarpals, the dorsal surfaces of the metatarsal bones are easily defined, although their heads do not form prominences. The plantar surfaces are obscured by muscles. The phalanges, in their whole extent, are readily palpable. Articulations. The hip joint is deeply seated and cannot be palpated. The interval between the tibia and femur can always be easily felt. If the knee joint be extended, this interval is on a higher level than the apex of the patella, but if the joint be slightly flexed, it is directly behind the apex. When the knee is semi-flexed, the medial borders of the patella and of the medial condyle of the femur, and the upper border of the medial condyle of the tibia, bound a triangular depressed area which indicates the position of the joint. The ankle joint can be felt on either side of the extensor tendons, and during extension of the joint, the superior articular surface of the talus presents below the anterior border of the lower end of the tibia. Muscles. Of the muscles of the thigh, those of the anterior femoral region contribute largely to surface form. The tensor fascia lata produces a broad elevation immediately below the anterior part of the iliac crest and behind the anterior superior iliac spine. From its lower border, a groove caused by the iliotibial band extends downward to the lateral side of the knee joint. The upper portion of sartorius constitutes the lateral boundary of the femoral triangle, and when the muscle is in action, forms a prominent oblique ridge which is continued below into a flattened plane, and then gradually merges into a general fullness on the medial side of the knee joint. When the sartorius is not in action, a depression exists between the quadriceps femoris and the adductors, and extends obliquely downward and medialward, from the apex of the femoral triangle to the side of the knee. In the angle formed by the divergence of sartorius and tensor fascia lata, just below the anterior superior iliac spine, the rectus femoris appears, and in a muscular subject its borders can be clearly defined when the muscle is in action. The vastus lateralis forms a long flattened plane traversed by the groove of the iliotibial band. The vastus medialis gives rise to a considerable prominence on the medial side of the lower half of the thigh, This prominence increases toward the knee, and ends somewhat abruptly with a full curved outline. The vastus intermedius is completely hidden. The adductores cannot be differentiated from one another, with the exception of the upper tendon of adductor longus and the lower tendon of adductor magnus. When the adductor longus is in action, its upper tendon stands out as a prominent ridge running obliquely downward and lateralward from the neighborhood of the pubic tubercle and forming the medial border of the femoral triangle. The lower tendon of adductor magnus can be distinctly felt as a short ridge extending downward between the sartorius and vastus medialis to the adductor tubercle. The adductores fill in the triangular space at the upper part of the thigh, between the femur and the pelvis, and to them is due the contour of the medial border of the thigh, the gracilis contributing largely to the smoothness of the outline. The gluteus maximus forms the full rounded outline of the buttock. It is more prominent behind, compressed in front, and ends at its tendinous insertion in a depression immediately behind the greater trochanter. Its lower border crosses the gluteal fold obliquely downward and lateralward. The upper is part of gluteus medius and is visible, but its lower part with gluteus minimus and the external rotators are completely hidden. From beneath the lower margin of gluteus maximus the hamstrings appear. At first they are narrow and not well defined, but as they descend they become more prominent and eventually divide into two well-marked ridges formed by their tendons. These constitute the upper boundaries of the popliteal fossa. The tendon of biceps femoris is a thick cord running to the head of the fibula. The tendons of the semimembranosus and semitendinosus, as they run medialward to the tibia, are separated by a slight furrow. The semitendinosus is the more medial, and can be felt in certain positions of the limb as a sharp cord, while the semimembranosus is thick and rounded. The gracilis is situated a little in front of them. The tibialis anterior presents a fusiform enlargement at the lateral side of the tibia, and projects beyond the anterior crest of the bone. Its tendon can be traced on the front of the tibia and ankle joint, and thence along the medial side of the foot to the base of the first metatarsal bone. The fleshy fibers of peroneus longus are strongly marked at the upper part of the lateral side of the leg. It is separated by furrows from extensor digitorum longus in front, and soleus behind. Below, the fleshy fibers end abruptly in a tendon which overlaps the more flattened elevation of peroneus brevis. Below the lateral malleolus, the tendon of peroneus brevis is the more marked. On the dorsum of the foot, the tendons emerging from beneath the transverse and cruciate crural ligaments spread out and can be distinguished as follows. The most medial and largest is tibialis anterior. The next is extensor hallucis proprius, then extensor digitorum longus dividing into 4 tendons to the second, third, fourth, and fifth toes, and lastly peroneus tertius. The extensor digitorum brevis produces a rounded outline on the dorsum of the foot and a fullness in front of the lateral malleolus. The interossei dorsalis bulge between the metatarsal bones. At the back of the knee is the popliteal fossa, bounded above by the tendons of the hamstrings and below by the gastrocnemius. Below this fossa is the prominent fleshy mass of the calf of the leg produced by gastrocnemius and soleus. When these muscles are in action, the borders of gastrocnemius form 2 well-defined curved lines, which converge to the tendocalcaneus. The medial border is the more prominent. At the same time, the edges of soleus can be seen forming, on either side of gastrocnemius, curved eminences, of which the lateral is the longer. The fleshy mass of the calf ends somewhat abruptly in the tendocalcaneus, which tapers in the upper 3/4 of its extent, but widens out slightly below. Behind the medial border of the lower part of the tibia, a well-defined ridge is produced by the tendon of tibialis posterior during contraction of the muscle. On the sole of the foot, the abductor digiti quinti forms a narrow rounded elevation on the lateral side, and the abductor hallucis a lesser elevation on the medial side. The flexor digitorum brevis, bound down by the plantar aponeurosis, is not very apparent. It produces a flattened form, and the thickened skin underlying it is thrown into numerous wrinkles. Arteries. The femoral artery, as it crosses the brim of the pelvis, is readily felt. In its course down the thigh, its pulsation becomes gradually more difficult of recognition. When the knee is flexed, the pulsation of the popliteal artery can easily be detected in the popliteal fossa. On the lower part of the front of the tibia, the anterior tibial artery becomes superficial and can be traced over the ankle into the dorsalis pedis. The latter can be followed to the proximal end of the first intermetatarsal space. The pulsation of the posterior tibial artery becomes evident near the lower end of the back of the tibia, and is easily detected behind the medial malleolus. Veins. By compressing the proximal trunks, the venous arch on the dorsum of the foot, together with the great and small saphenous veins leading from it, are rendered visible. Nerves. The only nerve of the lower extremity which can be located by palpation is the common perineal as it winds around the lateral side of the neck of the fibula. Surface markings of the lower extremity. Bony landmarks. The anterior superior iliac spine is at the level of the sacral promontory, the posterior at the level of the spinous process of the second sacral vertebra. A horizontal line through the highest points of the iliac crests passes also through the spinous process of the fourth lumbar vertebra, while, as already pointed out, the transtubercular plane through the tubercles on the iliac crests cuts the body of the fifth lumbar vertebra. The upper margin of the greater sciatic notch is opposite the spinous process of the third sacral vertebra, and slightly below this level is the posterior inferior iliac spine. The surface markings of the posterior inferior iliac spine and the ischial spine are both situated in a line which joins the posterior superior iliac spine to the outer part of the ischial tuberosity. The posterior inferior spine is 5 cm and the ischial spine 10 cm below the posterior superior spine. The ischial spine is opposite the first piece of the coccyx. With the body in the erect posture, the line joining the pubic tubercle to the top of the greater trochanter is practically horizontal. The middle of this line overlies the acetabulum and the head of the femur. A line used for clinical purposes is that of Nelaton, which is drawn from the anterior superior iliac spine to the most prominent part of the ischial tuberosity. It crosses the center of the acetabulum and the upper border of the greater trochanter. Another surface marking of clinical importance is Bryant's triangle, which is mapped out thus. A line from the anterior superior iliac spine to the top of the greater trochanter forms the base of the triangle. Its sides are formed respectively by a horizontal line from the anterior superior iliac spine and a vertical line from the top of the greater trochanter. Articulations. The posterior superior iliac spine overlies the center of the sacroiliac articulations. The hip joint may be indicated, as described above, by the center of a horizontal line from the pubic tubercle to the top of the greater trochanter, or, more generally, it is below and slightly lateral to the middle of the inguinal ligament. The knee joint is superficial and requires no surface marking. The level of the ankle joint is that of a transverse line about 1 cm above the level of the tip of the medial malleolus. If the foot be forcibly extended, the head of the talus appears as a rounded prominence on the medial side of the dorsum. Just in front of this prominence, and behind the tuberosity of the navicular, is the talo-navicular joint. The calcaneo-cuboid joint is situated midway between the lateral malleolus and the prominent base of the fifth metatarsal bone. The line indicating it is parallel to that of the talo-navicular joint. The line of the fifth tarso-metatarsal joint is very oblique. It starts from the projection of the base of the fifth metatarsal bone, and if continued would pass through the head of the first metatarsal. The lines of the fourth and third tarso-metatarsal joints are less oblique. The first tarso-metatarsal joint corresponds to a groove which can be felt by making firm pressure on the medial border of the foot 2.5 cm in front of the tuberosity of the navicular bone. The position of the second tarso-metatarsal joint is 1.25 cm behind this. The metatarsophalangeal joints are about 2.5 cm behind the webs of the corresponding toes. Muscles. None of the muscles require any special surface lines to indicate them, but there are 3 intermuscular spaces which occasionally require definition. These are the femoral triangle, the adductor canal, and the popliteal fossa. The femoral triangle is bounded above by the inguinal ligament, laterally by the medial border of sartorius, and medially by the medial border of adductor longus. In the triangle is the fossa ovalis, through which the great saphenous vein dips to join the femoral. The center of this fossa is about 4 centimeters below and lateral to the pubic tubercle. Its vertical diameter measures about 4 centimeters, and its transverse about 1.5 centimeters. The femoral ring is about 1.25 centimeters lateral to the pubic tubercle. The adductor canal occupies the medial part of the middle third of the thigh. It begins at the apex of the femoral triangle and lies deep to the vertical part of the sartorius. The popliteal fossa is bounded, above and medially, by the tendons of semimembranosus and semitendinosus, above and laterally by the tendon of biceps femoris, below and medially by the medial head of gastrocnemius, below and laterally by the lateral head of gastrocnemius and the plantaris. Mucous sheaths. The positions of the mucous sheaths around the tendons about the ankle joints are sufficiently indicated in figures 1241 and 1242. Arteries. The points of emergence of the 3 main arteries on the buttock, that is, the superior and inferior gluteals and the internal pudendal, may be indicated in the following manner. With the femur slightly flexed and rotated inward, a line is drawn from the posterior superior iliac spine to the posterior superior angle of the greater trochanter. The point of emergence of the superior gluteal artery from the upper part of the greater sciatic foramen corresponds to the junction of the upper and middle thirds of this line. A second line is drawn from the posterior superior iliac spine to the outer part of the ischial tuberosity. The junction of its lower with its middle third marks the point of emergence of the inferior gluteal and internal pudendal arteries from the lower part of the greater sciatic foramen. The course of the femoral artery is represented by the upper 2/3 of a line from a point midway between the anterior superior iliac spine and the symphysis pubis to the adductor tubercle, with the thigh abducted and rotated outward. The profunda femoris arises from it about 1 to 5 centimeters below the inguinal ligament. The course of the upper part of the popliteal artery is indicated by a line from the lateral margin of semimembranosus at the junction of the middle and lower thirds of the thigh, obliquely downward to the middle of the popliteal fossa. From this point it runs vertically downward for about 2.5 centimeters, or to the level of a line through the lower part of the tibial tuberosity. The line indicating the anterior tibial artery is drawn from the medial side of the head of the fibula to a point midway between the malleoli. The artery begins about 3 centimeters below the head of the fibula. The dorsalis pedis artery is represented on the dorsum of the foot by a line from the center of the interval between the malleoli to the proximal end of the first intermetatarsal space. The course of the posterior tibial artery can be shown by a line from the end of the popliteal artery, that is, 2.5 centimeters below the center of the popliteal fossa, to midway between the tip of the medial malleolus and the center of the convexity of the heel. Its main branch, the peroneal artery, begins about 7 or 8 centimeters below the level of the knee joint, and follows the line of the fibula to the back of the lateral malleolus. The medial and lateral plantar arteries begin from the end of the posterior tibial. The medial extends to the middle of the plantar surface of the ball of the great toe, the lateral to within a finger's breadth of the tuberosity of the 5th metatarsal bone. From this latter point the plantar arch crosses the foot transversely to the proximal end of the first intermetatarsal space. Veins. The line of the great saphenous vein is from the front of the medial malleolus to the center of the fossa ovalis. The small saphenous vein runs from the back of the lateral malleolus to the center of the popliteal fossa. Nerves. The course of the sciatic nerve can be indicated by a line from a point midway between the outer border of the ischial tuberosity and the posterior superior angle of the greater trochanter to the upper angle of the popliteal fossa. The continuation of this line vertically through the center of the popliteal fossa represents the position of the tibial nerve, while the common peroneal nerve follows the line of the tendon of biceps femoris. The lines for the deep peroneal nerve and the continuation of the tibial nerve correspond respectively to those for the anterior and posterior tibial arteries. This concludes Anatomy of the Human Body by Henry Gray. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org.